Recording in progress.
One, two, 1, 2. Is your mic testing 1, 2.
Recording in progress.
Does your mic test? Testing one, two. Okay. Does your mic test? Testing one, two. One, two. Yeah, yeah. Yeah. Does your mic test? Testing one, two. One, two. Yeah, yeah. One, two. One, two. One, two. Does your mic test? Testing one, two. One, two. Yeah, yeah. Yeah, yeah. One, two. One, two. Yeah, yeah. So mic test. Testing one, two. One, one, two. Yeah, yeah. One, two. Number two. Yeah. Does your mic test? Testing one, two. One, two. Yeah, yeah. One, two. One, two. Yeah, yeah. Does your mic test? Testing one, two. One, two. Yeah, yeah. One, two. One, two. Yeah, yeah. One, two. One, two. I'm sending now to him to the interpretation. I turned up my aux. Um, number two. So, but it's not sending. Okay. 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 We just double check. Okay. Test your mic test. Testing one, two. Yeah. I didn't sing with our mic. Okay. This is your mic test. Testing one, two. One, two. This is your mic test. Testing one, two. Check. Yes. Yes, I can. Can you hear me? This is channel one. Channel one. English. Channel two. Number three. Number three. I can hear. Yes, I can. What channel you on? Which channel? Yes, I can hear you. Okay. Yes, I can hear you. Pues ja, gewoon because the mixer in het KPD, I have to access and summons. Okay. Does your mic test? Testing one, two. One, two. Yeah, yeah. Does yes I can. Yes I can. Does your mic test? Testing one, two. Does your mic test? Testing one, two. Does your mic test? Testing one, two. Can you hear me? Can you hear me? Can you hear me? Can you hear me now? How about now? Can you hear me now? Okay. Okay, no problem, ma'am.
Good morning. Bonjour. Bom dia. And that's the sum total of my Portuguese and French. So can you please take your seats so that we can start? And welcome to Cape Town. Hopefully it won't rain this week. We shifted this meeting. This is our third annual vaccinology course fourth for NITAGs. And it's normally held in July. We shifted it to May so that there's less rain. But the bad news is that the rain's coming on Wednesday. So we have quite a busy week. My name is Gregory Hussey. I'm the founding director of the Vaccines for Africa initiative, which was established 21 years ago. So it's our 21st birthday this year. So we'll have a party tomorrow night. Okay. The niche. Can you people hear from that side? Yeah. Okay. Can you hear me on the left? Can you hear me on the right? All right. And for those of you who don't understand English, please use the headsets because we have both French and Portuguese translation. If you'd like to follow the translation, and it's quite simple to follow. So as I said, my name is Gregory Hussey. I'm the founding director of the Vaccines for Africa initiative, which we started more than 20 years ago. And this annual meeting is hosted by the NITAG Support Hub, NISH, which is a project, our flagship project of the Vaccines for Africa. I'm not going to say much because I don't want to steal Ben Kagina's thunder. Ben Kagina is the person who made this all possible. He is the principal investigator of the NISH project, and he's also the current co-director of the Vaccines for Africa. So Ben is going to officially welcome you and set the scene for the week's proceedings. So Ben, over to you.
Thank you so much, Greg, and good morning, everyone. How are you today? Excellent. Lovely to see some familiar faces and also unfamiliar faces. I hope your travel to Cape Town was smooth. I heard there are some people whose bags got stuck somewhere, but thankfully they arrived on time. Okay, so it is wonderful to see you all and to welcome you to our fourth annual vaccinology course for NITAGs. And this year, it's a big one, okay? We do have 11 countries represented in this year's course. And I think it is the first time that West African Health Organization has partnered with us. They have partnered with us in the past, but not to sponsor NITAGs to come to the AVCN. So Wahoo sponsored NITAGs from Nigeria and Gambia to come, and we thank you, Wahoo, and we hope this is the beginning of partnership that is going to continue. And it is fitting. Anytime I see partners coming to support the work of NITAGs, I say a big thank you, because we do understand the constraints of NITAGs in our setting. So just before I start, I would want to request the niche team, VACPA team, to please stand so that our guests can see who has been behind all the hard work to get you here. So are they all outside? Yes, please call Collie. I just want to introduce you all to our guests. There is a lot of behind the scenes work to make such a big event possible. And I'm actually the spokesperson. Most of the work is done by the team that you see here. Collie, raise your hand. Possibly most of you has received emails from Collie. Also Elizabeth. And then we've got Alana. Most of you have sort of interacted with Alana, if not everybody. And then we've got Greg, who introduced himself earlier here. And then we've got Salim there. And we've got others. And I think in the next presentation, Alana is going to show you who is the team. But if in case you need something related to the local issues, where to go, where not to go, please speak to them. They know all that. Okay. So on behalf of the niche team that I've shown you, on behalf of the University of Cape Town, I welcome you to our vaccinology course for 2025. And also to say that this year we've got new partners that have joined us. We've always partnered with WHO. I've mentioned about Wahoo. Now we also do have Linksbridge. We've been working with them for quite some time now. And it's also wonderful to see Gavi. Amina is here. And Michelle, where's Michelle? She's coming. Okay, so this is a forum where we've got NITAGs and also the partners who support NITAGs. So I expect a lot of interaction so that we can learn from each other, be able to support each other in all what we do. Okay, so just a bit of history. Niche. There is some echo. Better now? Okay. Okay, I'll possibly use this one. Can you hear? Much better. Okay. So just a little bit of context. We came up with the idea that we can have a university-based project to support the work of NITAGs in Africa. Initially, the thinking was that this is going to be done in WHO Afro, and that is where we went to sort of ask and do research, ask information from NITAGs then. That was in 2019 to 2020. And we looked at the literature. We did quite a bit of stakeholder engagement, spoke to NITAGs themselves, and asked them, do you think having a project which we called niche would be useful to support the work of NITAGs? And the answer was overwhelming yes. Then the next, we asked them, what kind of support would you need this kind of project to be giving to NITAGs? And you will hear in the next talk the kind of activities we do to support the work of NITAGs. And one of the things that I would want to highlight from those findings, you're going to hear more, is the issue of modeling and training in vaccinology. So it is from those findings that we actually started vaccinology training in 2022. And this being the fourth year, it is more mature. So you're benefiting from the feedback that we got in 2022, 2023, and 2024. So you're going to and I will highlight some of the improvement we've made since the first year. So after we collected the findings, and we were sponsored by Wellcome Trust to do this. So after we got the findings, we were able to put a proposal together and submit it to Wellcome Trust. And it was funded. And I think it is important to mention at this stage, there was concern as we were engaging with stakeholders, with NITAGs, what is going to be the separation between the work of NISH and the work of WHO that is already doing? And that was very well clarified by indicating that WHO and NISH works as partners. So we closely collaborate with WHO. In fact, those of you who are here, the selection was based on WHO and us working together. So we continue to work together with WHO to support the work of NITAGs in Africa, ensuring that we do not duplicate effort, but we leverage on each other's strength. So the first inaugural vaccinology course was in July 2022. And we had 34 NITAG members from Madagascar, Sierra Leone, Niger, Kenya, and Angola. Importantly, we realized training NITAGs as a group, it's much better than inviting individual NITAGs to come for training. And we actually realized this is a very unique time that NITAGs spend 5 days together as a team. So there's so much benefit because you get to discuss some of the issues that you don't get enough time to be together back in your country to discuss those issues that can be discussed in this meeting. And we've built on that. That's why we've asked each NITAG to nominate a couple of people to come and participate in this training. So you can see CD on this photo, and you can see then the Vice Chancellor of UCT. This is Mark, representative from Wellcome, who is our focal point person. And it was a wonderful, wonderful occasion. And as I said, from 2022 to now, this is the fourth year. It's much more mature vaccinology course and with much more experience. Not only from us, the conveners, but also from the faculty that are involved in delivering lectures to you, because we've explained to them the kind of audience they will be speaking to. So we did send you a PowerPoint template asking you to populate with specific details. And one of the issues we asked you to populate is what are the expectations you have for this course? Some of the NITAGs responded. I've already shared the expectations. And when I looked through, some of the expectations is around vaccine impact assessment, especially following an introduction of new vaccine. Some of you talked about forging partnership and collaborations, not only with NITAGs, but also with partners that are here. And also some of you talked about wanting to learn what are the strategies to improve vaccine confidence. And also there was expectation of being able to know where to access the tools and resources to support the work of NITAGs, and also being aware of which tools and resources exist. And importantly, and this even came out in our scoping review that I mentioned, we did the pilot work to find out whether we should set up niche, the issue of resource mobilization. You see, most NITAGs do not have a dedicated funded secretariat. So it is not surprising that some of the expectation is how do we mobilize resources to make sure that we support the work of NITAGs optimally. So looking at these expectations, I haven't received all of them, but please, if you haven't submitted to us what you expect from this course, it is important because those expectations help us design how we're going to meet them, the program, but also during the discussion, we can structure the discussions in a way that we address some of these issues that are being expected by you. So what do you expect from 2025 AVCN? So we made modification, and I've said this is a much more mature vaccinology course, having been done for 3 years now. So one of the things that we did was we agreed it is good for NITAGs that have done E2L training, evidence to recommendation training, to be prioritized to come for this vaccinology course, so that it is in the context of vaccines, it's boosting of the knowledge that you've gained from the E2R. And what we've done is we've structured the program in a way that it links to the different domains that are contained in the evidence to recommendation process. Also, we got feedback from past participant NITAGs indicating you want more discussion sessions, you want less virtual presentations, and also you want opportunity for NITAGs to share their experiences and learn from each other. So we have structured the program to make sure that there is less virtual presentation, more opportunities for discussions, and during coffee, during lunch, please sit with other NITAGs, get to know them, get to share your experiences with them. But also importantly, we've allocated each NITAG 10 minutes to present and share the experiences with us. So day one, which is today, we're going to cover the vaccinology in the context of NITAGs. We're going to hear about what is the situation in the region in terms of VPDs, vaccine preventable diseases. We're going to hear about where to access different types of evidence to support your work, may it be local, regional, or global evidence. We're also going to hear more about some of the resources and services that partners are providing to NITAGs to support their work. And day two, we're gonna switch on to look at the domain one of E2R, which is the disease a public health problem? We're gonna hear more about epidemiology of different VPDs, looking at how do we measure the public health problem of a specific disease, and learn more about some of the core principles underpinning evidence-based decision-making in the context of epidemiology. Day two, we're also going to talk about adverse event following immunization, benefits and harms. We're also going to hear more about immunological responses following vaccinations. Day three, we're going to transition to very pertinent issues, especially in our continent, the issue of equity and implementation science. How feasible is it to implement a decision after NITAGs make a recommendation? Some of you may be only involved in making a recommendation and say your job is done. But ultimately, as NITAGs, what you want to do is to strengthen immunization program by making sure that your recommendations are evidence-based, timely, and of high quality. But unless those recommendations are optimally implemented, we're not going to have strengthened immunization program. So it is good to understand what happens after NITAGs make a recommendation. We're going to have a panel discussion to speak specifically on that. Then therefore, we're going to talk about resource use. You're going to hear more about modeling health economics in the context of immunization and vaccines decision making. And then the last day, we're going to hear about how health system needs to be factored in when making decisions. We're also going to hear more about how can we be innovative, think outside the box when tackling some of the challenges facing our immunization programs. All right. How do we make the most out of 2025 participation? And when I say how, I'm saying to you and to us, because it's for everybody. Everybody in this room, every time I learn something new, all right? So the first thing is be on time for sessions, right? It is always good to start on time so that we stick to the time. The program is packed, and if we have to cover everything well, we need to make sure that we show up for sessions on time. Please put your phone on silence. I know some of you still have to give some guidance back in your country. Just when, if you put your phone on silence, it means if a call or a message comes, it doesn't interrupt the session. You can walk out and answer your call, but please keep your phone on silence mode. Be silent during the presentations. As I said, one of the benefits for this course is NITAG spent 5 days together. But there's also a counter side to that. I think sometimes you get excited and want to talk more during the session. So please avoid discussions among yourself at the table during the sessions to make sure that we have a silent room to allow for everybody to hear what the presenters are saying. Ask questions and make comment during the question and answer session. This is very important. We do have evidence that NITAGs who ask questions and who make comment actually make the most out of this vaccinology course. In fact, what we've done before is that we have scored NITAGs based on keeping time. And when we say keeping time, is everybody on the table, not one person that counts on behalf of the rest. And also in terms of engagement, the questions you ask, the comment you make. And I think we're going to start scoring, keeping a tab of how many points each NITAG has. And Alana, I suspect we have a gift at the end for the NITAG which scores the highest. We can make a plan, right? And then always ask yourself, because this is very much a course that is designed for application. Just ask yourself when the presenter are here, when the presenter are talking about their areas of expertise, when there is discussion, ask that question: how can I use this knowledge to advance decision making in my country? Because as much as the knowledge increase is one of our focus areas, importantly, we want what you take from this meeting to be able to apply when you go back to your country. And then network with fellow NITAGs. They are brothers and sisters, uncles, aunties. Please, during networking dinner tomorrow, interact. It's very important. Some of the interactions that happens here have continued post the vaccinology course, and they have been crucial in strengthening immunization programs on the continent. Importantly, make connections with the niche team. If you want to know where best to go shopping, not during the sessions though, okay? Or where you can go and get a nice meal outside the hotel. Speak to the niche team, but also more importantly, what services do they offer? What resources does niche have? The last one is the most important part. Please give us feedback, right? The improvement of this course has largely been due to the feedback that we get. When I started, I mentioned that we ask NITAGs, we ask partners whether it is worth establishing niche. So we are very consultative in the way we run this project. And we strongly believe that unless we get feedback, unless we get comment from you, we're not going to know which areas we're going to improve. So give feedback, except on 2 issues that I do not want feedback on. Can you guess which ones are they? Okay, I do not want feedback that we want to come next year. Okay. The other one is I do not want feedback that we need to make it longer. So those 2 are not possible for many reasons, one of them being resource. Okay. But all other comments, suggestions, please feel very welcome. So every day we're going to be doing a feedback that, will be sent, questions will be sent to you, kindly complete that. Were it not for feedback, last year, would still be having this course in July. But NITAG said, no, this is just too cold, too windy, too wet. We listened, and now we're having the course in May. So your feedback matters. All right, with that, I think at the end, we're going to be as happy as this first group and be able to go back to our countries with more knowledge equipped to address our challenges. And finally, to the chairs, please keep time. I know I'm 3 minutes past and I'm speaking even to myself. Let's try to keep time. And if you're interrupted by the chair saying you cannot ask the question, it's not being rude. We're trying to manage time. Thank you so much, Chair.
But Benjamin did start 5 minutes late, so we can accept the fact that he went a bit over time. And just a welcome to those who came in a bit late. Nice to have you here. We're going to move on. You've all seen the agenda for the week. You all have a copy, all right? If there's anything that you think we should be addressing that's not on the agenda, please make a note and give it to one of us, and we will try to address that in some way in the week, either during the discussions or even if it's an email after the conference. So if there are any issues you'd like to raise today or the rest of the week, please let us know, because as Ben said, the idea behind this meeting is not for us to stand here and talk to you, but for us to debate and discuss. All right. We thought it's very useful for us for those who may not be familiar with what the niche project is all about and what we do. So we're going to have a short presentation by Alana Kaiser. Alana Kaiser is the young lady who keeps us on track in the project. She's our project manager. And she will tell you a little bit about what niche is, what we do, and what our aspirations are. So Alana, thanks very much. Over to you.
Thank you, Greg. Good morning, everybody. Let me first say it's very heartwarming to see all the faces, and now we've got the faces to the names, and I'm so happy that you all are here and you arrived safely. And yeah, I hope you all have a very insightful week with us. So I just want to tell you a bit about Niche and what we do at Niche. So just by show of hands, who knew about Niche before your invitation? You got your invitation to join us this week. Did anyone know about the NITAG support hub based in Cape Town? Nope. South Africa? Just a few. Do everybody know who Niche is as you are sitting here now? I hope so. So we are Niche. So we are the NITAG support hub, and we are basically here to be of service to the NITAGs on the African continent. So Niche is a formal academic initiative, I would say, And it supports night tags across all the 40, or how many ever, sorry, I don't think 47 is accurate anymore, countries in the WHO Africa region, including recently the EMRO countries as well. So we provide training through, sorry, we provide support to the NITAGs through three core pillars. And these are training of the NITAGs, scientific support, and research. And we also facilitate regional knowledge exchange and collaboration organically through these type of events. And we are working close collaboration with WHO, and we are funded by the Welcome since I think 2020. So who is Niche? Niche, as I said, is the NITEC support hub, and we are hosted by VACVA, which is a unit within the University of Cape Town's Health Sciences faculty. And as I said, we are supported by our funding. We are funded by Welcome, and we work in close collaboration with the WHO. And our vision is an Africa free of vaccine preventable disease. So this is our team. And I've deliberately omitted the names, and I want to challenge you to tell me by the end of this week how many names. We're going to put this up again, and we'll see which country can come up with the most names. So this is mostly the UCT delegation of our team. There are two of my colleagues that unfortunately you don't see their faces on here, but they are they will be here. They are here, and I hope for you to find Naina Manga and Tony Hawkridge. And then we also have quite a group of consultants that we consult with, who, of course, we are catering. As you can see, we are a very small group. And so we sometimes make use of external experts to help us with our training programs. And then, of course, we have got various partners, our main partner being the WHO, but there is various other ones that we work closely with. And we recently have also started working with Wahoo, Gavi, and Linksbridge. So our partnerships are expanding, and we are also always looking for new partners to join our initiative. So why does Niche exist? So as I've said, our vision at VACVA is an Africa free of vaccine preventable diseases. And we can appreciate the importance of NITAGs in that vision. So, and we realize that we can do this in collaboration with the NITAGs to strengthen the evidence-based, evidence-informed decision making in immunization by working with the NITAGs, by supporting the development of strong and sustainable NITAGs. And we also want to ensure that the NITAGs are able to give informed national immunization decision making on policies, and are guided by their own local and global evidence. So together, this effort, we believe, will contribute to an equitable and effective immunization program across the African continent. So how does niche work? How do we support capacity building for the NITAGs? So we do it through direct engagement with the NITAGs, similar to what we are doing today. We have our vaccinology training courses, in-person courses, which we have today. Then we also have a research stay program, which I think you all heard of, which is happening, hopefully happening next week. And then through that, we are also, through these initiatives, we are able to connect the NITAGs to experts and networks across the continent. We also facilitate webinars and workshops. We've got a workshop scheduled this Saturday. And this also allows for peer exchange amongst our participants. Further, we also support the use of evidence tools for policies. You will hear more about our library guides that we put together on request from my colleague later. And through these, we've actually organically, it has now happened that we see more co-development between us and NITAGs to develop strategies to address country-specific needs. So we've got, for instance, an MCV study looking at the hexavalent to pentavalent, the 10-dose, the 10-dose switch to a 5-dose switch in various countries. So it's something that is now, we didn't foresee it happening, but it is working very well. And we also have a TB study similarly co-developed with various countries across Africa that has now also been funded and will start in due course. So as I've said, the capacity development for NITAGs, we are in the game of training NITAGs, and we do it on the in-person platform, such as the annual vaccinology course that we are doing here today. Then there are also on request through WHO, ETR and vaccinology training, where our team actually flies out to the specific country, and we either do a country-specific training, or it's a collection of other countries that meet up in a location other than Cape Town. And I'll speak more about those. We've done various of those. And then also, of course, the research day is another in-person training course that we offer. Then we do online training as well. You were exposed to our online courses, which is very new. It was launched this year. I'll speak more on that later. We also offer webinars once a term or once a quarter, and this is guided by a very relevant topic at the time, and I'll speak a little bit more on that as well. And then obviously there's a lot of resources available on our niche website. You will find the recording of this course. You will find on the niche website. You will have the library guides that you will hear about on the niche website. You can access the courses. If you haven't finished them, you will have opportunity. You can access the courses via the niche. Somebody smiling brightly at me. You can access the courses through the niche website. The webinars are recorded for future use. So there's a plethora of information available on the niche website. And please, you'll see the QR code coming up every so often, please scan it, have a look and see what is there. And also, I'll put up the website link at the end, the address. Okay, so then just back to our capacity development, the AVCN, just a few numbers for interest. So this is our 4th edition of AVCN. We had our first one in 2022. So at the moment, so with each course, we have access to about 30 or more faculty members that will do presentations and share their expertise. To date, including this cohort, we have trained 187 NITAG members, and that equate from about 30 countries. And 16 of those countries are Anglophone, 11 Francophone, and 3 Lusophone. So we don't see the language as a barrier. Through our interpretation services, we could bring all these countries together here today. We also offer AI interpretation during our webinars. So it's open to everybody. And just to say that normally we have 5, I think in the past we had 5 to 7 countries at this conference. This is the first year that we hit the 10 mark, and it's the first time that we've hit 11 countries. And we'll see how the week goes and your experience of what we would perceive as a large cohort, what your experience is of this number in this room. Then we have the E2R and vaccinology training, which is normally requested, a request that is put towards WHO. This usually also comes straight from the NITAGs or through our partners to WHO. So we work very closely with them. And as I said, we've done 14 locations so far across the continent, and those have also covered 35 countries already. So it's quite a useful tool, and it's easy to mobilize. And so if you feel, and I think most of these countries here have been through those that training. Then the niche WHO webinars. As I said, we do this once a term. We've done 12 webinars so far. We are planning to have another one in June. Through this engagement now, we've had 72 countries, translating into 864 participants, and about half of those were NITAG members. So this is a very powerful tool to access a lot of people across the continent, but not just on the African continent. We also have managed in the last few webinars to bring in countries from the Middle East, as well as the US, Europe, Asia, and also Australia. So those are the in-person training platforms that we make use of. Then we also have the new online courses, which came live in March of this year. We offer 4 modules, and I think you are very familiar now with those 4 modules. And I hope it was a very useful pre-course to this course. And we'll hear your feedback on that during your presentations during the week. Um, I've heard inside info that we will be loading a fifth module, hopefully soon. So you can keep your eye out for that one. So for this period that it's been launched, we've so far had 252 registrants, which is quite fantastic for us. Because it's a different and a new platform that we are using. And we're looking forward for those numbers to increase, as I'm sure not everybody has been able to get through the pre-course yet in this room. And then access to evidence is another area that we want to provide that service to NITAGs. And this basically involves our library guides. And we've already on our website, you will see you've got access to 13 library guides. In the last month or so, we've loaded 6 new library guides, those covering MCV, Hep B, birth dose. We did a very urgent one last year for Mpox. So all of those are on our website and it will remain there. So you can access it at any time. But I will leave Dilshad to speak more on that. But also to say that to date we had, through that platform, we had 313 interactions just for this year. So please have a look at what is there. We also recently added one that was a request from Lesotho, and they were interested in the MMR vaccine. So we could, that request came in the beginning of the year, and we could provide that to them. I think it was in April. So how do you access the niche support and engage with us? On our website, you will find a help desk through which you could either request the development of a library guide. You can request vaccinology training through that help desk. And all you need is just to access if there's any evidence questions you want to get access to. That is the place where you can go. And as I said, on the website itself is a fantastic resource with everything that is being archived on there. We are also adding new documents on there that might be of interest to your NITAG. Our recent addition is the theory of change. We also, if you want to know what we've been up to for a period since we've last seen each other, but I hope we're not going to go quiet after this week. I hope we still see each other after this week. But if you want to know what we are up to, we have a newsletter that is also posted on there annually. Otherwise, you can follow us on our niche LinkedIn pages or on Twitter X. We also, VACVA is also available on LinkedIn and on Twitter, so you can follow us on those platforms as well. So just to say thank you, everybody. And I hope you're going to have a fantastic week. I have to confess something here. It was clearly time for the Gremlins to take me on, and I hope I'm the only one they're going to take on. This is not my last edition of my presentation, hence there is no QR code. But I hope Sir Lim can put that up for you to scan the the access to the niche website. So sorry about that, but I just, as I was standing here, I just realized that this is unfortunately not my last edition of this. But yeah, thank you, everybody. That's it from me.
So thanks, Alana. Alana's tried. No, don't go away. Alana's tried to explain to you what we're all about and what our activities are all about, and our partnerships with various agencies, including WHO Afro, who is our main partner. So we will be talking more about some of these issues as we move through the next 5 days. But are there any burning questions or general comments? We have a few minutes left for discussion before we move on to a very important part of the program, which will be the NITAGs introducing themselves, which we'll start in a few minutes. Any comments or questions? How's the interpretation going from our French colleagues? Is it good? It's okay? Portuguese? Okay, all right. English? Okay, that's good. You have a question or comment? Sure, go ahead. Let me give you a mic, please. Hang on. Is this on? Here we are.
I just wanted to know if you'll be reviewing the presentation of the modules online, because I did have a little bit of difficulty with the flow. Sometimes. So I was just wondering if you've had feedback from other people as to how easy it was to access the modules. Thank you.
I hope that. Sorry. So we will look, as I was just saying, we haven't had any feedback through the platform yet. As I also said, you are the first cohort that we are we've exposed to the online courses. But we are looking back, we are looking forward to that feedback so that we can improve on it. So please do give even if your feedback is not complete on your presentation, if you have submitted it, please just insert it and say resend us your presentation. It is important for us to move forward on.
So that's a good comment you're making. So tomorrow I'll be talking about epidemiology, and Ben will be talking about immunology, and we can pick up on some of those issues. I'm not going to do the whole lecture because it's there on the website, but we'll complement the lecture with some additional information. But please provide some comments. First, I'm not sure who was first.
Thank you. Thank you very much. Amazing communication. I just want to ask if the online courses is free.
They are free. Sorry, we saw that was a bit confusing to everyone. The platform that we are using is housed within UCT, and they have certain modules from other departments that are not for free, but our modules are offered for free. You'll see there was no charge, 0 rand.
Okay, from Nigeria.
Thank
Please,
you.
as a matter of interest, when you make your comment or question, just say your name, please, if you don't mind.
Okay, thank you. Good morning, everyone, and apologies for coming late. My name is Muhammad Mashin from Nigeria. The first is feedback for the online course. The suggestion is to add a downloadable document so that those who are not able to study online can read the document and come back online and do the quiz. The second question or clarification is that in your early slides, the niche is funded by Welcome till 2026, which is just next year. So what happens after 2026? The next clarification is NITAG members has been trained from 30 countries, and niche is supporting about 47 countries. what would have been the status of the NITAG recommendation from other countries that have not been trained. And last but not the least, University of Cape Town, we just want to ask for clarification. Are there other universities from these 47 countries that are in collaboration? Thank you and over.
If I can field some of those answers, and Ben will probably jump in. But the co-development part of how we work has now started to engage universities from other countries, and it's still in its infancy. But I will leave Ben to just speak on that and our plans for niche beyond 2026. Ben, can you?
Thank you for the question. There are many questions, so I will try to address those that I remember. So the first one is the 47 countries. I think that is a bit of an error. We do give support to all African countries. Is that correct, Alana?
Yes, unfortunately, that was what in my last edition of the presentation. Sorry.
Yes. So I mean, we do support all WHO Afro countries, which are about 47, 48. And from the EMRO region, African countries, I mean, we do have Tunisia and Morocco, who are in Africa, but EMRO region. So we do support all African countries. And it's a young project. It's been running for 4 years. So in fact, when we started, the intent was to be training about 5 countries every year. But now we've exceeded that. So that's why we've been able to train 30 countries in 4 years. And the intent is before the project ends, at least we've trained almost all African countries. In terms of when the funding ends, that is $1 million question, as they say. And I'm seeing CD smiling here because it's been in our minds for quite some time. So part of the things that we try to do is to advocate for resource mobilization. We do have partners here, and Wahoo is coming into the party. And the more partners are aware about the work of NITAGs, the more impact we can show from the support we are giving NITAGs, the easier it will be to mobilize resources. So part of our sustainability plan is to relook at how we can adapt to the changing needs of NITAGs and also work with partners who are interested in supporting NITAGs. So we do not have confirmed funding post-2026, but there are active plans. And Tony, who is seated here next to me, we've tasked him to find out how are we going to do it. Is that correct, Tony?
And hopefully Trump will be out by 2026, so that we can move smoothly ahead with development activities.
Yes.
But the important point, what's missing? What's missing about when we're talking about support for NITAGs? What are our country responsibilities in terms of supporting NITAGs and the work we do as a collective in Africa? And I think that's something that we need to think about very carefully. We're always thinking about who is going to fund this or that or that. What about our responsibility as a country? So we'll pick it up. That's a good point that you're raising early on in the week, and that will be picked up later on in the week. Have we answered all your questions?
One last one, Greg, is the universities.
Oh, the university, sure. Okay.
So that is a very, very important question. And we do have, people we work around the continent. Of course, we cannot do all the work from Cape Town. So for example, we've got a posse from Cameroon who is here with us. She works with us. And we've got recently Jason here, who is based in Kenya, that also work with us. And the intent is to have collaboration with people based all over the continent so that we can be able to give the support to the vast continent that we have. But equally important, and this ties to what Greg has said, we do have a project, and you'll hear about it. It's MCV Switch Project, which is looking at how NITAGs can be supported in switching from 10-dose vial to 5-dose vial. But part of that work involves looking at how NITAGs can work better with the local academia in their setting. And that is very important because it also fosters country ownership, making sure that we optimize and leverage the resources we have in our countries. But partnership and collaboration with other universities, we're very open for that. Thank you.
There was a question from South Africa.
Yes, thank you very much, and good morning, everyone. I'm Smangele Mtetwa from South Africa. My question is around the support to say, are there specific persons for countries or regions, or it's just if there's any question that we may have and needing support on, we just write to Alana, just to be clear on who is there anyone that is directed for specific areas?
So we do accept from any region across the continent to contact us either through the help desk. So those are all coming to us, and our team will give feedback and guidance on how we're going to approach your request. Ben, is there something you want to add to that?
Just to say that you don't submit it to Alana directly because Alana may be on leave. And so you submit through help desk, which you can access it on our website. And once you submit your request, it goes to CD, who is the NITAG WHO Afro focal point person, and it comes to us. And that helps because CD may have some magic solution to your request instead of us, because he's overseeing many countries also. So that coordinations help us in how we respond to your requests. And then the other one is if you reach also to CD directly, CD says, okay, I'm not able to do this because I'm under-resourced, you reach out to us.
If
Yes.
just press the button.
OK. Merci beaucoup. Oui, je suis Dr. Yves Mongo de l'Organisation ouest-africaine de la santé. Pour ceux qui ne connaissent pas, c'est l'institution santé pour la CEDEAO. Donc, qui couvre initialement les 15 pays, maintenant 12 pays. Je voudrais remercier Alana pour sa présentation. Je vois qu'avec l'équipe de Ben, en 4 ans, ils ont eu à faire beaucoup de choses, beaucoup de progrès. Et c'est vraiment intéressant. Je n'ai pas vu quelque chose dans la présentation. Je voudrais poser une question avec et faire un partage d'expérience. La question, dans le fonctionnement, dans le dispositif de niche, il y avait un board. Dans la présentation, je n'ai plus vu parler du board de niche pour son fonctionnement. Le board n'existe plus ou bien existe toujours? Si ça existe, c'est bon d'en parler. Alors, pour le partage d'expérience, c'est justement pour le financement durable. Pour ceux qui sont un peu anciens avec les GTCV, il y a le projet qu'on appelle CIVAC. Et c'est bon aussi de rappeler cela, CIVAC, qui avait été financé, qui a fonctionné de 2011 à 2017. Mais dès qu'ils sont arrivés, ils ont compris qu'après eux, il faut que l'expérience continue. Et ils ont très rapidement pris attache avec l'OAS, l'Organisation ouest-africaine de la santé, pour pouvoir, puisque nous, on est une institution gouvernementale, pour pouvoir continuer à assurer le financement et le travail avec les GTCV quand le projet serait terminé. Ça fait une possibilité. Deuxième possibilité aussi, c'est par rapport aux directeurs du PEV qui sont ici. Nous avons mis beaucoup de temps à expliquer aux directeurs du PEV qu'au niveau du financement de Gavi, il y a la fenêtre renforcement des systèmes de santé. Et ils peuvent trouver des ressources là-bas pour pouvoir poursuivre et renforcer le fonctionnement des GTCV. Voilà le partage d'expérience que je voulais dire. Merci beaucoup.
Thanks, Eve, for those comments. So the issue of sustainability is a big issue. It's about sustainability of support. It's about sustainability of programs, et cetera, and we don't have time to talk about that now, but we will definitely pick it up in the week. There'll be some presentations on sustainability of immunization programs, and in the context of that, we can also talk about the issue around sustainability of capacity development. Ben, do you want to just make a quick comment about the board?
Yeah, so we do have, if it's a good point, Alana's presentation focused mainly on the core services, not on the governance. But in terms of governance, we do have a management board that has representative from WHO, UNICEF. In fact, we need to replace UNICEF because the UNICEF representative has left. We do have a civil society rep. We do have a representative from the University of Cape Town, and NITAGs, French speaking, Lusophone speaking, and also English speaking NITAG. So we do have a functional management board. And actually our next meeting for the board is in the next 3 weeks. Okay.
All right. Thanks, Alana, for that input. We need to move on. And as Ben indicated earlier on, we will be hearing from each individual NITAG. And Adina Amamposa da Costa, who is a member of the NISH team. And she's got quite a range of expertise, and I'm not going to talk about her CV because we'll be here for the rest of the day. So Adina is going to facilitate the discussions around the individual NITAGs. And Adina, over to you to manage the process. Thanks.
Good morning. Oh, it's very quiet. Good morning. Bonjour. Bom dia. I am very pleased to be joining all of you this morning. Alana mentioned that it's important for you to get to know the niche members. And as Greg mentioned, I work for niche. I work for VACFA. In fact, I've been with VACFA for 8 years. And I just realized that Greg said my surname wrong. So I'm going to have to say my name again, Greg. Greg, we're going to have to learn my surname. So I'm Adina Amponsa da Costa. And my job this morning is very easy. We need to get to know each other as NITAGs. We need to know the work we do, the differences between our capacities, and how we can better support each other. And this is a very important component. And we hope that it would be very engaging, that you will give the NITAG that's coming up enough attention and also ask some questions. So I'll kindly ask you to please power down your phones, put down your laptops, and please give attention to the next NITAG that is coming up. I'm not saying the laptop's going down. Please, full attention. So it's my pleasure to introduce the South African NITAG, who will be presenting to us for the next 10 minutes. And after that, we'll have some time for questions. So Haneli is coming up and her presentation is up. And to allow for engagement, I think I'll also encourage that we have some questions, and I'll take the first 3 questions from Cabo Verde. So please prepare your question. The next one from Mauritius, please prepare a question for South Africa. And the next one from Tunisia. And if we have some more time, we'll also take questions from the rest of the floor. Over to you, Haneli.
Thank you very much, Edina, and good morning to everybody. I'm also very pleased and excited to be here. And I think we're going to learn a lot from one another in the next couple of days. So I'm going to tell you more about South Africa's NITAG, and the rest of the team is sitting over there, so I'll call upon them to answer all the questions. But as you can see there, so our NITAG is called the National Advisory Group on Immunization. So we are known as NAGI in the country. It was established in 1993, and at the moment we are 14 members within the NITAC. So in the last 6 months, no new members joined. So the latest new members joined in the beginning, during last year. And the number of members who's been trained in evidence to recommendation is one person formal training, and then two informal training through VACFA. So yeah, in the interest of time, I won't be able to speak about everything that you're going to see on these slides, but I assume the slides will be shared with everybody. So what happened last year in terms of our recommendations, maybe I could just mention at the end of 2023, which is why it's not on here, we actually made a recommendation to introduce the HPV 1 dose, but it happened like in December. So, and then last year, as you can see, it was mainly about Mpox, recommendations for the vaccination, also recommendations for COVID-19 vaccines, although we don't have any in the country at this point in time. Then recommendations to prioritize the acquisition of the Mpox vaccines. And then lately, towards the end of last year, the Mpox deployment plan, bearing in mind limited doses. So for this year, we've already made 2 recommendations. The first one was on the RSV vaccine to be provided during pregnancy. And then the other one was the issue around catch-up doses of the measles rubella containing vaccine in children 9 years of age. We've got an integrated school health program for 9 years after introduction. So we only introduced rubella at the end of time is flying, I think 2023, basically more, I would say, from last year. So that's why this recommendation was there. Then for this year, as you can see, there's a lot of work on the table for this committee. And then we also have working groups within the committee. So the working groups are made up of committee members, for example, members and a chairperson, but then we also pull in other experts in the country for the working group specifically. So there are 2 questions for HPV, looking at the quadrivalent or the non-valent vaccine within the program. And then the second one is a single dose HPV vaccine, the question around whether it is adequate for people living with HIV. Then there are 2 questions for RSV. The one is a recommendation on long-acting monoclonal antibodies. And then the other one is for vaccination of RSV in the elderly. So you'll see that, there's some questions around elderly and adult patients coming up now more frequently within our NAGI. Then there's one on rubella, recommendations for a seroprevalence study. Then in terms of polio, recommendations for a long-term polio vaccination strategy, including surveillance. For PCV, the introduction again of an adult schedule, like I just mentioned. Hepatitis B, to put together a priority list of an adult schedule. And then rotavirus, which is just kicked off as, what is the best clinical product within the South African context of all commercially available rotavirus vaccines. And then the last one is to provide recommendations for a wholesale pertussis vaccine. Then there are questions already sort of on the table for 2026. They might start this year, but at this point in time, they're up there for 2026. The first one is on TB vaccines, recommendations for that. Then there's, again, the HPV, the inclusion of boys in the HPV program, because at the moment, we do not have boys included in the program for resource reasons, I would say mainly. Then again for RSV vaccines, also for further, recommendations for the elderly. For measles, recommendations for the measles vaccine schedule, to look at the schedule again. And then there will also be some questions more around adult vaccines in terms of maternal vaccines, bearing in mind that we are looking now at RSV, and then also specifically, for healthcare workers. Then there's also hepatitis A on the table, and then lastly, the varicella zoster vaccine, to provide recommendations around that, specifically for the immunization program. Okay, I see I now have only 4 minutes left, so I don't want to be the reason why our team will lose some points. So in terms of our strengths and weaknesses, so we have quite a number of strengths. As you can see there, we've got a lot of technical expertise within the committee. We have institutional credibility because we are established under the National Department of Health, with the authority to guide recommendations as we make recommendations to the Minister of Health through the channels. We do have experience in evidence to recommendation process. Like I mentioned before, we are very well aligned in terms of global recommendations with WHO. We have members serving on SAGE, GVAP, and so forth. Also the GACs. Then we have a good track record. An example is, the leadership during the COVID-19 pandemic. We are able to influence policy. Like I said, we have a good relationship with the National Department of Health. They are represented on the committee as well. And the implementation of the recommendations are monitored. Then, in terms of weaknesses, I think something that we all have as a challenge is the human resource gaps. So there are some long-standing vacant posts within our EPI program. And there's obviously limited dedicated funding from the National Department of Health, limiting the implementation of some action points by NAGI. So that is a weakness. The other one is our secretariat. So it is not funded by the National Department of Health or the Ministry of Health. So that is definitely a weakness. And then our capacity in terms of evidence to recommendation, as I mentioned, we actually only have one formally trained person. So we need more skills on that, which is also some of our expectations that I'm going to mention. Then some opportunities. We now have a NAGI webpage, so it's an opportunity to make people more aware. Also to create a repository where information and documentation is available to NAGI members as well as to the Secretariat. And then the technical support, as you've all heard now from Nish, I'm not going to talk about that now. And then regional collaboration. So NAGI is, prepared to, twin with our neighboring countries, allow them to attend our meetings, to build capacity across the continent. Then we also have some threats. So is historical memory, loss of historical memory, specifically because in terms of the Secretariat, because our Secretariat's not funded by the Department of Health, so you rely on external funding and then you lose that memory. And then the whole issue of growing vaccine hesitancy in the country, I would say due to the COVID-19 pandemic, with a huge increase in the rise of zero-dose children in the country. And then lastly, this whole issue around funding, being very volatile. So this is just actually for information, just to show in terms of our opportunities. We have been assessed in terms of the maturity, the NITAC maturity assessment. And you can see there are some red dots, but there are already some green dots and some yellow dots. So we are making progress in using these opportunities. And then lastly, our expectations for this program. Thank you. I'll be done within a minute. So our expectations for this, the course, Ben has actually mentioned some of them already. And some of them you've seen on the opportunities slide. I can maybe just add, together with this whole issue of vaccine hesitancy, the role of public health and social sciences in NITACs and how we can actually use that. And then the whole issue around modeling. You have the modeling, you have the cost effectiveness studies, but how do you actually implement this? And then we are going to still do the coursework over the course of the week. Thank you.
Thank you so much, Hanali, for that comprehensive presentation, and congratulations to Nagi for all the excellent work you've been doing under some very difficult situations. So we have 5 minutes for questions. And as I mentioned, I wanted to start with a question from Tunisia. Tunisia, do you have a question for the South African NITAG?
Yes.
Thank you very much, ma'am, for this presentation, for this interesting presentation. And my question is to know what is the relationship between the NITAG and the Ministry of Health in South Africa, especially in the side of the financing and the organization of the activities of the NITAG, please.
Okay. I'll also call on my colleagues there from the Department of Health to answer. I would say it's a good relationship, apart from the fact that because of resource constraint, for example, the Secretariat is not being funded. So you do get, and I mean, we're all aware of what's happening globally now in terms of funding. So it's very difficult. One day you will have a Secretariat and the next day you won't have a Secretariat. So that is a problem, but it's not because they don't want to. It's because of these funding issues. I don't know if the colleagues would like to add, but further than that, the National Department of Health, the EPI, is part of the NITAG. They attend meetings, they organize the meetings. And then something that I didn't mention is we also have various ministerial advisory committees in the country. So there's one on vaccine safety, and then there's one on the essential medicines list. And we now have representation from both of those committees also on our NITAG. So, to have that, collaborative working relationship.
Did you have your own budget?
Pardon?
Did you have your own budget?
Oh, budget. I'll call upon, we've got the EPI manager there. Thanks, Elizabeth.
Thank you very much. I'm Elizabeth Massetti, EPI Manager, South Africa. NAGI, which is NITAG, is part of the EPI ministerial committees. We are part of the full secretariat, but I think as Prof. Haneli has mentioned, the capacity because of vacancy rate within the subdirectorates. So other functions that we need to provide as secretariat to our committees are lagging behind, but we do have a support from partner to support all our ministerial committees. And with regard to the budget, all NITAG, together with other ministerial committees, we do fund their meetings, and they do have some stipend that they are having on attending the physical meetings, but we don't have a dedicated person within the program that is a person who will be employed, who has been employed to support NAGI. But the EPI is a secretariat, full secretariat to NAGI at the moment. Thank you.
Thank you very much for that. So the second question can come from Mauritius. Mauritius, you have a question for South Africa?
Thank you for the great presentation, of course. Just like to ask, you have made a lot of recommendations, and we all know that some countries, in all countries, we have funding issues. With so many recommendations, I'm just asking whether it's a bit like we should have limited number of recommendations so that the government can make some decisions. I'm just asking. Sometimes like 10 can be too much for the government to take a decision. And the second question would be, what's your strategy you use for the dropouts of measles and the surveillance that you've proposed in the recommendation? Thank you.
So with regards to the recommendations, yes, there are many recommendations, but there are many questions at the moment. So, there might not be actual recommendations coming forth already this year, for example. But, as we move forward, and yes, indeed, use RSV as an example. So the recommendation is now on the table, but now it is to identify the budget, and the resources to run with the program. I didn't hear your question on measles properly. Sorry.
I've seen something about in your recommendation about the measles dropouts and the strategy. What you were proposing on the measles dropouts.
Oh, so the measles is about the last recommendation that we made is to use the measles rubella in the catch-up program for 9 years so that we can catch up on all the children, because we've only introduced the combination of measles rubella last year or end of 2023. So we never had rubella. So it's because of that we are having that recommendation. Anyone else? Wasila?
Okay, maybe just to clarify, as Prof has said, we did not, when you introduce a new vaccine, generally you should do a campaign to reach all of the children, but then that's not the route we took. We've introduced it in the normal age group that needs to get the vaccine, but then we'll be catching up the children within the school program than to have a countrywide campaign for the introduction.
There was an
It's just
for the
started.
challenges. Yeah.
It's just started.
Okay,
Yeah.
great. Thank you. Thank you.
Hello, I am from Mauritius, Mr. Badu. I found in your presentation for the threats, concerning the threats, you have identified the hesitancy. And I want to know how you address that issue. And we all work towards evidence to recommendation, but how we are here to learn from you, from your experience.
So at the moment, maybe the team over there can also add, at the moment, we don't have a working group specifically to work on vaccine hesitancy. But it is something that is now very well recognized within our NITAG. From the EPI side, I would say, and it's actually a sort of a collaborative effort through the country. Whenever we are doing something, say for instance, it's HPV week or month or whatever, then we all try and do some, advocacy in terms of that. But yes, I think it's something that we need to think of, is to have a specific working group for vaccine hesitancy. So I would be very interested to hear if there's anything like that in some of the other countries, because we after COVID, you investigate whether this is happening or that, and what's happening with the coverage and so on. But we now have recognized that definitely there's a huge problem with vaccine hesitancy. I don't know if the team would like to add anything to this.
Edina, there's presentation on vaccine hesitancy, I think tomorrow or the next day, Wednesday. So we could reserve some of the conversation around that issue for Wednesday, just in terms of time.
Absolutely, absolutely. I do like that the question was raised for Haneli, because you might not know, but among our circles, Haneli is known as the queen of vaccine hesitancy. So I like that it came to her. And because South Africa has homegrown advantage, we do have 3 extra minutes for South Africa. So I will take another question from Cabo Verde.
Good morning. I'm Edith Santos from the NITAG in Cape Verde. You know, I would like to ask what are the recommendations you can give us because we are just starting from this year. So we would like to have your recommendation for a starting group. What we could do best, not to repeat the same problems. Thank you.
Okay, that's a very good, a very difficult question. A good question, but a very difficult question. So, I mean, I haven't been part of NAGI actually from the beginning. I think Greg was. I don't know, but I know Greg has been around for a long time, and he was a chairperson of NAGI, if I'm not mistaken. But I think to start with, you are in the right place now. Yeah, where you are. So, I mean, these committees, they do start small, and I think it's important to identify the right key people and then start small. And I mean, Rome wasn't built in one day. So, yeah, I don't know if anyone else would like to add to this, but that, you know, to build capacity with those around you, and I think to have a very, very good working relationship with your National Department of Health, because you need to advise them and you need to have that very good. And that's something that we have in South Africa that is very strong, as well as our regulatory authority. So all of these people work very well together.
If I may just make a comment, um, uh, I'm one of the founding members of the South African NITAG, and I broke all the rules. I spent 20 years on the NITAG. But I think, and it relates to a question raised earlier on, the South African NITAG has done a lot of good work because of its good relationship with the Department of Health and the EPI program specifically. But further to that, we've always had good relationship with academic institutions, all right? So we're talking about the University of Cape Town, University of Witwatersrand, University of KZN, et cetera, because many members of the NITAG, which will apply to you as well, are members of an academic environment. So it's about utilizing those resources within the country to maximize the benefit of the roles and responsibilities of the NITAGs.
Yeah, thank you. Sorry, if I can just quickly add to what Greg has said. That's a very good comment that he made, because when you have people from academia on your committee, you get that commitment. So if I can compare it, say, to private practice, when you need to get people, you need to have people from private practice representative, but it's more difficult for them to go away from their practice to do the work of NAGI. Well, academics, that's part of their work, you know, gathering the evidence, working with the evidence, and so on. So it's really a very, very important issue. Yeah.
Thank you, Haneli, and thank you, Greg. I think that is some very sound advice for some of the NITAGs that are starting up, but I think also even for some of the established NITAGs, because there are always many challenges. So a round of applause to Haneli and the rest of the South African NITAG team. I took some very key lessons from the South African NITAG's presentation. For one, I appreciate their life course focus. And it seems like there is some motivation to take a proactive approach, not just wait for MOH to say, this is your policy question. So it was nice to see that broad range, the foresight for 2025 and for 2026. So I will stop here so that we can take a break for tea. Please enjoy tea. Take some time to get to know the rest of the team. And we will be back at exactly, can I get time? At 10:30 exactly, please. Thank you very much, and a round of applause for you for getting through the first session.
It's working?
Yeah.
Click. That's all.
Would you like to take your seats, everybody? Maybe to give those who are still topping up their caffeine levels a shout there. Would you like to return to your seats? There were quite a lot of people sitting on the seats by the door in the previous session, and the idea is that you sit with your country delegation. So if anyone who was sitting there would like to join their table, this is a good time to do it. Okay, it's bang on past. We're going to make a start. Would somebody like to close the doors? Thanks. So we've got, it's now 10:30, and we've got until 12:45, and then you get released for lunch. So that's quite a long session. That's the bad news, but the good news is we've got some really good presentations to keep you occupied. My name is Tony Hawkridge, and you saw it earlier. I was marked down as an EIDM specialist. I'm not really. I sometimes pretend to be, but I'm a public health medicine specialist who's done a bit of work around vaccines. So welcome back. If you'd like to sit and maybe stop talking. Thank you. Right. We've got 4 presentations. The first is by Dilshad Bray, and she's a member of the NISH and VACFA team at UCT, and she fills a very, very important role. She's not the CEO, she's not the professor, she's the librarian. And I have come to appreciate, I think in the last couple of months when I've been working with NISH, the importance of library science in this whole process of getting evidence base for the decisions that we make. So Dilshad's going to talk to us about development and uses of NISH library guides. Welcome, Dilshad.
So thank you, Tony. Good morning and assalamu alaikum to everyone. As Alana said earlier, it's great to put faces to the names. And I want to say a special shout out to Mori Tag there in the corner, who hosted us so graciously in January. Thank you. So, Alana also in her presentation alluded to the library guides. So that's what my presentation is about, the development and use of niche lib guides. Okay, so I'll be covering, so what are these library guides? How they are developed, and lib guides and night tags, how they can be potentially of benefit to you. And then we'll have a look at select features of these guides. And then I've got some exciting news to share with you regarding a future development. Okay, so where are you going to find these library guides? So this is the niche website, okay? And that's the address. And because we will be sharing the slides, so you will just be able to click on the link. Okay. So where do you find these library guides? So from the Assets and Resources tab, if you click on there, we've got some of our other resources listed here, but you click on LibGuides General Introduction, and there are currently 14, okay, and they're all listed here. And you can see several of them are very topical, okay, and you can actually and have a look at them in your own time. So what are these LibGuides? Okay, they are organized, curated collections of reliable and authoritative resources. You can also call them a database or a repository. Okay, and they are related to a particular topic or subject. And of course, in our case, they deal with a specific vaccine or immunization related topic. And what do they include? They primarily include published scholarly peer-reviewed journal articles, suggested lists of books. They can also include images and videos, and gray, which is unpublished literature. Okay. Then they update it regularly because that's what, which is so important. Then full text access, you have full text access to open source material, and where possible, non-open access articles are made available on request. So how are these LibGuides developed? So NISH's development of LibGuides for evidence-informed decision-making is unique. Okay? The topics are informed by involvement of vaccine preventable diseases, for example, Mpox. Then we also receive requests from NITAGs. For example, the Lesotho NITAG requested for a LibGuide on mumps. Then WHO also requested several LibGuides, and one of them is hepatitis B birth dose. Then the measles-containing vaccine, the MCV presentation switches LibGuide. There was a perceived need because MCV switches are now happening in a few countries, and there's an expectation that other countries will also switch. So this LibGuide was developed to provide a quick access to relevant literature for the countries who are thinking of switching. And you can you can find information such as planning, implementation, and evaluation of the switch. Okay. Then the focus obviously is on Africa. Then they are compiled by librarians with input from experts in the niche team. So you've got librarians bringing the expertise in information searching skills and the knowledge of databases, and that is coupled with the expertise of the niche team. Then we search several core medical databases such as PubMed and the ones listed there as well. Okay. So what is the sort of like the value for you as NITAGs? So according to SAGE, the primary roles of NITAGs should be to collect, review, assess and organize scientific evidence on specific vaccine-related topics. So the potential benefits for you is that you have access to contextually relevant, high-quality evidence-based research. And so this can actually improve your capacity to make robust recommendations. Then we all know that you face challenges of finding locally relevant information. So this is where the guide can also help you to provide efficient access to local data. And the following 3 points I've already mentioned, the fact that they deal with topical issues, they have up-to-date information, and you have access to full text material. Okay, so I think I'm going to pause here a little for a quick check-in. Can you perhaps indicate with a show of hands how many people know the existence of the LibGuides? Okay. So hopefully that is going to improve now after this presentation. And then have you accessed any of the LibGuides? Suppose. Okay. And then also now, I suppose I cannot actually, ask the last question if we've actually used the LibGuides in making recommendations. But hopefully this is all going to change after you see what a useful resource this is. Okay. So what are select features of the LibGuides? Because, I can't go through all of them. You see there's a LibGuide just devoted to what LibGuides are. Okay, so it gives you a better idea. Then each LibGuide has an introduction section to tell you more about what the LibGuide is about. Then the PICO is also included in the LibGuide, and also the search strategy that was used to compile that particular LibGuide. And for some of the LibGuides, there are tabs per country. It's either per region or per country. I'll show you that. Then, of course, we foreground WHO position papers, because your research should actually start with a position paper if there is one. And then what we also include is the reference list, which was used to compile that particular position paper. Okay. And as I said earlier, there are links to full text open source material. And of course, I'll show you some of the searching features, although it's very rudimentary. Okay, so you can see this particular LibGuide is devoted to what library guides are. Okay, I'm not going to read through each tab. You can do that in your own time. So this is a guide on its own dealing with LibGuides. Then this one on pentavalent meningococcal conjugate vaccine. This was one which was requested by WHO Afro. And you can see this is the introduction section here. And what we highlight here is that the ABCW vaccine should not be confused with the ACWYX vaccine. Okay. Next one, this is a one on Mpox. I'm just highlighting the PICO here. You can see we've got, so we've got the policy question there, then the population, intervention, comparison, and the outcome. Okay, so you are given the PICO there. Then also here is the search strategy, okay, which was used to compile that particular LibGuide. Okay, and so we've got the Boolean operators there. These are the search filter for Africa south of Sahara and so on. Then this one, we got a tab for WHO publications. They are listed here, but very important. You can see the first one is the WHO position paper. And then we've got the WHO position paper, the reference list. So it's easy, we make it very easy for you. So if you want to follow up on any of the references, they're all there. You can just click on the links, and there's the full text link. I've been talking about the full text link. If you click on here, it takes you directly to the resource. Okay. Then this one. And so there was talk about vaccine hesitancy. So we've got a LibGuide, on the topic here. And this one, you can see it's organized by the sub-Saharan African countries. Okay? And you can see there's a tab per country. Okay? So what are some of the search features? As I said earlier, the searching is very rudimentary. You can't do this type of searching that you can do in PubMed and some of the other databases. So it searches at a very like a high macro level, because it's looking just for information in the LibGuide. But you can search for evidence on a topic for your country. You can say Nigeria or Algeria or Tunisia, and if there's information to be displayed. And on a particular page, you can use a normal Control F function, okay, to see if a particular topic is represented on a particular page. And this is the search block here. If it's a search this guide, it's going to search for whatever you are looking for in that particular guide only. Okay. And then yes, so coming soon. So we've heard you. So, as I said, the search feature is very, rudimentary. It's very, you cannot really do very sophisticated searches. So we're hoping to develop a niche chatbot, okay? So which will provide more interactive searching. For example, you'll be able to ask a question, is there research on malaria in Africa and so on. Okay? And then, so what the chatbot will do is only looking at the material in the LibGuide, okay? Will not be searching full text articles, okay? So that's an exciting development. Okay, so now I welcome any questions or comments or suggestions. And I would really like to urge, so if you see maybe a similar work missing from our LibGuides, from your country, we really appreciate, if you can, email and we can include that. But remember, we cannot include everything, although we try to be exhaustive. So thank you.
Thanks very much, Dilshad. Okay, so Dilshad's asked for questions or comments or suggestions. Are there any here? We've got quite some time. So remember, as Greg said, when you get up, just tell us who you are and where you're from.
I'm Simeon from Nigeria. This is quite an exciting presentation, and some of us who are in the NITAG in Nigeria do not have access to this kind of information, and it will be quite interesting if we can help us integrate our own NITAG with you people so that we can have a robust information as far as vaccine access is concerned.
Thank you. Dilshad?
So I didn't quite understand the question. So remember, this is free access. Anybody in the world will be able to, go to the LibGuide and search for the information. The only information which will not get, if an article is like, if it's under behind paywall, so you will perhaps get like an error message, then you can just contact me for a particular resource that you are looking for. So I'm not sure if that answers your question.
Yeah, no, I'm talking about collaborating with you so that we're able to be guided on getting some of this robust information.
Yes, absolutely. But we are searching, as I say, free source information and the particular databases. But I think you may have a disadvantage in that you don't have access to the other databases like Scopus and so on. Do I understand that? But, we at UCT, we pay for Scopus. So you see, we also search some pay for databases to compile the LibGuides. So PubMed is the only free search engine. So if we were to collaborate with you, yes, I think we need to actually discuss at what level you want that collaboration to happen.
Like some of this article you are talking about is some of them is paid for, and we are a little bit resource constrained in terms of getting access to that. You need to pay for some articles. So for some of us who cannot pay for the articles, how can you come to our rescue?
Oh, absolutely. So that is why we have a partnership with UCT Libraries precisely because of that, because we know everybody doesn't have access. So it's as easy as, you send me an email to say you want a particular article. So even if it's behind paywall, we'll supply the article for you for free.
So just on that, so there are articles which even UCT with all its resources cannot access because they're paid for. What is the proportion? I mean, so we get all the general stuff, the Lancet, the BMJ, everything like that we've got access to, but there are journals that we cannot access either. Is that right?
Yes, absolutely. But I think we are very fortunate, Tony, that we can satisfy almost all the requests of our users.
Yeah.
And yes, so we do have what we call an interlibrary loan service. So that's nationally. So if the University of Cape Town doesn't, subscribe to a particular journal, we can, approach our colleagues at WITS or Stellenbosch and so on. So and we also go international if need be.
There was a question somewhere here. There we go.
Thank you very much, Dr. Benazouz from Morocco. My question is there any process for updating data?
Yes, so you can imagine it's a huge task. You can see there are 14 there, and material is coming all the time. Like I've got alerts for everybody, so we try our best. So, for example, most of this year was spent in developing new LibGuides. For this year, we developed 4 or 5, and so that's the next step, going from May forward to update them. But for example, if I see an alert coming through, which I think is like a bit important, then it does get updated. Yeah, but I understand that is a great challenge.
Yeah, thank you so much. I really think your presentation is pivotal. Sorry, my name is Dr. Dorothy Esangbedu from Nigeria. I think your presentation is really pivotal to the work that NITAG do.
Absolutely.
And one of the main problems that I think we face, and I expect it to be general, is that there's still a lot of information within our continent that we don't access because they are not in these so-called databases that is global. So in other words, there are a lot of local information that we may not be having access to. And so I want to know from you how you would try to access some of this information, which become important when we are talking about certain situations that are rare, where you don't even have information in general. Take mpox, for instance, you know. So I just want to know what you're doing to harness all the efforts being made by so many scientists in Africa that is not actually in the global space.
Thanks very much. That's the whole issue of the grey literature. So do you want to talk about that?
Yeah, so I think this is where we would like to partner with you because it's pretty much local in the sense that, for example, in Nigeria, you have particular information. Then you can actually share that information with us. But I mean, that is, I know that's been an issue for a very long time because even these databases, they mainly include, like, say, first world material, you know, and European material, although they are getting better. You can see PubMed is getting better, and Scopus, and there's something called Africa-wide, there's Scielo. So I think the only way is that we must take ownership of our own information and make that available. And many of these databases, they also open to, you know, wanting to add additional information. You know, they do want to be useful to more countries and so on. So I don't know if that actually, you know, answers your question, because if you, it can be local. For me, for you, it would be information in Nigeria. So what is the issue there? Why is that not being there? Why is that information not being harnessed or put into databases? And then you've got Africa generally. And I don't know, Ben can, you know, perhaps, I don't know how, you know, we are willing to help, but I don't know to what extent we'll be able to, you know, get that local information into the databases.
Ben, do you want to make a comment?
Yeah, you're right. It is a very important issue. In fact, when we ask NITAGs what kind of support they would want to get from the hub, you know, I mentioned vaccinology training, but the other thing was access to ROCO evidence, okay? And it is for that reasons that actually we developed those library guides. And for those library guides to be comprehensive, it need to be two-way. The librarian can only access what is available out there. Some of the information that you generate in your country goes into government report may not be readily accessible. So if you have that kind of information and you see it missing in any of the library guide, please let us know. And we will be able to add that information. And I think we were at a RITAG meeting sometime last year, CD, and the issue of African scientists being able to make their work visible came up strongly because we do a lot of research, but it's not visible to the rest of the people, which does not translate into using that information to influence the policy. So I think I see it as a two-way. As we do our part, also as scientists, evidence producers, let's not generate our data and keep it where it's not visible. Let's try to make effort to share it. I know there is issue of publication cost. Thankfully, most journals, you can make a case that you come from low and middle income countries and you get substantial discount to publish your work. And then the second part that we've been doing, we haven't made much progress, but we've started, is to create a network of librarians from African countries who are interested in supporting the work of NITAGs. We started that. We had about 6 countries represented, librarians in those countries, saying that they did not know about NITAGs, and they are very keen to get involved in supporting NITAGs, especially with accessing local evidence. So I think, Dilshad, that is something that needs to be, you know, we need to continue building that momentum so that we can have a network of librarians in Africa that looks after the interest of NITAG's access to local evidence. Finally, access to articles that you are talking about. Please, anytime you're not able to access an article because of paywall, submit your request to Niche through the help desk. And that request will go also to WHO Afro to City. Because sometimes you find somebody has that article, and once it goes, that request goes to many people, you are likely to get help. If not from UCT, I think from also the WHO colleagues. Thank you.
Thanks, Ben. I think Greg wants to make a comment.
Yeah, just to add on to what Ben is saying. So, I mean, the data that we use depends on where it's published, either in journals or the grey literature. And the grey literature for NITAGs is important. So Louise Hennef, she'll probably talk about this tomorrow. There is a NITAG Resource Center, the NRCS, that's hosted by WHO. And on the website, if you just Google NITAG Resource Center, you will find a website that's dedicated to NITAGs and all the outputs from NITAG. So if Nigeria makes a recommendation on monkeypox, if Uganda makes a recommendation on NOPV, they can publish it on that NITAG Resource Center, all right? So access to that information depends on us providing that information to the NITAG Resource Center. So it's a resource that we should encourage people to use and to deposit information, especially unpublished information, our recommendations, our minutes of NITAG meetings, etc., etc. And maybe we can ask Louise tomorrow when she's here to say a few more words about the NITAG Resource Center.
Greg? Okay. I think we probably need to move on. So thank you very much. I must just tell you, Dilshad is absolutely passionate about this stuff. And she likes nothing better than to get you the information that you're looking for. So please contact her when you need it. All right.
Okay, thank you, Tony. Thanks, everybody.
I forgot something very important. Where's Chipisa? Has she gone? Oh my goodness. All right. We had a birthday to celebrate, but we'll have to postpone it till she's back with us.
I'm coming, Tony.
Okay. We've got two senior colleagues from WHO who are going to speak to us next. Jason used to work for WHO. I'm sure many of you know him. Jason Mwenda. He's now an independent consultant, and he's going to talk about global, regional, and national sources of evidence relevant to NITAG's work. And then Sidi, I'm going to be accused of pronouncing Sidi's surname wrong, like Greg was earlier. So it's Ndiaye. Is that right? Ndiaye. Ndiaye. All right. So Sidi is currently, and I'm sure many of you know Sidi as well. But Jason, welcome to you, and over to you.
Thank you very much, Tony, and good morning, colleagues. I hope you enjoyed the session in the morning and also this just a few minutes ago. I think it was really quite informative. So what you do is we'll look at the sources of evidence that is relevant to NITAGs. I think we've already started discussing some of these sources and how we use this data, particularly to inform the recommendations and the decisions that we make at the country level. I think the role of the NITAG is extremely important, and it's important to make sure that we have the right information. So let's start with a few basic questions. I think some of these have already been answered. I'm told we have about 11 countries represented here, or NITAGs from those 11 countries. So we expect every country to make a comment, or at least be able to answer one of these questions. I think the discussion was quite lively. I think we already know what the NITAGs are. And to some extent, I think what is the role of the NITAG, I think we also know that. Does anyone want to refresh our mind? What is the role of the NITAG? I'm aware that there are mature NITAGs, there are NITAGs that are just being established. Anyone who wants to tell us what is the role of the NITAG or NITAG? Which country? If you don't, I'll volunteer you. I'll use the African democracy to volunteer you. But we want to hear from you. We're trying to make this as interactive as possible so that we can also learn from you, or we learn from each other. Anyone? No one. You're NITAGs. You don't know what the NITAGs are supposed to do. Yes, yes, please. Which country? Mauritania. Yes, please.
Oui, bonjour, je suis Dr Abdelmalik de la Mauritanie. Donc, pour le rôle du NINTAG, c'est d'avoir un rôle de conseiller auprès des décideurs politiques pour tout ce qui concerne la vaccination. Donc, il y a aussi un rôle de formation continue pour tous les membres qui travaillent au sein du NINTAG. Voilà, donc c'est essentiellement un rôle de conseiller en matière de politique vaccinale.
Thank you very much. That's correct. Advising the Minister of Health, I think that's extremely important. So let's move to the next one. Why should NITAG gather evidence? I think we talked about it, particularly scientific evidence. I'm going to be focusing more on the scientific evidence. Why do we need scientific evidence? Anyone? Cape Verde. Do you have Cape Verde? Yes, please. I think I heard you saying you're trying to set up your NITAG, right? Okay. Mike, can you use the mic, please, if you don't mind?
If we are going to advise the Ministry of Health about the vaccines, we have to gather evidences, technical evidences to try to explain why we are taking recommendation or other, because otherwise we won't have all the basis to stand for our recommendation.
Precisely. You really need to make sure that the recommendation that you make to the Ministry of Health in terms of advising the Ministry of Health is evidence-based, is evidence-informed, because the ministry needs to make that decision, and that decision is extremely important. You don't want the minister to make the wrong decision. For example, we talked about Mpox, or we talked about PCV, pneumococcal conjugate vaccine, or rotavirus vaccine, or any other vaccine. So you want to make sure that you're on top of the evidence. In other words, you have all the evidence that you need at your fingertips to be able to make the right decision to advise the Minister of Health. You do not really want to misadvise the Minister of Health. Okay, let's move on a little bit. I think we have more or less also answered this question. Why is it that this evidence is critical for the NITAG members? So let's look at the next one, the sources of evidence. I think we also started discussing that. What are the sources of evidence? I think we also talked, and also the previous presentation. But can we hear from, let me see, my friends from Senegal? Senegal.
Par là.
Oui.
Bonjour. Attends. Bonjour, je suis le docteur Ogeka du Sénégal. Donc, les sources pour les données probantes, il faut aller sur les sites qui publient des articles scientifiques sur le sujet que l'on recherche et pour pouvoir les étudier, les exploiter. Et ça va constituer un peu la base pour formuler des recommandations pour la question qui a été posée. Merci.
Excellent. I think we have a very informed audience here, Ben. So congratulations to everyone. I'm just wondering whether I should continue with this presentation. Okay. And how do we use the evidence? I think this one also we have more or less discussed this one, how we use the evidence that we gather. So let's move on. There'll be more questions. And those of us who have not made a comment, we expect you to make a comment. So I think this, we have more or less gone through this in terms of the NITACs. What are the NITACs? This is who we are, the NITACs, what we do, and why we do it. I think it's becoming quite clear in terms of the NITACs. So it's it's a group of technical experts, and I really wanted to sort of underline that, technical experts. And I think earlier we discussed about the composition of the NITAC, how the NITAC should be composed, constituted to make sure that we have the relevant expertise, and also looking at the evolving landscape of the vaccines and the vaccination. We need to make sure that we have the right experts. If we have epidemiologists, for example, immunologists in that NITAC, we also need to have health economists now, because this is becoming an important topic. We learned a lot from the COVID and other vaccines, that we need to look at the health costs as well in terms of the public health benefits of vaccines and the vaccination. A review, I think, is extremely important, to review the evidence that we collect. And I think we talked about the published, this is peer-reviewed information, but also the great literature. But later on, we'll come to how do we assess the quality of that evidence, because I think it's extremely important to make sure that the evidence that we are using is of the highest quality, so that we can make the right decisions. We advise the ministries for health. I think the colleague from CAV1 mentioned that. Making sure that we are using the latest scientific evidence, and also looking at the available best practices. I think this is all that informs the decisions or the advice that we give to the Minister of Health. So in terms of the sources of evidence and the use of that evidence, there are different levels. And I think this came out very clearly when we were discussing the previous presentation. At the global level, obviously, there is evidence that is at the global level, and we'll look at that in more detail. At the regional level, we also have evidence that is available at the regional level. Here we're talking about Africa, for example. If you take Africa, what kind of evidence is available at the country level, at the national level? What kind of evidence is available at that level? And I think we've already started discussing that. I think it's also extremely important to assess the quality, as we just mentioned, the quality of evidence, because we want to be informed when we make that recommendation or when we advise the Minister of Health. In other words, now we need to put all that information together. We analyze that information depending on the question that we've been asked by the Minister of Health to advise on. And we need to also be able to integrate that information from the global level, the regional level, and also the national level, to be able to triangulate that information, put it all together and look at it, so that we have a very good idea of how we can be able to advise the Minister of Health to address that particular question that the Minister of Health has asked us to look at, to make a recommendation. And I think the presentation from South Africa was actually quite good in terms of some of the questions that they have come up with and the recommendation that they have made. With PCV, for example, looking at the use of PCV in infants, the use of PCV in adults. So the schedule, the type of vaccine, I think these are some of the questions that will be brought to us as NITACs, and we should be able to advise the Minister of Health appropriately. So why is evidence so important? Because you are saying evidence recommendation. Why is it important? Why do we need to make sure that we have the evidence? Anyone? One is to build the trust in vaccines and vaccination. And I think the issue of vaccine hesitancy also came up. How do we build the confidence? It's only having that information in terms of, for example, what is the impact of that vaccine having in terms of reducing the burden of disease? That's extremely important. Once people see those figures, here is the data before the introduction of the vaccine, and here is the data after the introduction, and showing the reduction in terms of the disease burden. That builds the confidence in terms of vaccines and vaccination. Policy also, I think, is extremely important. The Minister of Health will use that information to be able to formulate a policy based on the recommendation or the guidance that we have provided to the Minister of Health. The other one is in terms of optimizing the use of these vaccines. We do have vaccines, but we know that we can do better in terms of really harnessing the potential of these vaccines. We are not there yet. And that's where the NITAC becomes extremely important to be able to package all that information to be able to help the Ministry of Health to optimize the use of those vaccines for public health impact or effect of that particular vaccine. So in terms of what questions is the Minister of Health asking us to do? It could be the minister wants to introduce a new vaccine. We heard about RSV, for example. We heard about South Africa wanting to change the vaccine from PCV 13 maybe to PCV 15, or changing the schedule, for example, from 3+0, in other words, 3 doses of vaccine to 3+1, or 2+1, or 2+0. These are some of the policy questions that the ministry will be grappling with and being unable to make that decision. And these vaccines are not cheap. They are expensive. And therefore, we want to make sure that we make the right decision to make sure that we are also minimizing the cost and harnessing the potential benefit of these vaccines. Global sources of evidence that is relevant to the NITACs. So these are, I put here a list of some of the institutions who are the custodian of some of the data or information that we might need. In addition to what we discussed, public literature, where the data has been published, but also these organizations, for example, WHO collaborating centers, US CDC, Gavi, we have a representative from Gavi. Depending on the question that you're asking, if you look at the websites of these organizations, you'll be able to find a lot of information. For example, we talked about the WHO position paper. If you go to the WHO website, you'll be able to see the WHO position paper, which is very, very clear in terms of, it starts with the background of the disease. For example, if a country wants to make a decision in terms of introducing a new vaccine, like let's say PCV or any other vaccine or malaria vaccine, for example, the WHO position paper is a very important document. That should be the starting point, looking at that WHO position paper. And we'll come back to that. The universities and the research institutions where they do a lot of research. If you're taking malaria, for example, you can also see the local evidence and the local data for your country. If that's not available, you might be able to get data from a neighboring country, for example, that can inform your discussions as NITACs. We have the IHME. I don't know how many of you know about IHME, which is Institute of Health Metrics and Evaluation. It's part of the University of Washington. How many of you? It's a very important resource. We should publish, disease burden data, which is extremely important. And in some cases, they can look at the regional disease burden and also country-specific disease burden. And I think their website is also publicly available. If not, through niche, perhaps you could be able to access some of the data that can be extremely important to inform your discussions and the decision. CEPI, which is Coalition for Epidemic Preparedness and Innovation, they also have a lot of information, and this is all information that is openly available to anyone who might want to look at it. Additionally, they discuss vaccines against emerging infections, epidemics, and pandemic. This is their specialty in this area. So if you look at the website of CEPI, you'll be able to access a lot of information. So what kind of evidence needs are there? We oftentimes may need to look at the disease burden in our particular country, because the ministry want to, is this really a public health problem in country X, for example, in Nigeria? I know Nigeria struggled to introduce PCV, rotavirus vaccine also took a bit of time, and there are a lot of discussions. I remember when we started working on rotavirus vaccines, a lot of policymakers never believed that rotavirus diarrhea was a major public health problem until we started producing the data, and I will show you some of the data that has been published and available, country-specific and also regional data. And the trends after the introduction of the vaccine, for example, PCV. Do you know how the trend of invasive pneumococcal disease, for example, or pneumonia in children? New vaccines introduction, a country may need to make a decision which vaccine to introduce. For example, rotavirus, how many vaccines? How many rotavirus vaccines are there? How many? 4, 5, right? So the ministry will be grappling, which of these vaccines should we introduce? What is the difference between those vaccines? As a NITAC, you need to know if the ministry is asking, should we introduce Rotavac, for example, or Rotacil vaccine? Are there any differences? What makes a country decide one vaccine over the other? Are there any differences? Is one vaccine working better than the other? And so you need to look at the literature. You need to look at the information. Are we doing with time? Okay. Okay. Sorry. Okay. Okay. Thank you. Vaccine safety, I think, is an issue that came up, and we learned a lot from COVID and other vaccines. We really need to look at this area very carefully. You don't just say vaccines, our generation used to say vaccines are very safe and everyone will believe it and no problem. These days is not the same because of misinformation about vaccines. And we need to be informed. Where do you get the information? I think Sidi may touch on some of this because when the medicine is asking, is this vaccine safe? You don't know, rotavirus vaccine, for example, there are issues about interception with the early generation of vaccines, and people still have that in mind. But the current vaccines, we know that interception is not a major issue with the rotavirus vaccines. And the data is there. You can be able to gather that data and show it to the Ministry of Health and say this vaccine is safe, at least based on the information that we have. And there is surveillance, not just on the burden of disease, but also in terms of the safety of these vaccines. There is a lot of monitoring that is going on through the vaccine safety network. The vaccines in pipeline, I think it's also important to also know what are the vaccines that are being developed. Not yet pre-qualified by WHO, but in the next 1 or 2 years, these vaccines might be pre-qualified. So you are ahead of the game all the time. And the WHO website will also have some of this information in terms of vaccines that are in the pipeline, RSV, for example, and what are the changes that are taking place? Because even with the WHO position paper, that information is not static. WHO continues to look, and other organizations to still look at the data that is coming through. What is the data telling us so that we can be able to make the right decision? Do you need to say? For example, there is a lot of discussion now about PCV. The recommendation was 3+1 schedule, but we know that 2+1 might also be working better, and you might even save in terms of the cost and the expenditure on that particular vaccine. Not very clear, but here, this slide is basically to emphasize that WHO is one of the leading health authority that provides technical guidance on health policies and practices globally, especially in terms of vaccines, because we are talking about the vaccines here. It also provides the information on these vaccines and also the strategies on how to use those vaccines. I think it was mentioned about the resources for NITAC. If you go to the WHO website, there is that link there for the resources for NITAC, which also has a lot of information. And this is publicly available information. How many of you know about SAGE? Strategic Advisory Group of Experts. I think this was mentioned earlier. Do you know about SAGE? Who? No? NITACs? Which country? Let me see. Oh, Morocco. We haven't heard from Morocco. SAGE. Do you know SAGE? This is the Strategic Advisory Group of Experts. This is a group of experts, very high level, that was put together by WHO way back in 1999 to provide WHO with high-level guidance on vaccines and vaccination. The meetings are held, I think 3 or 4 meetings are here every year. They meet, and WHO usually has an agenda. So WHO is advised by SAGE in terms of all aspects of vaccines and vaccination. These are very informed, technically very high level. They advise WHO. So when you hear of WHO position paper, it's not just WHO issuing that position paper. WHO issue that position paper based on the guidance and the recommendation from SAGE. So it's multidisciplinary, all sorts of experts. We put together different experts to advise WHO to look at every aspect, if it's epidemiology, if it's vaccine safety, if it's the age range, for example, for that particular vaccine. They will look at all that, and these are experts who advise WHO, and they serve for a period, a specified period. And there is also geographical representation in SAGE to make sure that if it's Africa, the interest of Africa or the particular context within Africa is also, the voice is also heard, US and other countries. So this is a very powerful group of experts that advise WHO on the global policies. Currently, there are about 27 policy papers on vaccines and vaccine preventable diseases, and you can be able to access the website of SAGE to see some of this. We mentioned some of the WHO position paper here, just to give some information about PCV, for example, how the information is regularly reviewed. So it just doesn't stop at the first position paper. Reviews are made regularly. The first one was February of 2019, and this was the use of pneumococcal conjugate vaccines in infants. Then there was an update of that position paper in April 2021 on the use of PCV during community outbreaks, and then another one, also 2021, looking at the use of PCV in older adults. So this information, and at the website, you'll see some of this information. So if the Minister of Health is asking, can we use PCV for older generation? The information will be on some of these position papers. US CDC is another source of evidence for vaccines, also issues guidelines in terms of vaccines and vaccination, and these can also be an important resource for NITAGs. Regional sources, also very, very important. We talked about WHO Afro and EMRO region. In Africa, we have 54 countries. Afro is 47, and 7 of the countries in EMRO are also part of Africa. So some of these links will also be very useful. We do have the Regional Technical Advisory Group, or RITAC, which is constituted by WHO Afro. Also, they discuss vaccines and vaccination. Some of this information will be very useful. There are other technical advisory groups. EPI managers meetings also discuss some of these, and some of the reports can also be useful to inform the NITAG discussions. Regional committee meetings, the ministers of health often come together once a year to discuss different topics, and usually there is an agenda on vaccines and vaccination in Africa. Africa CDC also could be an important source of information for the NITAG. UNICEF, I think we mentioned. Gavi also has a lot of information on new vaccines introduction, and a lot of technical information also that can be very useful. We also have important laboratories like the regional reference labs that can be useful. Universities also would have very important information. Okay, I think we'll probably, let's can skip this one. The slides will be available to you. Surveillance, we mentioned surveillance as extremely important, and there is a lot of surveillance activities ongoing for a specific disease, for example, at the regional level and also at the local level. That can be very, very useful. So really familiarizing yourself with the surveillance activities within the region will be very useful to inform the discussions. At the national level, also, there will be information that will be available there. I think we talked about the ministries of health also collecting epidemiological data on certain diseases that could also be very useful to inform the NITAG. So we have the global, we have the regional, and also the global level. There's a lot of research institutions also in our region. Some of these research institutions are also collecting a lot of information that could be available. And I would really encourage you also to to network with the research institutions at the country level. We had colleagues from Nigeria, you know about the Nigeria Center for Disease Control. That is also has a lot of information, and if you access their website, if not through the focal points, you could be able to access some of this information that can guide you. And if you don't have a research institute in your country, you can look at the neighboring country, Medical Research Council in the Gambia, for example, Cameroon in Kenya, CSIM in Mozambique, for example, that does a lot of research and also collaborating with WHO and other institutions, and that information could be available. So here the emphasis is networking. What we do as NITAC, we really have no network. We have to know where to get that particular information. So depending on the question, if the minister has asked you to look at a particular question, you need to make sure that at least you are able. If not, get in touch with WHO and they might be able to direct you to where you can get that information that will inform you. I remember when I was with WHO, some NITACs would get in touch with me and ask me to give a presentation on a particular topic, let's say invasive pneumococcal diseases, and particularly for that particular country. What is the disease? What is the trend after the introduction of the vaccine? So here just to show you some of the examples of some of the surveillance that are going. I mentioned the rotavirus. You can see here again, and this is publicly available through the rotavirus surveillance network. We're gathering information from different countries, and from time to time, we'll put all that information together in terms of a journal supplement to put all that information together. And you can see here some of the publications that are publicly available. Yeah, the impact of vaccination, pneumonia, and also invasive pneumococcal diseases, again, journal supplements that we are putting together as part of the network. And some of these we would actually distribute even hand copies to the NITACs. And if you look at some of these publications, you'll see country-specific data in terms of the disease burden and also in terms of the impact of PCV and rotavirus. I mentioned about evaluating the evidence that we collect. We need to be able to evaluate the evidence and look at the methodology. How was that data collected, for example, to make sure that you have credible information that informs your discussion. Look at the sample size. Is the sample size reasonable? Is the statistical evaluation of that data appropriate? Can you really rely on that particular evidence to make a decision? I think these are some critical things. How applicable are the funds? I mean, are the data or the findings to your particular context or the decisions that you need to make in terms of advising the Minister of Health? I mentioned about data triangulation. You're looking at the global level, regional level, the national level, putting all that together, really be able to look at the quality of the data and analyzing so that you have the credible information that you need. Okay. We still have about 5 minutes. So just to conclude, I think NITACs are extremely important. And we've seen it over the years in terms of advising the minister whether to make the right decision that really makes sure that we are using these vaccines in an optimal manner to be able to have the potential benefit of these vaccines. So it's extremely important, and the URO is extremely important and is really, really appreciated by the Ministries of Health and also WHO and other partners. Collecting that data together, integrating and triangulating that data is extremely important to make sure that you are informed as you make those recommendations to the Ministry of Health. And then finally, these decisions should be impactful. Whatever we do should have that public health impact that we want. What is it that we want to achieve in this area of work? Is to make sure that these vaccines are having the potential impact, reducing the disease burden and saving the lives of our children, and also all the targeted diseases. Thank you very much.
Thank you very much, Prof. And thank you for keeping to time. That was excellent. We're right on time now. I'm not going to allow questions now because we've got 15 minutes after Sidi's talk where we can ask questions on both, if that's okay with you. So I'm going to invite Sidi up to give the next talk. He's going to talk about, sorry, let me, thank you, Apple. There we go. Right, he's going to talk about WHO Afro-regional immunization policies for half an hour. And then, as I say, we've got 15 minutes where we can entertain some questions before we get to the separate NITAGs. So thank you very much, Sidi, and welcome.
Thank you, Tony. It's challenging to come after Professor Jason. So I think we have few French-speaking countries here. So we'll be switching to French. South Africa, take your headset, please. Don't worry, the slides are in English, so I'll be speaking in French. Merci à tous. Alors, professeur Ben m'a chargé de vous parler un peu des cadres de la vaccination au niveau global, au niveau africain et ce qui se passe au niveau des pays. Donc, ça, c'est un peu les grandes lignes de la présentation. Est-ce que quelqu'un est au courant des cadres global, du cadre global de vaccination au niveau mondial? Quel est le cadre, le cadre stratégique de la vaccination au niveau mondial? J'ai un promotionnaire dans la salle, donc souvent je vais le fatiguer. Magan, vas-y.
Bon, ce que je retiens de ce cadre-là, pour moi, c'est le programme mondial IA 2030, l'agenda IA 2030 qui régit un peu donc ce cadre donc, au niveau mondial.
Merci, effectivement. Et le cadre au niveau africain? Le cadre stratégique de la vaccination au niveau africain, quel est ce cadre? Oui.
Alors, je peux deviner que le cadre africain, il émane du cadre mondial, c'est-à-dire faire bénéficier tout le monde des bienfaits de la vaccination durant tout le cycle de vie.
Merci beaucoup. Merci, effectivement, c'est ça. Donc, on va parler globalement de ces différents cadres. Actuellement, le cadre stratégique de la vaccination au niveau global, c'est effectivement l'agenda 2030 de la vaccination, qui est un cadre stratégique qui partage un peu les objectifs de la vaccination au niveau global. La vision, comme vous le voyez, c'est un monde où tout un chacun, à quelque âge que ce soit, où qu'il soit, puisse bénéficier pleinement de la vaccination pour le bien-être et une bonne santé. Je pense que ça, c'est des visions qui sont reprises dans tous les cadres de santé, que ce soit la vaccination, que ce soit aussi les autres interventions de santé. Et nous avons 3 objectifs d'impact qui ont été définis, à savoir la réduction de la mortalité des maladies évitables par la vaccination, de ne laisser personne derrière en termes d'accès équitable à la vaccination, mais aussi que ce ne soit pas seulement les vaccins traditionnels. Il y a les nouveaux vaccins, il y a les vaccins qui vont venir avec les nouvelles émergences de maladies, mais aussi, on sait que dans nos pays, il y a des vaccins qui sont sous-utilisés. Et ça, c'est quelque chose de très important en Afrique, à savoir l'accès équitable à la vaccination. C'est ce qui explique beaucoup d'initiatives dans nos pays. La mise en place de Gavi, ça vient un peu pour combler l'accès équitable à la vaccination. Et d'autres partenaires de la vaccination. Donc, après le cadre global, il y a le cadre régional stratégique de la vaccination qui émane de ce cadre global-là et qui est chargé de pouvoir mettre en œuvre les cadres globaux de la vaccination. Mais au niveau africain, ce qui est spécifique, c'est qu'en plus de ce cadre de la vaccination, il y a des cadres spécifiques de lutte contre la maladie qu'on va voir. Et en plus de ça, il y a la déclaration des ministres de la Santé, la déclaration des chefs de l'État de 2017, la déclaration d'Addis Abeba, avec les 10 engagements des chefs de l'État en faveur de la vaccination. Et cet engagement a été renouvelé juste après la pandémie Covid, parce qu'on a vu quand même qu'il y avait beaucoup de choses encore à faire. Et à partir de là, nous avons au niveau national ce qu'on appelle la stratégie nationale de la vaccination. Auparavant, c'était les plans multi-annuels de la vaccination, les CMYP. Mais maintenant, on parle de stratégie nationale de la vaccination. Et voici un peu les jalons par rapport au cadre mondial de la vaccination. Le premier jalon, c'est d'éviter 50 millions de décès dus aux maladies évitables par la vaccination. Le deuxième, c'est que tous les pays puissent achever le contrôle, l'élimination, l'éradication des maladies ciblées. Quand on parle d'éradication, on va penser à la poliomyélite. L'élimination, c'est la rougeole, le tétanos maternel et néonatal, l'hépatite B, et pour le contrôle, les autres maladies évitables par la vaccination. On a aussi qu'on puisse mettre fin aux épidémies massives des maladies évitables par la vaccination. Ça, c'est quelque chose qui est surtout spécifique dans nos contrées, où les couvertures vaccinales, quand même, ne sont pas optimales. Et quand la couverture vaccinale n'est pas optimale, on risque d'avoir une accumulation de susceptibles dans la communauté, d'où des épidémies massives dues aux maladies évitables par la vaccination. Donc l'autre, c'est d'avoir 50% de réduction des nombres de zéro dose comparé à 2020. Je ne sais pas où est-ce qu'on en est dans nos pays, mais il faut dire qu'on est souvent loin d'atteindre cet objectif. Mais il y a d'autres présentations, je pense à la troisième journée qu'on va faire. Il y a mon patron aussi qui va intervenir sur le niveau d'atteinte de ces objectifs. L'introduction de 500 nouvelles introductions de vaccins dans les pays à l'échelle mondiale. Mais dans ces 500-là, la plupart, c'est en Afrique. Et les pays supportés par Gavi. Et l'autre jalon, derrière lequel on court depuis 30 ans ou 50 ans maintenant, depuis 50 ans, parce que la création du PEV, c'est 1974, c'est d'avoir au moins 90% de couverture vaccinale aux antigènes du PEV. Il y a certains pays qui y sont arrivés. En Afrique, on peut citer les pays du Maghreb et les îles telles que l'île Maurice, Seychelles. Mais en Afrique subsaharienne, on a encore d'énormes efforts à faire dans ce sens-là. Et le dernier jalon, c'est de renforcer, d'augmenter l'accès universel aux soins de santé primaires. Donc ça, c'est un peu le cadre de mise en œuvre de l'IA 2030 au niveau de la région africaine. Comme je vous l'ai dit, en plus du cadre global de référence, il y a aussi des cadres spécifiques aux maladies, tels que l'initiative pour mettre fin aux épidémies de fièvre jaune, le cadre régional d'élimination de la rougeole et de la rubéole, de mettre fin aux méningites bactériennes et aussi le cadre, le business case pour la vaccination en Afrique et aussi, bien sûr, la feuille de route pour la mise en œuvre des engagements de la déclaration d'Addis Abeba de 2017. Donc, vous voyez que pour le cadre au niveau africain, donc en plus du cadre de l'IA 2030, il y a d'autres cadres spécifiques qui s'y sont greffés et c'est ce qui va expliquer un peu le plan stratégique régional de la vaccination qui va augmenter en plus des 15 objectifs, des 15 indicateurs globaux. Au niveau africain, on a augmenté 31 indicateurs au niveau régional. Donc, c'est une diapo qui va reprendre la vision, les objectifs d'impact, les stratégies, les axes stratégiques prioritaires qui sont au nombre de 7, les objectifs stratégiques avec 21 objectifs et les domaines d'intervention prioritaires. Par rapport aux objectifs d'impact, voici les 5 objectifs d'impact au niveau de la région africaine. Et nous allons voir où est-ce qu'on en est pour l'atteinte de ces objectifs. Alors, pour les pays qui sont là, où est-ce que vous en êtes par rapport à la couverture vaccinale? L'atteinte de 90% à tous les antigènes. Quels sont les pays qui ont atteint 90% de couverture à tous les antigènes? Levez la main. Cap-Vert, Tunisie, Maroc, sauf rougeole. Oui. Afrique du Sud? Non? Oui, allez-y, prof. Oui, oui, bien sûr.
Il y a les 3 vaccins classiques de 3-4 mois. Ouais. Ensuite, il y a les vaccins qui viennent à l'âge de 1 an et les rappels. Ouais. Donc, la couverture, est-ce qu'elle va concerner tous ces vaccins ou uniquement les vaccins de la première année?
OK, je parle des couvertures des vaccins infantiles. La première année de vie. Oui. Donc, vous voyez que on est encore loin. Quels sont les pays qui sont entre 80 et 90? 80 et 90. Tu n'as pas levé ta main. Hein? Sénégal, Cameroun, Mauritanie, Nigeria, Guinée. OK. Quels sont ceux qui sont entre 60 et 80? Tout le monde doit se trouver au moins entre 60 et 80. Non? Oui. Gambie, Guinée et Cameroun. Donc, on a 3 catégories de pays ici. Donc, vous voyez que les priorités, souvent, ne seront pas les mêmes. Yes, I'm on track. Ensuite, pour la rougeole, vous voyez que la plupart des pays, souvent, ils ont de très bonnes couvertures. Au Penta 1, Penta 2, souvent, rougeole première dose, mais quand il arrive à la deuxième dose, on tombe. Et pour l'élimination de la rougeole, il faut au moins atteindre 90% de couverture aux 2 doses. Au moins. Et ceci sur au moins 5 ans, de façon soutenue. Il faut aussi faire des campagnes de suivi pour les 5 ans, les enfants de moins de 5 ans, et des campagnes de rattrapage pour les enfants de moins de 15 ans tous les 10 ans, à peu près. Mangane, je pense que c'est ça, hein? Je n'ai pas oublié. Et puis avoir un bon système de surveillance. Malheureusement, ce qu'on voit après le ramp down de la polio, c'est que on a vu que notre système de surveillance était un peu supporté par la polio. Et on doit repenser souvent, même dans certains pays, le système de surveillance. Parce que les fonds sont partis. Souvent, il n'y a plus de stop team dans les pays. On ne fait plus la surveillance. Et un bon jour, on se retrouve avec des centaines de cas de rougeole et d'autres maladies. Donc, ça, c'est un axe prioritaire. Et malheureusement, dans beaucoup de pays, on n'a pas encore de cadre stratégique d'élimination de la rougeole. Donc, en plus de notre plan national de vaccination, stratégique de vaccination, il faut aussi des cadres spécifiques de lutte contre les maladies évitables par la vaccination. Avoir un plan stratégique contre la rougeole, avoir un plan stratégique contre la méningite, les méningites bactériennes, les diarrhées, les pneumocoques, et les infections respiratoires, ainsi de suite. Quand je discutais souvent lors des réunions des API managers, je leur disais, la vaccination est devenue pratiquement un ministère à part. Parce qu'on va au-delà de la petite enfance. On a maintenant les femmes, on a les hommes, les adultes, on a les personnes âgées. Donc, même le positionnement institutionnel de nos programmes de vaccination doivent être revus, renforcés. On ne peut plus se limiter à 2, 3, 4 personnes au programme de vaccination. Ce n'est plus possible. Et les NITAC sont là pour supporter les programmes de vaccination, bien sûr. Et ça, d'ailleurs, c'est devenu c'est revenu à son heure. Alors, en parlant de la rougeole, il faut avoir au moins 95% de couverture à la première dose. Et de façon soutenue. Mais malheureusement, cette couverture, on a vu que pendant la COVID, elle a baissé. Bon, elle commence à remonter, mais pas à un niveau soutenu. D'où les grandes épidémies massives qu'on a vues en RDC, en Angola et dans d'autres pays entre 2019 et 2023. Et ça continue encore dans certains pays. Nous avons aussi, en plus du cadre stratégique contre la rougeole, le cadre pour mettre fin, bon, on dit defeat meningitis, pour défaire les méningites bactériennes. Et je pense qu'actuellement, dans la région africaine, on a un moyen pour pouvoir faire ça. Actuellement, pratiquement tous les pays ont eu à faire des campagnes massives de vaccination contre la méningite à méningocoque A. Et ça, c'est une des réussites de la vaccination dans la région africaine. Bon, on n'ose pas dire qu'on a éliminé le sérogroupe A, mais depuis beaucoup d'années maintenant, depuis je pense 6 ou 7 ans, on n'a pas vu de prélèvement positif au sérogroupe A. Donc actuellement, oh, ok. Ok. Bon, c'est la taille souvent. Je pensais que les gens ne m'entendaient pas. Actuellement, on a une arme qui a été donc et qui est supportée par Gavi, c'est-à-dire c'est le vaccin pentavalent contre la méningite. Et il faut dire que certains pays déjà prévoient de l'introduire en 2000. Il y a certains pays qui l'ont utilisé pour répondre aux épidémies de méningite comme le Nigeria. Il y a d'autres qui planifient d'introduire ce vaccin-là. Et moi, je dirais aux pays qui sont dans la ceinture méningitique de pouvoir très rapidement introduire ce vaccin-là. D'autant plus que c'est supporté par Gavi. Et saluer ici le travail qui a été fait par le niche. Je leur ai envoyé récemment une requête pour avoir une librairie guide pour la dose, le vaccin pentavalent, et ils ont eu à faire ça. Félicitations encore à Dilshad et à l'équipe de niche pour ça. Donc, on est là aussi pour pouvoir appuyer à cela. Ensuite, nous avons le cadre. Nous avons le cadre stratégique d'élimination des épidémies de fièvre jaune dans les pays à risque. Et actuellement, au niveau régional, on est en train de penser à pouvoir renouveler ce cadre stratégique-là qui est arrivé à terme. Mais il faut dire qu'il y a eu des résultats réellement positifs par rapport à la lutte contre la fièvre jaune, parce qu'il y a 14 pays qui ont eu quand même à faire des campagnes massives de vaccination contre la fièvre jaune. Et il y a des pays qui sont en train de revoir le cadre stratégique aussi de lutte contre les fièvres jaunes. Le Tchad, le Niger qui est là, la RDC et le Cameroun. Nous avons aussi le cadre global pour accélérer l'élimination du cancer du col de l'utérus dû à HPV. Et la vaccination est un des piliers fondamentaux de ce cadre. Ça veut dire que tous les pays sont appelés à introduire le vaccin contre HPV et avoir au moins 90% de couverture pour pouvoir impacter positivement sur ce cadre stratégique d'élimination du cancer du col de l'utérus. Globalement, au niveau de la région africaine, voici là où on est par rapport à la mise en œuvre du plan stratégique de la vaccination. On en est où? Les décès évitables par les maladies évitables par la vaccination, on est off track, comme disent les Anglais. Pour l'élimination du poliovirus sauvage, on est bien. Mais pour tous les autres, on est encore très en retard. Pour la rougeole rubéole, aucun pays de la région africaine n'a éliminé la rougeole rubéole. Pour l'élimination du tétanos maternel néonatal, c'est bon. Pour les couvertures vaccinales, j'en parle pas. On est très en retard. Et après la pandémie Covid, on a eu des baisses de couverture vaccinale extraordinaires dans nos pays. D'où l'initiative du Big Catch-up dans la région, avec les différents objectifs qui sont cités ici, qui sont 6 objectifs. Et il y a eu 14 pays qui ont été priorisés dans ce Big Catch-up-là, qui sont en train quand même de faire des efforts. On va le voir le mercredi, des efforts énormes pour pouvoir rattraper les enfants âgés de 12 à 59 mois. On a beaucoup de défis. Premier défi, c'est l'engagement politique. Au-delà des déclarations. Au-delà des déclarations de principe, il faut mettre les moyens. Les moyens budgétaires de l'État pour acheter des vaccins, mais aussi pour les coûts opérationnels. Malheureusement, si ça ne suit pas, les financements ne suivent pas, les couvertures vaccinales ne suivent pas, on a des épidémies, le personnel est mobilisé pour lutter contre les épidémies, on oublie la routine, ainsi de suite, la retourne, le cercle vicieux est là. Et bien sûr, la réticence vaccinale, je pense qu'Elisabeth va en parler, la réticence vaccinale qui commence à augmenter dans la région africaine. C'est devenu un réel problème et nous devons l'adresser. Et il y a des pistes de solutions, bien sûr, que nous proposons ici, mais dans chaque pays, on doit contextualiser. D'où l'importance du groupe technique consultatif sur la vaccination, qui sont des experts de l'université, des experts qui ont eu à pratiquer la vaccination, la santé publique, qui doivent orienter les politiques et les stratégies des pays pour pouvoir avoir des programmes de vaccination solides, pour que ce programme de vaccination qui a maintenant 50 ans, qui est un adulte, mûr, mais avec les jambes flageolantes. Merci.
City. I wasn't sure why he picked up the microphone. I thought it's because he's so tall. And his neck was getting stiff, bending down, so he picked up the mic. Anyway, all right. So thank you very much also, Sidi, for keeping to time. And Jason is still with us. So we do have some time now if we would like to raise some questions on the last two presentations. We had first the professor, and then I'm not sure about Sidi, either the politician or the preacher, but he was very emphatic in the way he put it across. That was lovely to have. And I think it's a privilege to have such senior people from WHO with us. So thank you. Any questions? And okay, so you push the red. Yeah, there we go. And just remember, introduce yourself and
Ok,
let's have a
merci.
question.
Docteur Abdelmalik de la Mauritanie. Donc, ma question s'adresse au professeur Jason. Je voudrais savoir s'il existe un référentiel qualité sur les données probantes. Est-ce qu'il y a quelque chose qui permet de classifier ou de coter un peu l'origine de ces données? Un référentiel qualité. Merci.
It's about a quality reference framework for the evidence that we are seeking.
Yeah, thank you very much. Is that Mauritania? Yes, Mauritania. I'm not quite sure I fully understood, but I think the emphasis here is that when we collect the evidence, particularly evidence that is not peer reviewed, then we need to look at the quality of that evidence. For example, if you are referencing literature, for example, where somebody just put out information out there which has not been sort of verified, then you need to be a little careful because if that information is not correct, then you are likely to provide the wrong or not inappropriate guidance to the Minister of Health. I think that's I think the comment here.
Yeah, so maybe it's also about where. Sorry, I've also been told my voice is too loud. Sorry. Where do we put the bar? So what do we include, and what do we not include, and how do we tell the good from the bad apples in terms of so it's about quality control of evidence. Yeah. So how do we know what to include and not to include? But I think you've answered it. I saw a hand over here. Sir, you want to use that mic or this mic? Is that one? Okay.
Okay, thank you, Prof, for your presentation. I'm looking at some resource-constrained environment. How can recommendation of NITAG to the Ministry of Health be implemented where there are scarce resources? Is there any body that can come to assist such country?
That's a tough one. I think even in the discussions in the morning, I think the issue that was coming out is I think we're expecting NITAG to provide guidance to us, but they are not facilitated in most cases. And I think this has been a discussion because the guidance that we give should be independent. So should the EPI or Ministry of Health fund the NITAG? I think this has been the discussion, and I'm not quite sure whether there is any dedicated funding as of now to support the functioning of the NITAGs. I know Gavi had sort of an allocation or some fund to support the NITAG. I don't know whether the colleague from Gavi may want to comment. I know certainly the Ministry of Health do struggle. We heard from South Africa that the Department of Health facilitate meetings, for example, and give some stipends when there is a meeting of the NITAG. But I don't know whether that is the practice across all the NITAG. I think that is really the elephant in the room. And maybe it would be nice to hear from other NITAGs how they function. We had the South African example, but maybe Gavi.
Anyone from Gavi want to respond to that? Sorry, here we go. Use your mic or then? Yeah.
Hi, everyone. My name is Amina Bouthmani, and I'm the program manager for Measles and Rubella program at Gavi. No, that's a really good point. And I think, funding for NITAGs is very critical to the whole immunization system in countries. In Gavi, there are different funding levers that are provided, which are at the discretion of the MOH to use. Some of them indeed can be tapped into strengthening such activities that are led by NITAG in terms of leading decision-making processes and really working on evidence-based research to inform recommendations with regards to immunization programs. So it's really depending on each country how they would want to prioritize the funding they receive from Gavi for which activities, and this is really through the senior country manager at Gavi that this can be discussed in terms of which options are available, how to use them, within which time frame. But again, happy to engage in any kind of bilateral conversations to ask any questions for any specific country context. Thanks, over.
Thanks very much, Amin. Okay, I've got one here and there, and then I saw a forest of hands over that side, so I'll come to the back there next. Sir.
Okay. Moi, je m'appelle Dr Robert Camara du Justice Civil Guinée. Ma question s'adresse à Sidi. Dans votre exposé, vous avez dit de réfléchir sur le repositionnement des programmes de vaccination. Est-ce que vous avez l'expérience d'un programme où on a eu à faire un repositionnement et qui a permis le développement des activités de vaccination? Bien, moi je pense avec tout ce qui existe comme défi, pour moi c'est important, mais ce n'est pas essentiel. Parce que même quand le programme est dans sa position actuelle, s'il bénéficie du renforcement de ses capacités et de toutes les fonctions dont il a besoin, ça peut faire avancer les activités pour lesquelles il est créé. Je voulais juste avoir votre expérience sur cela. Merci.
Merci Robert. Je pense que quand je parle de repositionnement institutionnel, ce n'est pas forcément que le PEV soit plus haut dans l'architecture du ministère de la Santé. Mais le repositionnement institutionnel peut correspondre à plus de ressources humaines qualifiées au niveau du programme de vaccination. Ça peut être aussi plus de points focaux au niveau des provinces, au niveau des districts. Je prends juste l'exemple d'un pays, peut-être Dr Yves va plus en parler, au Bénin, où ils ont carrément une agence des soins de santé primaires où la vaccination est positionnée au sein de cette agence-là. Ils ont plus de ressources et plus d'autonomie financière pour pouvoir gérer les fonds de la vaccination. Par contre, dans d'autres pays, vous voyez les fonds de Gavi avant de venir au programme de vaccination, le circuit que ça prend. Il faut une autorité là-bas qui valide, ensuite d'autres qui valident. Et à la fin, souvent les activités sont retardées, la mise en œuvre financière n'est pas optimale, etc., etc. Donc, en fait, il faudrait repenser l'organisation de nos programmes de vaccination. C'est vrai que c'est une des composantes du renforcement du système de vaccination, mais pas essentiel. Il y a les autres 6 domaines de la vaccination, effectivement, qu'il faut revoir.
Thank you. My name is Dr. Dorothy Esangwedo, Nigeria, NITAG. I just also want to emphasize that one of the main, I think one of the main deterrent to funding of NITAG that we haven't emphasized is the independence of the individual membership of NITAGs. Because, we've been talking about academia, but in the membership, as I know it from WHO, the individuals are supposed to be independent. And that also puts pressure on organizations from taking ownership of funding, because each member is asked to declare their conflict of interest at every meeting. And conflict of interest means what association you have with all these organizations, which may affect your decisions or your contributions to the decisions that have been the recommendations. So I want to suggest, I don't know if I'm in a position to do that, but I want to suggest that this is one area that I think the nations should take ownership. The funding, I believe, is best coming from the country themselves than from organizations, whether be it Gavi or something. But in our country, for instance, we are funded mostly through WHO, and which again is good, is more independent than having specific organization do the funding, because then you have an allegiance to that organization. I don't know what that could mean to this. Thank you.
Yeah, I think one of the objective of this training also is to share experience within NITAX. I know some countries here where I went to for the external assessment. For example, Cameroon. Cameroon now they have funding from, yes, from Gavi, but the government also put money in the NITAC. Because the Minister of Health, they took a decree saying that the NITAC now is a part of immunization program and should be funded by the Minister of Health. That is a very good example. Maybe Tunisia, Morocco, or South Africa will give example also, like Mauritius. They fund their API, so, and Cabo Verde also. So I think the ownership of the country start by funding the health system, not only NITAC or immunization, but the whole health system. And currently we are at the area where the ownership for the country's development is at time with all this geopolitical environment. Now it's time for us to take ownership for all our developments, not only immunization. That is the African talking about.
Thank you, Sidi. I think we all agree with that. We've got 5 minutes, and I know there's at least 4 hands. Sir.
Alors, je suis Dr Abid, pédiatre, NITAG, Morocco. Ma question est la suivante. On parle de stratégie nationale. Le fait d'avoir des preuves, des données probantes, de bonnes preuves en faveur de la vaccination, on oublie actuellement de parler des maladies. Je vous donne un exemple. Nous, on n'a plus de polio et la rougeole, on ne l'a pas vu pendant 20 ans. Et les pédiatres, les médecins, les médias, tous disent pourquoi vacciner puisqu'on n'a plus de rougeole. Et à l'occasion de Covid, la couverture a baissé et on a été submergé par la rougeole. Parce que même les médecins actuellement, les médecins qui travaillent actuellement, n'arrivent pas à diagnostiquer la rougeole puisqu'ils n'en voient plus. Donc il faut qu'on continue à parler de ces maladies, de leur coût, de leur gravité, de la mortalité, pour garder la population, les médias et les décideurs en éveil vis-à-vis de ces maladies. Et ça, les NITAG, il faut qu'ils y pensent durant ces 5 journées. Je vous remercie.
Thank you, Professor. Thank you. And let's take the other one from Morocco, and then we'll respond.
Merci beaucoup. Ma question est pour professeur Jason. En fait, j'ai un commentaire et une question. Donc, il a partagé avec nous un certain nombre de sources d'informations. Je pense que le GNN fait partie de ces sources. Donc, c'est parce que c'était volontaire de votre part de ne pas citer ce Global Network for Immunization. Et ma question, vous avez recommandé un certain nombre de
de sources d'informations fiables et reconnues. Alors, si on renverse la question, est-ce qu'il n'y a pas de sites ou de sources à ne pas consulter, à être prudent à les consulter? Voilà, merci.
Thanks very much for those questions. I think that's probably all we're going to have time for. I'm going to ask both Jason and Sidi to respond. And then I think we're going to have to wrap it up. Otherwise, I'm going to be stealing time from the next session. Prof?
Yeah, thank you very much. I think, yes, that was an oversight. I think GNN is one source of information, very important source of information. Thank you for that. That's a global NITAG network. Also has a lot of information that might be useful to the NITAG. The second question was about no, that was.
C'est toujours pour vous. Vous avez recommandé un certain nombre de sources d'informations fiables, SAGE, CDC et autres. Est-ce qu'il y a des sources qu'il faut éviter de voir?
That's again a very important one. I think what comes to mind is the social media. I think a lot of people now depend on this. And I think it's something that NITAG really need to be aware of. A lot of information that is in the social media may not be accurate in most cases. So I think it doesn't mean that that information is not useful, but I think look at it, but then verify. Because most of the information that you see in the social media is from people who are not experts in the field. And for the NITAG, you really want to have solid evidence and information that informs the discussion and the recommendation that you make to the Minister of Health. And the last thing you want is to be able to make the wrong recommendation for the Minister of Health, because that will have major implications. So the social media, you may look at it, but then you need to verify. Maybe a quick one on the comment that was made, I think, by your colleague also from Morocco about making sure that we don't lose track of what we are doing. For example, if we say we have eliminated one polio, for example, that is not the end by itself. You saw the targets that Cindy was showing in terms of the coverage. What are the global targets? What are the regional targets? It doesn't mean that the countries that have achieved those targets, then we sit back and forget about them. No, because there could be a resurgence of those diseases. And we've seen diphtheria, for example, where I think the last 2 years we've had outbreaks of diphtheria almost, in Southern Africa. There was, I think, Nigeria, Niger, and other countries. So it's very important to make sure that even when we have achieved the targets and the control or elimination or eradication of those diseases, we still have to maintain the surveillance to make sure that if there is any increase the number of cases, we are able to pick them and making sure, because coverage is one thing, but there could still be some sporadic outbreaks of some of those diseases. So that's, I think, a very important point. And I think NITAG could also help here in terms of really making sure that as we interact with the Ministry of Health, we really keep emphasizing the need to maintain and sustain high quality surveillance for vaccine preventable diseases. Thank you.
Thanks, Prof. Sidi, any quick comments?
Non, c'est par rapport aux évidences, la qualité des évidences pour le GTCV, c'est fondamental. Quand il y a un doute sur la qualité des évidences utilisées par le GTCV, ça peut plomber tout le travail. En plus de ça, comme l'a dit Dr Assem Beno, les conflits d'intérêts doivent être gérés de façon claire, de façon limpide au sein du GTCV pour pouvoir éviter toute mauvaise interprétation des recommandations du GTCV. Et ceci pose la question de l'indépendance, bien sûr, du GTCV. Et quand on parle de l'indépendance, pour garantir l'indépendance, pour éviter les conflits d'intérêts, il faut que les États mettent les moyens dans les GTCV. J'ai l'habitude d'utiliser l'aphorisme Pourquoi, si vous avez un Rolls-Royce, vous allez utiliser des 2 chevaux pour conduire votre programme? Vous avez des universitaires que vous avez mis ensemble pour former votre jet CV, mettez les moyens pour qu'ils puissent travailler et vous fournir les bonnes preuves pour conduire votre programme de vaccination. Merci.
Thank you very much. Can we have a hand for all 3 speakers? And I'm being told that Edina is ready for the next one. Thank you very much. Dr. Edina Amponza da Costa. I got it right. Thanks, Edina.
Okay, so I'm back very quickly to introduce the Cameroonian NITAG who will be presenting. Can I find out who's presenting? Ah, okay, we have a person. Thank you very much, sir. And the questions for the Cameroonian NITAG will come from Gambia. Second question from Mauritania. And the third question from Morocco. So please prepare to ask them some questions. Over to you. A round of applause, please.
Good morning to everyone. So I'm Dr. Nibungo. I'll be presenting for the National Immunization Technical Group of Cameroon. This is a template we're given, so I'll just go on and talk about the different items that we are supposed to present on. So the NITAG of Cameroon was created in 2018. It's worth mentioning that we had a scientific committee in 2006, which was somewhat managing the affairs of the advisory role that NITAG is playing today. But NITAG, as we call it today, was created in 2018, and the members were appointed in 2018 as well. So we have 16 core members for the NITAG, but also we have kept with us all those who have been playing an active role in the past, including those who were members of the scientific committee. So you have what we call ex officio members. There are 6 of them. We have auxiliary members who come from various organizations. We have the technical secretariat made up principally of the central coordination of the EPI. We have one honorary president who has been there for many years, and so the experience of this honorary president is also called upon regularly to advise the NITAG and other honorary members. As far as the last 6 months are concerned, we do not have any new members that have joined within the last 6 months, but in the past year, we've had a couple of people who have joined. And the members who are trained on ATR, we have 8. We are expecting to expand that number to include all the members of NITAG. And so when I'm talking about the 8 on 16, I'm talking about the core members. But apart from the core members, the members of the Secretariat as well are part of these. And so we have at least 6 members of the Secretariat who have been trained as well in that aspect. So the recommendations in 2024 that were made by NITAG, we have a recommendation on measles rubella vaccine switch. I think a lot of people who have talked here have talked about switching from 10 doses to 5. Cameroon is looking into that. And so in 2024, again, we talked about multi-cohort catch-up of HPV vaccination for girls and boys. It should be noted here that Cameroon, I think, is the only country in Africa that's currently vaccinating boys for HPV. And so after the introduction in 2020, Tunisia as well. Oh, Mauritius as well. So we are with Mauritius on that. Thank you very much. So after the introduction in 2020, it was timid. And so the NITAG recommended a multi-cohort catch-up of most of the children who had been missed since after introduction. We also have had a recommendation on the introduction of MEN5, which is also another aspect that was touched here a bit. And the organization of the measles rubella catch-up follow-up campaign in 2026, which is what we are currently planning. And but we have another aspect in this, which is a serosurvey, which is going to be added post-campaign. We think that's an important aspect as well to look into to help us understand the cyclical nature of these epidemics and how to fight them. As far as Mpox is concerned, we want to concentrate on high-risk population, especially healthcare workers and those within the areas where epidemics have been declared. And our ongoing questions, we talked about the big catch-up here. Cameroon is one of the countries that has been implementing the big catch-up. And so one of the important things that the NITAC has been talking about is how to really identify, reach, and monitor the work that is being done on the catch-up of these children. Remember, we talked about 50%, and so we want to vaccinate them, but we also want to monitor and know how many of these children have been reached, and so we can determine how much more effort we need to put to cover the rest of them. And about operational research, we are looking at especially the new vaccines that have been introduced post-2020. When we're talking about the level of coverages here, we said 70 to 80%, principally because vaccines like the second dose of measles rubella, we are still lagging behind in terms of the coverage. So the NITAG took particular note of that and said, we need to look at issues of equity, coverage, economic value of vaccination, especially looking at some of these aspects. So the operational research is supposed to generate enough evidence to help us in this light. So what are our planned policy questions for 2025-2026? We want to scale up malaria vaccination, which is from the 42 districts currently vaccinating against malaria to include more districts in the country. And so the NITAC is looking at that aspect as well. We're looking to switch from pentavalent, now the pentavalent vaccine plus IPV to hexavalent. Partly the question on that is to increase adherence of parents because the number of injections are increasing in terms of each visit that a child comes. And so the NITAG wants to look for ways to cut this down as much as possible without having any negative impact in terms of the quality or the immunity that these children can develop from these vaccines. We have also to switch from PCV13 to PCV10. This is mainly a matter of cost. The amount that is spent on PCV13 really drags us down. You know, since Gavi has not yet given its okay for the introduction of HPV in boys, this vaccine is purchased by the states. And so we are looking at all possible ways to cut down costs that will help boost the finances that are available at the level of the country to help in covering the other gaps that we still have. Now, we joined the Global NITAG network with the creation of the NITAG in 2018. So in terms of the SWOT analysis, we have the core members come from all specialties. And then I mentioned that we are bringing a lot of other people, including ex-officios, because we want that at every discussion, we have those who are experts in each specialty being available to give their opinion and guiding the NITAG in making good decisions that we can present to the minister and be converted into policy. The NITAG, like Dr. Sidi said, has been integrated as part of the immunization, an independent body attached to the vaccination program. And so as such, the government as well has certain responsibility towards this organ. There is sustainable financing with a dedicated budget line for NITAG, including for honorariums. There is a mandate of the NITAG encompasses all areas of immunization program. This is not just limited to the EPI, I must say. The EPI in Cameroon is mostly childhood vaccination, but the NITAG covers even adult vaccinations, so they cover all the questions on immunization. We have a dedicated secretariat, which is the central coordination of the EPI, and the NITAG operates independently of the Ministry of Health as well to reduce bias and external pressure. But there are weaknesses like the insufficient generation of local data to support our decision making, challenges in accessing high quality data, which we are hoping, of course, with this collaboration we're going to have here, that some of these issues we are raising here would be easily solved by being members of this great network. And donor dependency as well. We talked about financing that comes through Gavi. That can be a potential situation, but which is being dealt with also by the allocation of budget by the state. So we have opportunities, financial and technical support that we've been receiving from various partners, capacity building of NITAC members on their roles and responsibilities, and even on the ETR processes. Yeah, that has really picked up since last year, and we are hoping to cover a lot of that this year as well. The training of the technical secretariat, we want to ensure that the technical secretariat is fit and able to carry out their role. And then partnership with other African NITACs is one aspect that we are really hoping is going to boost the work of the NITAC in making good decisions and all. And that beyond childhood vaccines, the NITAC also advises for adult immunization. Now, one threat is, of course, the over-reliance on some external funding, which could impact issues of autonomy and so on. As far as the key expectations are concerned, I think a presentation was done on that already, and it covered the key expectations that we have for this fourth AVCN. And we try to provide a bit of feedback on this table that was given to us as well. In summary, that's what we have for you as Cameroon NITAC. Thank you.
No, you stay. Thank you very much for that. That was a very powerful presentation and really insightful to hear about all the great work that the Cameroonian NITAC is doing. I spotted that you have a health systems analyst and a geriatrician on the NITAC, which I think is very, very impressive. So we'll start with a question from Gambia. We have 5 minutes for questions. Sorry, where's Gambia? Ah! Do you have a question for our colleague?
Thank you very much for the presentation from Cameroon. We've actually learned a lot from it. My question is on the 10-dose switch from MR to 5-dose. I just wanted to know if you did an EVM assessment, which for especially logistics and waste management, because this is one of the questions that Gambia would be receiving later on in the year, and we're very much concerned on waste management and logistics. Then the other question is on the HPV vaccination. What kind of strategy are you using based on the fact that it is not routine, with most of the children being 10 and 14, that, I mean, they would not come into the facilities to collect the vaccination? The last question is on the malaria scale up. Gambia just, with the NITAC, just recommended the vaccination, but our main concern is the vaccination coverage and dropout rate, based that, I mean, it does not conform with the routine immunization schedule. Thank you.
Okay, thank you, Gambia, for those questions. So the first question on the switch of 10 doses to 5 doses as far as the MR vaccine is concerned, we did an analysis of the logistics aspects, and we think that given the current capacity of logistics at the right down to the operational level, we will be able to handle that. But also, I should state here that we are trying to handle another issue, reducing from 10 to 5. You know, in the health facilities, when there is one child, because what we've said is that they vaccinate children when they come, even if it's just one child. But knowing that this is one of the vaccines that cannot be kept after 6 hours, it creates a big situation for us. And so that's why we attribute some of the low coverages of especially the second dose of measles, rubella to some of that. And so we want to solve that problem. That's the reason why switching from 10 to 5 is going to be very beneficial to us. But for the logistics aspects, currently we can handle the logistics that goes with an increase in the number of doses and all of that that will be stored in those health facilities. Now, the second question is on HPV. which coincidentally is one of those areas where we've had a lot of difficulties, but also we've adapted a lot. I think one of the things that really brought a change between 2020 to 2022, when we introduced the HPV vaccine, we had lots of issues. But moving to gender-neutral vaccination really led to an increase in the coverages, both for the girls and the boys. And so the coverages we had for the boys for the first year was significantly more than what we had for the girls in the first 3 years of introduction. And so the new gender-neutral aspect helped us in communication, because a lot of people were worried. They are used to childhood immunization, but suddenly we show up with another one that's supposed to be given to girls of 9 years, and they start asking all these questions, and the misinformation was really, really bad in the case of HPV. And so extending it to boys has been a plus for us. But as far as the other strategies are concerned, we do a bit of actually vaccinating of children in health facilities, like for the other vaccines. But in addition to that, the school strategy has really helped us also in terms of improving on the number of girls that we meet. So we go to schools. First of all, we communicate with the authorities of basic education, the authorities of secondary education. We go and target those schools. They pass the information to the parents as well. But in 2023, one other thing we did was a major campaign where we had communication with the authorities, both religious authorities and local leaders. And so the buy-in of the religious authorities and the local leaders has been key in helping Cameroon to improve on HPV vaccination. Recently, I think it was just last week, we had a meeting because we had a lot of resistance, especially coming from the Catholic Church. And so we had the health authorities in each diocese of the Catholic Church. We had a meeting with them, which was initially just to talk about vaccination in general, but they brought the issue of HPV on the table. We were hoping for that. And so when they did, we had a very good exchange with them, and they are going back to discuss with the bishops, the archbishops, to see how we can have a breakthrough in those health facilities, in those schools, and so on. Now, with malaria vaccination, I think I missed the...
No, my question was that do you actually have a high dropout rate, considering that the vaccination is outside the routine immunization? Because we are about to introduce, and this is one of the problems that NITAG was looking at.
Yeah, thank you very much. And so that's also one area where the NITAG has really been having some kind of a back and forth. You know, in Cameroon, when the vaccine was introduced, we took the first dose is 6 months, second dose is 7 months, and the third dose is 9 months. The fourth dose is going to be 24 months, since we've not yet reached it, but that's when the fourth dose will be given. Now, the 6-month visit is not a regular visit for EPI, but it's true that for 6 months, children used to come for their vitamin A and other things, other controls at the hospital. But the one that was really new is the 7 months. And so everyone is used to coming during the regular visits. Now suddenly they have new visits that have been included in their calendars, and that has been very difficult, especially for 7 months. And so we realized that for the most part, the second dose is administered at 9 months, for the most part. And so that in itself has gotten the NITAG to come back to the question and have a discussion on, should we modify, should we leave it like that? But what we have decided to do first is to organize a campaign of sensitization. And with the campaign of sensitization, we've realized that even the 7 months, people are beginning to come. Now, is that going to be sustained to the level where we would have to maintain it like that? But of course, it's evidence-based, so we are looking forward to really seeing how much evidence will generate that will help us make that decision. But you can start with a lot of communication.
Right, excellent. There is, so unfortunately, the Gambian NITAG had all the questions, and they took all the 5 minutes that we had. But perhaps I can take a quick comment from you, Imen, and then also from you, just very quick 2 comments.
Thanks so much, Edina. I'll try to be as quick as possible. A few comments and a few questions. I'm very grateful to work with the Cameroon EPI team very closely on the MR program. I had the honor to meet Dr. Shalom last week during WHA, and we really engage in conversations such as the upcoming switch application, the upcoming campaign, application submission this year for that. But just to be quick, so I mean, as you know, Cameroon is currently facing a measles outbreak. So we are also working with them on the outbreak response fund request. So I'm wondering, from a NITAG perspective, how involved are you, and under which kind of mechanism, or how do you engage with the EPI team in terms of the outbreak detection and response and the data surveillance systems, particularly in this context? And what we see usually is basically outbreaks happen, of course, because of the low coverage, but a lot of this is attributed to, you know, timeliness and readiness in the preventive campaign. So, you know, it's usually a few months here and there before the launch of a campaign where, you know, we have increase of susceptible individuals, and therefore, you know, outbreaks occur. So I'm just wondering, to what extent is there like pre-campaign monitoring to ensure there is timeliness, so that you know, and your role as NITAGs in terms of modeling that and understanding that and guiding the EPI and other immunization stakeholders. And then two other points, sorry, very quickly, in terms of routine strengthening, particularly referring to the second year of life, you know, part of the activities in the context of increasing the MR second dose coverage is definitely linked to what efforts are being done in terms of the second year of life strengthening. And here seeing, you know, Cameroon really committing to the malaria vaccine and scale up, you know, there's definitely the opportunity of the 4 dose of malaria vaccine to be also given at the same time as the MR second dose. So just curious to hear what is being done in the context of the second year of life. And more broadly on the catch-up policy, what we usually get during the independent review committee reviews of applications to Gavi, specifically on MR, is really what are countries doing in terms of catch-up policies? Is there an age limit to vaccinate for measles and MR? And how do you as NITAG guide those decisions? And how is it looking specifically for Cameroon? And final point is, what we're seeing now moving forward in the next few years, especially with the context of funding constraints and the need to really explore synergies and programmatic and financial efficiencies, is really to find ways to integrate vaccination activities. And this is really at the implementation stage, but also all the way leading up to that. So how do you as NITAGs, help shape those decisions in terms of what to integrate, in terms of co-delivery, but also in terms of planning which activities to be integrated? I'll stop here. Thank you.
Thank you, Amina. So Amina, on behalf of Gavi, is responsible for the cuts to our lunchtime. So you will speak to her directly. I'll take a quick question from you as well, and then we'll come back to you for the end. Very, very quick, please.
I'm Professor Amin Hassani from Morocco, and as I know that Cameroon country is francophone, I will ask in French. It will be preferred for me. Vous voulez faire un passage du 13 au 10 valent pour le pneumocoque, le vaccin antipneumococcique, expérience que le Maroc a connue sous d'autres contraintes, non pas économiques, mais des contraintes d'approvisionnement. Est-ce que aujourd'hui vous passez sur du 13 au 10 uniquement sur des contraintes économiques, ou vous avez pu aussi étudier les différents sérotypes et les émergences des différents sérotypes du pneumocoque? Parce que sinon, si c'est uniquement sur un contexte purement économique, vous allez avoir une résurgence de pathologies invasives qui vous coûterait beaucoup plus cher que ne vous coûterait le vaccin. Merci.
Very quick responses, if you can.
Okay, thank you. I'll just start with Amina. So the NITAC really has been working very closely with the EPI as far as organization of the follow-up campaign of next year is concerned. And I understand your question about the epidemics. Usually it was the case as well in the last cycle, where towards the end of 2022, we had a lot of districts coming up with epidemics just before the follow-up campaign. And so that's something that the NITAG is working closely with the EPI program, but also in terms of the response to the epidemics in the specific districts which are concerned now, NITAG has also given its advice, and it's working closely and looking at how that situation evolves so that we prepare the ground for the larger campaign which is going to happen next year. Now, the second year of life, questions on the second year of life are very important for us. Like I talked about the low coverage for the measles, rubella vaccine, we are strengthening a lot of our colleagues at the operational level because you understand that the problem stems from the health facilities themselves where people do not really understand this second year of life properly because people were used to having just the first year of life for EPI vaccination. And so we've done a lot of communication, we've done a lot of sensitization, and we think that information has gone through. But not just that also, we are working closely with all the major societies or committees like the pediatricians and the rest of them who are receiving these children to see how integrating vaccination in the second year of life can be successful. And it has helped a bit in raising our coverages of measles, rubella in the second year. And we think that the malaria vaccine is going to benefit from this work that is already being done before we get to 24 months for that. And the catch-up policy, the NITAG had a recommendation on the catch-up policy in 2023, which was that catch-up is for children less than 5 years of age. That is from 0 to 59 months. And so whether it is the measles rubella vaccine or any other vaccine, we go right up to just before the 5th birthday of the child. And that has been a great success for us as well in making sure that we catch up all of these children who did not previously receive their second dose of measles rubella vaccine, especially in areas where there was still a lot of confusion about vaccination during the second year of life. And integration is one of the aspects we talked about in the catch-up as well, where we have a lot of different departments in the Ministry of Health which are in charge of childhood diseases. So we are trying to integrate vaccination into this, that it's not just going for immunization alone, but we are going and accompanying people who are going for other things, maybe distribution of deworming or any other thing that involves getting to children. And so since they have this access and sometimes some of these interventions are very much accepted in the community, tagging vaccination to that helps us also meet these children. In terms of resources as well, I think that's going to be very helpful in putting all of this together and managing the few resources that are available to make sure that we reach these children. Now, the question pour le Maroc, la question sur PCV 13 à PCV 10, nous avons noté comme aussi une recommandation d'une nation qui a d'abord traversé cette étape. Et pour nous, ça va beaucoup nous aider. Mais il faut dire déjà qu'il y a beaucoup des analyses qui ont été menées en termes de différents types de ces bactéries qui sont censées être couvertes par le PCV13. Et nous sommes aussi en train de regarder sur comment ça va jouer sur cet aspect-là. Mais il est toujours important de dire que comme le NITAG est en train de débattre sur ce sujet, nous recherchons toutes les différentes évidences qui sont là pour nous aider à mieux conseiller le gouvernement sur ce qu'il faut faire sur ce front. Parce que nous avons parlé déjà des aspects de coût, mais il y a d'autres aspects qu'il faut considérer quand nous faisons ce genre de switch. Merci beaucoup.
Thank you very much, merci beaucoup. A round of applause, please, for Cameroon. And I'm just checking in with my bosses. We still have Cabo Verde, but I'm not sure how the room is feeling, whether we should go for lunch or we can take the presentation before we go. Elizabeth? We finish the presentations and then we eat comfortably. Okay, so over to Cabo Verde.
My name is Edith Santos. I'm from Cape Verde. As you see in the first slide, this the group, our group is GTCV, is in Portuguese, is our NITAG in English. The group is there. Before starting, I'm just talking a little about Cape Verde. It's a very small country formed by islands in West Africa with a very few inhabitants. As you see, about 550,000 habitants, and the rate the children's over 1 year old, it's about 1.7% of the population. Over 4 years, 7.3% of the population. We have a hot and dry country, but we don't have that much high temperature. It goes until 30 degrees, but mainly it's 25, about 25. There are islands, as you can see. I'm sorry because I am coming from a respiratory problem and my throat is it's not as clear. We have 6 hospitals in general because we are islands, small islands. We do have to have hospitals in all the islands so we can cover our population, what makes it very expensive for the population we have. We have 2 central in the main cities and 4 regional for the regions. Otherwise, we have 33 health centers, 40 health posts, and 111 basic unities. Those are the basic structures. That's the organization general of the health. Our NITAC, the name is GTCV, é o Grupo Técnico Consultivo para Vacinação de Cabo Verde. O CV está duplicado porque, como é Cabo Verde, é a mesma coisa. We are created in December 2024. As I say, we are a newborn kid, you know, with a high coverage, vaccination coverage in Cape Verde. We have been following the recommendation of WHO, and it has worked until now. So our NITAG is very young, and it's, as you can see, we are just now we are starting. In May, it was officialized by the Ministry of Health. We have 17 members. We all have the first initiating training in October 24, October in 2024, that we had a meeting in Cape Verde. It was a training in Cape Verde, and we all participate. So it was our first introduction to the NITAG system. We have a mandate of 5 years, and we generally meet quarterly, and once in a while, if that an extraordinary meeting if it's needed. So we have done so far 2 extraordinary meetings because we have had a lot of requests. So this is the composition of the NITAG, our NITAG. You know, we have the core members are 8. We have the ex-office 3 members, the liaison 2 members, and the technical secretariat 4 members. As you can see, that's how we are organized. we have a multidisciplinary group, as you can see, with various specialists in different areas. I'm not going to tell them because they are in the slide. Those are the official documents that officialize our group. That's the Ministry of Health. Now, as you can see, it was in. This is the ministers. It was in May 2025. That's why I'm telling you we are a newborn. We are on the process of logistics. The logistics. We have already elaborated our internal regulation procedures. We are formalizing our operating procedures, our SOP. We have already dealt with the confidentiality agreement, with the conflict of interest also, and we are elaborating and finishing yet our work plan for 2005-2026. We already have on hand the introduction of 2 new vaccines in the routine vaccination schedule, rotavirus and pneumococcal. We are switching pentavalent to hexavalent vaccine. And also they ask us to evaluate the possibility of introduction of dengue vaccine. Those are the main questions we have. We already have our plan. Our plan is based mainly that we are going to conclude the recommendation requested. We are going to and monitoring and the implementation and do the surveillance also, because it's very important to know how it goes to work. That's what's going on our plan. We are planning supervision visits, so we can see on local what they are doing, how it's working. We are planning new trainings for this year because, as I told you, it was the first when we first entered in the NITAG system. So now we need more training for people to do best work and make better our partnership with other NITAGs that are, as I see, the NITAGs that are presented here, we have the same problems that they have in some vaccines. So the strengths and weakness, like I told you, we are a newborn, so we don't know yet in work system what are our strengths and what are our weakness. But we can see that one of the big weakness, because we are new and we are still, like I was still telling my colleague, is the problem of funding, how we are going to organize in the NITAG the way the fundings are structured. It's not that we don't have the funding, but the way it's managed. You know what I mean? And in the strength side, I think we are a very, very good group, committed and knowledgeable, and we work no matter what's the other problem. We are engaged in this process, and we really want to help the Ministry of Health in the decision of introduction of vaccines. We do have another positive point we have assessed and the resources from WHO and UNICEF. I can say one of our big strengths that because we buy our own vaccine since 1998, we have been buying our vaccine because we are a middle low income country. We don't have Gavi's support. So all the vaccines we have introduced until now, it's the Cape Verde cover. So now we are going to make a plaidoyer for them to have a budget for us to also to work and help them. So that's one of our target for the future. We have a very specialized secretariat that works very well and help a lot in the organization and getting the documents, etc. We have a very good collaboration with the Ministry of Health and the immunization program. We don't have problem with that. We work in together. So those are the weakness. In times of opportunities, everything is opportunity for us because we're just starting. So we are going to consider the training, continuing training, the access of scientific literature, the support from the NITAG, the other NITAGs, everything. Those are all opportunities that we are looking forward to have so we can improve our work. Threats, like I say, the resources are small, and when the resources are small, the planning has to be cautious because you don't know how you are going to lead with it. And also there is the problem of the political all the ministry, the experience we have. As you know, the NITAGs group have been organizing a long time ago, and for us, we are just doing it. So if I wouldn't say it's not a priority, but it shows something that until now, maybe because we are a small country, with the help of WHO and UNICEF, we didn't have much need for the group. But one thing it doesn't cover the other. So it was really a very interesting point to create the group, and I hope we are going to work for the future. Our expectation, so it's the training, and improve our opportunities, the dialogue with other immunization programs, and etc. Those are the expectations. Like I say, we are beginning. So the expectations are all of them. We have many expectations. So we are going to list them slowly by slowly, and so we can get there. The idea is improving also the national immunization program, identify the collaboration that will help us more. Like here we are training in an English country. We come from Portuguese country, so I hope you are understanding what I'm saying. I'm trying to speak in English so so it's easier for us to talk with each other. But our official language is Portuguese. So I'm here to trying to yeah. So it's a way of identifying also the collaboration with other technical capacity building organization. You also would like to participate in the network of all the NITAG, so we can learn a lot more. Here it's our feedback about the training course. It was nice to go through them. Because it was in English, most of us had to go 1, 2, 3 times to see if we could get all the information. But for me, the most difficult was for searching for scientific literature. For me, that was the training that took me more time to try to understand what's going on. And to finish, muito obrigado.
Thank you so much. And indeed, obrigada. That was very interesting to hear from Cabo Verde. I don't know if there's one pressing question, but perhaps If not, please note your questions down and you can join the team at lunch and chat to them. Ben or CD? Okay, CD.
We will not let Cabo Verde going without a question. Maybe. Non, merci, docteur Edith. Je pense que c'est par rapport au fonctionnement du secrétariat. Je pense que lors de la formation, on avait parlé un peu de voir avec l'Institut de santé publique comment ils peuvent être mobilisés pour appuyer le secrétariat du GTCV. Et je pense que comme c'est un GTCV qui vient de naître, et je sais comment l'équipe du PEV est surchargée, docteur Evelina et son équipe. Donc, je pense que c'est une bonne chose de pouvoir explorer avec l'Institut de santé publique comment est-ce qu'ils peuvent mettre à votre disposition au moins un épidémiologiste, un spécialiste en santé publique pour appuyer votre secrétariat. Parce que je peux vous dire, si on laisse le travail au secrétariat actuel, ça risque d'être très, très compliqué pour eux. L'équipe d'Evanilda, bon, j'ai visité le pays un peu, je connais un peu les contraintes. Ça va être un peu difficile pour eux. Mais si vous avez une source externe, ça peut vous aider vraiment à aller plus rapidement dans vos recommandations. Donc, c'était pas une question, c'était juste voilà, une contribution, une suggestion.
Thank you, CD. Jason?
Yeah, thank you very much, Kabande. This was quite encouraging. A suggestion, because I saw that you are the new kid on the block, because there are other Portuguese-speaking countries that you can maybe through niche twinning, Angola, Portuguese-speaking, Mozambique, for example, where they may have already some of the guidelines translated into Portuguese. Rather than reinvent the wheel, you can learn from some of these other Portuguese-speaking countries. Thank you.
Thank you. Thank you very much. A very important point. Ben?
Mine is a quick introduction. It's like speed dating. Mauritius, are you also working on dengue vaccine introduction recommendation? You've discussed it. It's not part of your policy question. Not part of it. Okay. The matching did not work.
but we'll find
so sorry, because I mean it's not one of the diseases that many African countries focus on. So I think it's very important that if there is a country working on a policy question, and there is another country working on a similar things, especially in such a forum, it's a very good opportunity to get to know each other. But even if you've discussed, please just have lunch together. We understand the date is not my. Okay, thanks.
Thank you, Ben, for matchmaking. And another round of applause for Cabo Verde. So we're going to go for lunch. I'm checking if there are any notices. No notices, so we're going to go for lunch. My one key takeaway is that whether you are a baby like Cabo Verde or a grandpa like South Africa, the challenges are more or less the same. And so it just means that we have to continue to work together. Lunch is served at the restaurant downstairs where we had breakfast. Thank you, everybody, and bon appetit.
So I can pick a brain back then I get I see. Let's go. But I'm learning. But let you know this week, you guys might do the job when I come in. I posted that sounds like five people. This is like 5 words. Like it was like.
It's on now? Oh, okay. Good afternoon, everyone. If everyone could settle down, we are about 10 minutes behind time. And also just ask your colleagues to try head back so we can start and be on time. Is the Cape Verde team back? You're back? Okay. Lovely. So while we're waiting for the rest of the delegates to come back, can we have any questions, any burning questions that you might have had for the Cape Verde team? Because we didn't get to do that before lunch break. Does anyone have any burning questions or even suggestions and comments for the Cape Verde team? Go ahead.
Merci. Je voudrais savoir par rapport aux recommandations qu'ils ont eu à faire, est-ce que ils avaient un rôle dans la mise en œuvre de leurs recommandations? Est-ce qu'ils sont impliqués un peu dans la mise en œuvre des recommandations qu'ils suggèrent aux autorités?
You're in the, okay, so they are asking whether you had an implementation plan for your recommendations and how did that work? Okay, can you use the mic? Thank you.
Like I told you, we just newborn, you know. We are on the process of studying. That's why we showed it so we can get feedback from other people who have already studied the same problems. Okay?
Thank you. Yeah, go ahead.
Merci beaucoup, Mariama de la Guinée. Ma question serait de savoir, parce qu'ils ont parlé de l'introduction future du vaccin contre la dengue, est-ce qu'ils ont beaucoup de cas de dengue ou de chikungunya?
Yeah. Go ahead, Kate, whoever wants to answer.
Boa tarde. Sim, nós, o Ministério de Saúde, a Ministra da Saúde submeteu essa preocupação ao GTCV, mas o país ainda não tem condições para introduzir essas vacinas, a vacina contra a dengue. E o GTCV já está a finalizar a recomendação da não introdução, mas sim de aumentar a luta antivectorial e outras as medidas preventivas.
So there's a clarification to that answer. So the question was, what was the burden or the prevalence of dengue, right?
Yes, I can repeat. My question is to know if you have more prevalence of dengue or chikungunya in your country.
Cabo Verde não tem chikungunya, mas a dengue nós temos tido alguns surtos com uma periodicidade de 5 anos. 5 em 5 anos temos surtos da dengue. Somente dois surtos, sim. 2009, 2018 e agora.
Thank you for that answer, Kate. I think we'll take one more question and then we'll continue with the program for the day.
Merci, c'est Roger du Sénégal. Bienvenue au NITAC bébé. Donc, je voulais demander, avant l'instauration de leur NITAC, quelle était la structure qui s'occupait de la vaccination? quand il y avait l'introduction d'un vaccin, comment ça se passait, notamment lors de la pandémie COVID? Merci.
Nós temos, né, o grupo de apoio técnico, o CCIA, é que as preocupações, os planos eram submetidos a esses grupos e através da situação epidemiológica nós fazíamos as introduções. Esse grupo ainda funciona, mas já não é após a criação do GTCV nós enviamos deixamos essa preocupação para o GTCV e o grupo continua assim dando apoio ao programa alargado de vacinação.
Thank you for the questions and the answers, Cape Verde. Ben, do you want to comment?
Sebiso, were you not supposed to give us energizer before we get started? Because we are a bit sluggish.
So we're still waiting for the rest of the delegates to come back. So we decided to do questions while waiting. Okay, so 2 minutes. Edina has an energizer. 2 minutes.
I do have a quick energizer. So today is a very special day. It is Tsepiso's birthday. And so we are going to sing happy birthday to her. I hope you brought your best voices. Okay. So is everybody ready to sing? Ben wants to say something.
I was hoping we can sing in 3 languages.
In all the languages.
Represented here, Portuguese, French, and English.
Okay, so it's going to be a very confusing experience for you because we're going to sing at the same time in English, in French, in Portuguese, in Afrikaans, in whatever language you. Okay, we'll start with happy birthday in English. 1, 2, 3.
En portugais?
Happy birthday.
Thank you.
The bad news is we're supposed to finish, I think, at 5:30. You'll have to stay on for another hour for singing lessons.
Thank you, everyone. Again, I was going to introduce myself before the energizer, but now you know. So my name is Tepiso, and I'm currently a postdoc with Niche and Vaccines for Africa. Okay, so we will. Oh, before we carry on with the program, Polly wants to know, or the people that do not have name tags, the ones that have their names written in a pen, like me. So Toli has just asked that when you get a chance, just go to her so that she can, sort out your tag for tomorrow. Okay, so we will continue on with the program for today. So we will have Edina continue to facilitate the NITEC presentations. So we will have the Gambia presentation now, 10 minutes and 15 minutes for questions.
Thank you very much. So as Tsepiso mentioned, we will now switch to the Gambian team. who is our presenter for Gambia. All right, so we'll have our presenter speak for 10 minutes, and then we'll have 5 minutes for questions. I'm tempted to open the floor for questions, so any table that has questions for Gambia is welcome to ask them. All right.
Hello, good afternoon. My name is Dr. Hadiba. It's not easy coming on stage to present after a very heavy meal. Now I feel sleepy, and I'm sure some of you are, but I'm just going to be as brief as I could. The Gambia Night was established in October 2015, and currently we have core members that 14, and we had 3 from the Secretariat. Here we put number of members trained in ETR none, but we just realized that we had 1 training that was done in 2021. So the list of recommendations that we made in 2024 was the integrated laboratory-based VPD surveillance, and this include environmental surveillance. I'm happy to say that we have completed this, and it's integrated at the National Reference Laboratory. We also have a cross-country and cross-regional collaboration to support sample collection, transportation, and laboratory assistance. And we have also completed introducing what we call sample referral network, SRN system in the country, whereby this enables samples to be collected in other regions and sent to the reference laboratory or the teaching hospital for further work. A pooling system also has been established from the district level to the National Reference Laboratory. All surveillance trainings are integrated for all VPDs, regardless of funding, whether the funding is from Gavi, from WAHO. So everything is just integrated. So polio measles funds are integrated to include all VPDs. So another recommendation that we made in 2024 was to ensure that all girls between the ages of 9 and 14 years receive at least 1 dose of HPV vaccine, while immunocompromised individuals or HIV positive persons receive at least 2 doses of HPV vaccine. And what we have done is during school vaccination, now we have school cohort that we target that goes to school, and they are vaccinated there. And also we intensify this during the period. So we've made substantial progress, but there is need to improve on caregivers because they need to be more aware and sensitized to HPV vaccination. Don't blame me, I'm too full. So we also need to strengthen advocacy and communication strategies to encourage girls that are not at school to be vaccinated. Recommendation on the big catch-up, we recommended to build catch-up vaccination into a costed national immunization strategy, as well as vaccine forecasting. And this we haven't have a budget for, but it is included during the period when we conducting on the HPV. So another recommendation was to identify innovative and holistic approaches to mapping our zero-dose population, such as using multiple data sources and AI to identify unimmunized and underimmunized children. And we have done GS mapping of 0 and under-vaccinated areas. It is still ongoing, and we're using what we call the e-tracker. So this is just a brief history of what vaccines have been introduced in the country. And we have the VCG and the DPT, measles, and yellow fever, hepatitis B, were introduced between 1978 and 79, and then the rest followed. We have also introduced rotavirus. It's not on the table, we missed that one, but we have. So what are our strengths and weakness and opportunities, our SWOT? Our strength is we have dedicated and committed NITAC members and expertise from different fields of work, functional and active members, and evidence-based approach to immunization policy making. Our weaknesses, we have limited training. The last training was conducted, actually it was 2021, and NITAC activities not disseminated to the public. That means that the public are not aware of what work we as NITACs are doing. So that's a weakness. And opportunities is we have the involvement of two main partners, WHO and UNICEF. They provide us with financial and technical support. We have active participation of the Medical Research Council for scientific support. They've been very instrumental in helping us in the scientific area. Now, the threat is lack of budget line to support NITAC activities and operational cost. And we have limited policy for terminating membership, no written policy on conflict of interest, and inconsistent access to regional information and data. So these are our threats, and we're hoping that this will be remedied as soon as possible. So what are our expectations from this course? So, like I said, we had our last NITAC training, actually the one and only, which was in 2021. And we're expecting that this training will build capacity on new SOP and guidelines, provide opportunities to improve the Gambia National Immunization Program, provide access to data sources, and attain improved knowledge on challenges and opportunities in vaccinology. The team also is expecting to gain from lessons learned and the strength of other countries' national immunization programs. So what are the NITAC questions that we have ongoing? At the moment, we haven't got any from the Ministry of Health. The last one was on malaria vaccine, which the NITAC members have approved. We're yet to start giving out malaria vaccine, but it has already been approved. So what are the planned policy questions for 2025-2026? So introduction of the hexavalent vaccine, to switch from MR 10 dose to 5 dose, and introduction of the MMR vaccine. So the year of membership to the Global NITAC Network was in 2020. So this is the feedback on the niche online courses. We were able to access the basic epidemiology for NITACs. Unfortunately, we couldn't access the other three, so therefore we couldn't put a scoring for them. But yeah, basically that's it, and thank you very much. Like I said. Oops.
All right. Thank you very much once again for that excellent presentation. And of course, this is not a comment on the size of Gambia geographically, but somehow you finished in 8 minutes, short and sweet. So we have about 7 minutes for questions. And perhaps I'll start on my side. I think the one thing that stood out for me was the policy in terms of conflicts of interest, in terms termination of the terms that the NITAC serve. So where is the Gambian NITAC on that, and what is the team doing to sort that out?
We just recently had an informal meeting, and which was pointed out, actually it was picked up by Dr. Umi. So Dr. Umi, we talked about it, and we're going to start working towards that as soon as when we get back home.
Okay, all right. Thank you very
Yeah,
much.
want to add, Dr. Omi? Oh, okay.
But during the process of the formation of the TAG, this issue of conflict of interest has been observed. So that in identifying the TAG members, that has been has been factored in. So really it has been factored in. Yes, thank you.
Thank you so much for that.
Dr. Omi, you want to add something on that?
Questions?
Docteur Abid du Maroc. La question que j'ai à poser, c'est concernant justement la géographie qui unit la Gambie avec le Sénégal. Est-ce que une stratégie différente de l'un du pays ou de l'autre pays risque d'affecter, par exemple, une stratégie d'un vaccin, notamment la couverture vaccinale d'un vaccin que l'autre utilise, que l'autre n'utilise pas? Est-ce que ce problème, est-ce que vous arrivez à le discuter avec vos confrères sénégalais?
Can you please repeat the question for us? Repeat the question for us again.
Je voulais parler de la géographie intime que vous avez avec le Sénégal. Et que chacun a sa stratégie, son NITAG, calendrier de vaccination. Est-ce que la stratégie de l'un ne risque pas d'affecter la stratégie de l'autre, notamment concernant un vaccin, concernant une couverture vaccinale? Est-ce que ce problème se pose? Est-ce que vous le discutez entre vous? Parce que je n'ai pas encore vu la stratégie du Sénégal, mais on le verra par la suite. C'est bon?
Vaccine coverage, because of the proximity of Gambia to Senegal and also the geographical location, if we have using one vaccine for our country and they're using another vaccine, or maybe we're vaccinating and they're not, or they're vaccinated and we're not, do we have that dialogue between the two countries? I'll leave Mr. Jiba, EPI, to answer that. I've been cheeky now.
I know we have a very good relationship with the API team in Senegal. We've been supporting each other when it comes to vaccine requirements. When one area is short, we can support the other with it. But when it comes to implementation of our programs, we are independent. The only area we also come around is when we have campaigns, we relate with each other so that we have cross-border meetings and see how best we can go further to make sure that at least we have a success in both areas. But when it comes to the program implementation, each country is different. They implement their own program. Thank you very much.
Okay, thank you very much. The dynamics for the Gambia and Senegal, we have very open borders. People are intermarried and all that. When we looked at our immunization coverage, there are certain health facilities in the Gambia that are very close to Senegal, and most of the ones accessing it are from Senegal. So you see that during antenatal and maybe the first dose, they would get it from the Gambian side. Then they might go back and get the rest. So our coverages for the first doses in border areas are very, very high. But when you look at the second and the third dose, it is quite reduced. We haven't really put in the data, but we have seen that this is one of the reasons. It might also be the same in Senegal as well, because people are intermarried, they come and go. My grandfather is from Senegal, so half of my family are in Senegal. Thank you.
Thank you very much for that. Just confirming if perfect. There was a question here, and the second one was at this table, and then here. So 3 questions.
Voilà. Merci beaucoup. Moi, c'est Dr. Chimère Diaw de l'OMS. Je voulais, en fait, je voulais un peu revenir sur la question qui a été posée par rapport à la collaboration qui pouvait exister entre les deux pays. Je pense que c'est une dynamique qui doit être un peu plus globale. Non seulement le Sénégal doit travailler avec la Gambie, mais doit travailler avec la Mauritanie, la Guinée,
Et parce qu'en fait, on a les mêmes réalités. Et c'est les personnes bougent d'un pays à l'autre. Et souvent, quand on voit une épidémie dans un pays, au bout de quelques temps, on le voit dans l'autre pays. Donc, pour dire que vraiment, on a les mêmes réalités, nous gagnerons à travailler dans un cadre sous-régional, essayer de voir comment intégrer les différents NITAC, ou bien avoir au moins un cadre de collaboration sous-régional qui peut permettre un peu d'aborder de façon beaucoup plus globale ces questions liées à l'introduction des nouveaux vaccins, aux couvertures vaccinales, mais également voir comment il faudrait travailler ensemble. La question que j'ai, c'est quand est-ce que vous comptez introduire l'hexavalon? Parce que le Sénégal va introduire en demi-juillet. Quand est-ce que la Gambie compte introduire l'hexavalon? L'autre question, c'est par rapport à la rougeole. Vous allez passer de 10 doses à 5 doses. Qu'est-ce qui motive ce shift de 10 à 5 doses? Voilà, merci.
Okay, thank you, the Gambia team. Mohammed Mashim from Nigeria. My first question goes to your malaria vaccine, which the NITAG has approved, and whether it has been introduced. If introduced, what were your experiences in terms of dropout between first and second dose? And if you had that serious dropout, what are your strategies to reduce a dropout between second, third, and probably third and fourth? Then the next question I also want to ask is, in your next steps, you want to switch from MR10 dose to MR5 dose, and you're also preparing to introduce MMR. So won't this be a double work at the same time? If you are preparing to introduce MMR, I think it will be advisable for you to focus on how you can optimize the MMR rather than switching from MR10 dose to MR5 dose now, and in the next few months, you are now introduce MMR. Thank you, and over.
My name is Prof. Meiro Hassan. I'm from Nigeria. My question is also related to malaria vaccine. I'm really interested in how you went about your vaccine, what you have chosen, and what is actually the duration of immunity of the vaccine you have chosen, and what who are actually your targeted end users. Thank you.
Yes, thanks. Just a first question I had on the MMR vaccine also from my side is, so I'll be curious to hear like the decision-making process steps that you took to think about the decision to introduce MMR. If there are other countries in the region that have done so, which I'll be curious to hear which are these. But also just a flag from my side that the MMR vaccine is not funded by Gavi. So Gavi only procures the measles and rubella, not the measles, mumps, and rubella. So if the country will need to introduce it, it will need to be self-procured. Thanks, over.
Thank you, Amina. So we've actually run out of time, but I would really appreciate you touching on those points, and the rest of the team, please.
Yours was and the malaria vaccine. We have not introduced it yet. We looked at it as NITA members and gave the approval that it should be, API should go ahead introducing the malaria vaccine, but we're yet to start it. Dr. Obi, you were writing. Do you get the other questions? I think Senegal said something important that we should try to have that collaboration between the two countries, not only Gambia and Senegal, but Guinea and Morocco. the other countries within our sub-region. I think it is very important, and it is something that is doable, so that each country, even we're independent of how our EPI works, but we can work together. That shouldn't limit us. And like my colleague said, Dr. Umi, sometimes you have Senegalese coming to Gambia for some certain services and Gambian going to Senegal for certain services, because like she said, his grandfather is Senegal, both my grandparents are from Senegal. So it is kind of the same country, you know. So I couldn't remember the rest.
Okay, thank you very much. I'll first start with the malaria vaccine. NITAC has made approval, but we have not introduced yet. It was a very tough decision because the data we had in 2018, by the time we went in for the approval in 2022, 2023, the data has shifted. The target has shifted as well. So for now, we're only introducing NITAG approved introduction, phase introduction in about 3 districts. Initially, it was for 15 districts, but we saw that the other districts, the coverage was quite high for the other malaria innovations. So the data only reflected on 3 districts. The target is 6 to 18 months, and that was why I asked the question to Cameroon, because we are looking at the routine immunization services, and some of them are outside that routine immunization. So we haven't really introduced, but we are seeing thinking that we might have a very high dropout rate. Then the choice of vaccine was the RTS, and the second choice is the R21 that we looked at. And we are looking at the 4 doses, 6, 7, 8, and 18 months. Then I think for the other question was the MMR. This is a question we think might come up. It's not brought yet to the NITAG, but EPI has been reflecting on it, because we started seeing cases of mumps. I think of recent, even 2 weeks ago, we had an outbreak with about 17 suspected cases and 3 were positive. So, but it's a question that we're expecting from EPI, but we haven't really looked into it. You're very, very right. I mean, it's not covered by Gavi. And then at country level also, the funding for vaccines from the government side is usually very difficult. So it's something that we really have to look into. So I think the question would be looking more into MR, 10 dose to 5 dose, rather than the MMR. Then I think those were the questions. Maybe he can comment.
That's one question on immunity and how long it can protect that I wanted to answer. So the vaccines that she mentioned, they can protect. They can protect at 20 to 30%, and then it can take something like 2 years. So that's why in the Gambia we are using children from 0 to 5 years. So believe that, like, if you give them the vaccines, you can protect them for at least 2 years.
Okay. We've actually, I've stolen a lot of time from the next session, but it just goes to show that there's a lot of interest, and perhaps we need additional discussions during lunchtime and tea time. Senegal and Gambia NITAGs need to sit together, and Mauritania, to have discussions about what's happening in the region. So unfortunately, I'm going to close this now, but I want to thank everyone for all your engagement, and the Gambia NITAG for wrapping us off for today's NITAG sessions. And with that, that'll be it from my side today, and I'll hand over back to Tepiso.
Thank you, Adina, and the Gambia team, and the rest of the delegation. So next, we will have Dr. Tasha Gloek, who works for the South African Medical Research Council, or SAMRC. She's currently a senior scientist with the SAMRC. And she is a medical doctor by training and holds an MSc in clinical epidemiology and also a postgraduate diploma in health economics. So a lot. and currently working towards her PhD. So she'll be giving us a talk on using grade for NITAG decision making.
Good afternoon, everyone. Move this over a bit. Okay, I hope everyone can hear me. My name is Tasha Gluck. As Chafiso said, I am a medical doctor, and then I fell in love with public health and evidence-informed decision-making and guidelines, and that's what I'm doing my PhD on. But today I'm going to be talking to you about grade and why grade matters for your NITAG decision-making. So this is just the statement from the South African Medical Research Council in the vein or trying to work towards transformation after the atrocities of the past. So these are my disclosures and my acknowledgements. I won't stay too long. So we're going to start with a case study that is fabricated for learning purposes. So there have been several cases of mpox in 2 of the provinces of South Africa with growing fatalities. The Ministry of Health requires guidance on vaccination and has approached the NAGI or NITAG for advice on mpox vaccine recommendations. There are 2 vaccines available currently, and results of some vaccine studies are shared with you. So first, you have a meta-analysis of 2 randomized controlled trials, which shows that the MVA-BN vaccine reduces the risk of mpox infection by 25%. Then you have an RCT, which says the vaccine has no effect on the risk of infection. You then have a single-arm prospective cohort study, which says the vaccine reduces the risk of infection by 40%. And then you have an expert vaccinologist who's been practicing for over 20 years who says the vaccine reduces the risk of mpox infection and death. So if it were up to you and you were making the decision, which do you think you would want to rely on? Which source of evidence? Anyone? Meta-analysis. Great. So what if I told you that in the meta-analysis, both studies had high risk of bias, significant heterogeneity, and they were funded by a pharma company? What if I told you the randomized control trial was a very small sample size and had wide confidence intervals? What if I told you the single-arm prospective cohort was large and well conducted from one city? And the expert vaccinologist works for the pharma company. So that's the point. We need to assess the certainty of the evidence. It's not only about what it is, a meta-analysis, systematic review, it's about how certain you are in the evidence. So I'm sure you have all seen this, and there's definite merit in this hierarchy of evidence, but it is not the be-all and end-all. You have to consider how certain you are. So what do we mean when I say certainty of evidence? We're talking about magnitude of effect, and we're talking about how certain we are about the evidence. Magnitude, there's 80% chance of rain. Certainty, I'm 10% sure I know what I'm talking about. Okay. So today what we're going to talk about is we're going to look at grade and how what its role is in evidence-informed decision-making. We're going to look at the steps of using grade for systematic reviews, specifically how to develop an answerable question, because if you don't have a good question, you're not going to get the answers that you need for your question. And then we're going to look at rating the importance of outcomes. And then I'm going to just briefly look at the role of the grade evidence to decision tables for supporting decision making. We don't have a lot of time and we are running late. So if you do have questions, jot them down and find me at T, or you can email me. Okay, so the grade approach. Beginning in the year 2000, the grade working group developed the single transparent system for grading the certainty of evidence and making decisions. And at the moment, there are over 100 organizations using grade. It's a systematic and transparent way of rating the certainty of evidence in systematic reviews and clinical practice guidelines, and also in developing and determining the strength of clinical practice recommendations. So if we have a look at health decision making, we've got the NITAG. Then the NITAG has a question. They formulate a question. They choose the outcomes that matter to them. They rate how important those outcomes are. And then they hand it over probably to the methodologists to look for these outcomes across studies. The methodologist would then create an evidence profile within GradePro, looking at all the different results and the different summary of effects, which I'll explain shortly. And then they would rate the quality of evidence for each outcome. So it's on an outcome level, not on a study level. Okay, outcome as in death, mortality, morbidity, hospitalization, whatever. So that evidence can be high, moderate, low, or very low quality. And then you can improve that by either grading it down by looking at the risk of bias. All of these I'll explain a little later. Inconsistency, indirectness, imprecision and publication bias. Or you can, specifically with observational studies, because we all know that's often what we get a hold of, there aren't always trials, you can also grade it up. So observational study starts automatically at low quality, and then it can be graded up if there's a large effect or there's a dose gradient response or there's opposing bias and confounders. But basically what happens is the methodologist will come to you and say, here's the evidence, this is the certainty of evidence, and there'll be an overall grading of the quality of evidence across outcomes. And then that is where decisions can be made, and from there we go to the evidence to decision table, which is where we take in all the different contextual factors, such as quality of evidence, benefits and harms, values, preferences, resource utilization, equity, which I'll also speak about later, and then a recommendation is made. There's your recommendation. Okay. So, grade for reviews. There are 5 steps when you're conducting a systematic review using grade. First, you formulate the question. I know it seems simple, but actually it's the most important part, because if you get your question wrong, you're just going to waste your time and go back and go back and go back. So formulating the question, choosing the outcomes, and rating and ranking how important they are. Because if you have a list of 15 outcomes and you have limited resources, you can't look for all those outcomes. You need to decide which are the most important. Okay, then you would extract the outcomes and then you would review the evidence. So for formulating the question, we use, for intervention questions, we use the PICO format, which stands for Population, Intervention, Comparator, and Outcome. And this is central to grade because it helps to limit the scope of the project. It helps to specify our search strategy. It helps to guide your data extraction. It helps to formulate your recommendations. And a priori PICO questions limit the risk of selection bias. So in other words, you're not looking for specific evidence to answers you already know. You're asking a question and seeing what evidence is out there to avoid bias. Okay, so here's an example. See if you can pick out the PICO elements. Many people have been talking about how much better typhoid conjugate vaccines are for preventing morbidity and mortality of typhoid fever in children under 5 compared to the older polysaccharide vaccines, and they're also safer. Your NITAG wants to know how much truth there is in this. So what are your PICO elements? What is your population, your intervention, your comparator, and your outcome? So there's a thing again. So just think to yourself, what is your population? What is your intervention? Ah, you guys are switched on. Yes, okay. So your population, children under 5. Your intervention you want to know about is typhoid conjugate vaccines. Your comparator is the polysaccharide vaccines. And your outcomes are morbidity, mortality, and also safety outcomes. So there's your PICO. And from there, you can formulate your question. In children under 5 years old, do typhoid conjugate vaccines compared to the polysaccharide vaccines prevent morbidity and mortality due to typhoid fever? So there you've got a specific, nice question that you can then go and investigate. Okay, we'll do a little practical exercise on that just now as well. Okay, when it comes to selecting outcomes, you need to look at what the perspective is of your panel. Is it public health? Is it programmatic? Is it coverage? Is it individual, clinical? Then the outcomes should be important for people affected by the decision, not only those making the decision. And just a little caveat there, we should be having patient representatives on our NITAGs or on any decision-making panel to hear their voices as well. So grade then rates the quality of evidence for each outcome separately, and the source of evidence may be different for different outcomes. The same source of evidence can provide varying quality of evidence for the different outcomes. So for one outcome, death, obviously you're not necessarily going to get that much bias in recording death. You're either dead or you're not. But when it comes to subjective things like whether a child is experiencing pain from the parent's perspective, maybe that'll be different, even if it's the same study. So you have to assess at the outcome level. Okay. Then we choose the important outcomes. So you've identified a list of outcomes in advance. You need to look at which ones are important to the patients. Is there data around it? You need to include outcomes whether you know that there's data on it or not. And then you need to describe the outcomes. So how you would measure it, the scale, the timing. Details are important to avoid bias. Then when you look at rating the importance of outcomes, this is basically the table that GRADE has put together where from 1 to 3, it's not important. So let's say you've got, I had a little exercise, but we're not going to be able to do it. But basically, let's say you've given a whole lot of outcomes and you have to decide on a scale from 1 to 9, which is the most important, where 1 till 3 is not really important, 4 till 6 is important, and 7 till 9 is critical. So as a team, you would then decide which of the outcomes are the most important. And usually those, we do 7 or fewer just for the sake of scope and time. And we only do the most critical and important ones to guide our research. Okay. Then the methodology team would extract the outcomes from the papers that they find. I won't spend too much time there. But then you would review the evidence. So the question for this specific forest plot was, in people aged 6 weeks to 60 years, do typhoid conjugate vaccines compared to polysaccharide vaccines prevent morbidity due to typhoid fever? It's just one study, as you can see. But basically, the forest plot will tell you the magnitude of the effect, as you can see there circled, but it doesn't tell you how confident you are in the effect. So that's where we then move on to grade and interpreting the certainty of the evidence. So as I mentioned before, there are 4 levels of certainty or quality, high quality down to very low quality. If it is high quality evidence, we are very confident that the true effect lies close to that of the estimate of the effect. In other words, what your forest plot or data is showing you, we're very confident that that is true. Okay? Very low is we actually don't know, or we have very little confidence, and moderate and low are in between there. When we are then looking at your evidence, so let's say we have a question about mortality and we've got 7 trials, we want to assess for that outcome of mortality, what is the certainty of evidence? You have to consider 5 things. 1, risk of bias. Were the studies well conducted? So just doing an appraisal of a paper is not actually enough. That's only one domain, okay? So if, let's say, the studies weren't well conducted, you could lower the certainty by 1 or 2, depending how bad it was. So for example, with this one, you can see there's 2 domains that the risk of bias is high risk of bias. Those little red dots, I don't know if this is working. So we did write down for this specific one for bias. Okay, then there's inconsistency. Do the trials find different results? So you have one trial telling you that the typhoid conjugate vaccines prevent death, and you've got another trial saying, actually, no, they cause death. That's high heterogeneity, inconsistency. Then indirectness is about how were the trials done and who. Let's say you want to know about children. Indirectness, if you have a trial that only looks at adults, you're going to be concerned about indirectness there. Then imprecision is around whether the result is statistically and clinically important. There we often look at the confidence intervals and whether they are crossing the line of no effect. And then also, is there any suggestion of publication bias? So were there studies that were left out or maybe not published because the results were not what journals wanted to publish? That's something we have to look at. Then there's also looking at factors that increase quality. So that can be, you've got a cohort where there was a large magnitude of effect, or there was opposing plausible residual bias or confounding, or there was a dose response gradient. Okay, so just to summarize that again, you've got levels of certainty. Randomized control trials always start at high certainty, and then you can downgrade it according to those 5 factors, down to very low. Whereas observational studies, so cohorts, cross-sectionals, dose response, whatever, start as low quality, and then you can upgrade it, but you can also downgrade it. But they start as low quality. Okay. Then what we do is we actually go and grade the evidence to see how confident we are in the results. So the forest plot is captured to a large extent within this summary of findings table. You can see there's the certainty of evidence. You've got your outcome, which is acute typhoid fever. You have your absolute effects, you've got your relative effects, you've got your number of participants, and then you've got your certainty of evidence. So what? Grade summarizes the rating of the quality of evidence across the selected outcomes so that you can then make a decision. So that was a lot in a short amount of time. What we're going to do, there's still more to come, but what we're going to do is we're just going to have a brief practical session where you can just practice doing your PICO. We're going to do 5 minutes, not 10 because of time. But in your tables, I'm going to put up a case study and you can formulate your PICO question. You're going to specify the population, the intervention, the comparator, and the outcome. So this is your case study. It is 2022. The USA, Canada, and countries in Europe are recommending COVID-19 vaccines for 5 to 11-year-olds. You have noticed an increase in cases among 5 to 11-year-olds in your country and are concerned. There have been 2 reported cases of multi-inflammatory syndrome in children, and there are calls from some parent organizations to introduce the Pfizer vaccine to prevent serious illness, hospitalization, and death, whilst other parent groups are concerned about the vaccine safety. So that's what you're going to do. Do your population, intervention, comparator, and outcome. I'll put this presentation up again, the slideshow, case study. There we go. Yes. Okay, 5 minutes. Okay, that's a very quick 5 minutes. Does everyone have their answers? So this next bit is for the points. Okay? You get points for your country if you get it right. Colleagues. So your country will get a point if you're correct. So please don't shout out the answer. Rather put your hand up and I will call on you. Nigeria, I see you. So what we'll do is we'll just go through what the different elements are. Please don't feel too stressed if you don't get it, but I think you guys are all very smart. I'm sure you all got it. Okay, so for population, what do you think? Okay, so Nigeria gets a point. It's too easy. Okay, what is our intervention? Hands. Guinea. That's right. So he said the intervention is the BNT Pfizer vaccine. Okay, what is the intervention? Comparator, sorry, thank you. I'm going to give someone else a turn. Anyone? No vaccine, nice. What country is that? Mauritius. You have a beautiful country. Okay, and then, yeah. Just a second, everyone, just listen up.
So for comparator, you cannot use standard non-vaccine because you are compare because like now you are looking at the BNT 162B2 vaccine against a non-standard if it's available. So if it's not available, you can talk about no vaccine. But it's available, you look at a standard non-safe vaccine that you can compare with.
So it all depends on what you want to know, really. But exactly. So let's say blood pressure medication. You've got an ACE inhibitor and there's a new ACE inhibitor. You can compare those two. It's really just about what the question is that you have. Okay, and then outcomes. There's quite a few. So there's a few points. Gambia. Say again?
Serious.
Okay, good.
And then you have hospitalization.
Hospitalization.
Yeah, please.
Great. Time. Just one outcome. Just give me one. Thank you. Yeah. Hospitalization.
Okay, to
Tunisia?
increase hospitalization.
Death. Hospitalization. Good. Okay. Good.
Yes.
They said death. They get a point. Yes. Tunisia. 1, 2, 3. Okay. Good. So, almost. No one said adverse events and serious adverse events. Safety. But, okay, good.
Please, sorry, Tasha, please speak into your mic.
I thought I was. Can you not hear me? Okay, thanks. So,
Please speak into your mics when you want to answer.
yeah.
Yep.
All right. Well done, everyone. You're correct. The population is children under aged 5 to 11. The intervention was the Pfizer vaccine. There were three tables that got 1 point. 1, 2, 3. 3. Yeah. Okay. It's not so serious. I'll help you afterwards. Okay. The comparator was no vaccine. It could also have been standard of care. It could have been another vaccine, right? So if we took it back to the typhoid question, it could have been typhoid conjugate vaccine and the comparator polysaccharide vaccines, or another vaccine or a control, whatever. Okay? And then the outcomes that we said were important was symptomatic lab confirmed COVID-19, hospitalizations due to COVID-19, COVID-19 related deaths, adverse events, and serious adverse events. Do you see how specific we are in our outcomes? You need to be specific. So we said specifically hospitalizations due to COVID-19, not just hospitalizations. So the way you ask your question will change your scope and make it bigger or smaller. So keeping that all in the back of your mind, now we look at grade for recommendations. And grade has this framework called the grade evidence to decision framework. What it does is it provides an explicit structured approach to decision making, and it provides transparency. So even if you don't make a recommendation, anyone can go back and have a look at your evidence to decision framework and understand why you didn't make that decision or why you did. It doesn't prevent disagreements, so you have to make judgments, and usually experts in the field are in the best position to make these judgments. So it's that combination between high level of evidence, also using people's expert opinion and putting it together to make these judgments based on your specific context. And then obviously disagreements need to be explored and built on. We aren't robots, we don't all agree all the time. It takes discussion, and you can even in the evidence to decision framework, you can write there, 9 of the members agreed, the 10th didn't agree for this reason. All about transparency. Okay. So the whole idea is we're trying to move away from this type of decision making where you have this problem, then you have this big black box where nobody knows what happened, and then you've got a decision. And instead, we want to take into account equity, feasibility, evidence from research. Is it actually a problem? What resources is it going to take? How important is it? Is it acceptable to people if we do this recommendation? It's all very well you recommend something, but if people aren't going to use it, what's the point? Okay. So key evidence is then needed for decision making. You need to look at the balance of benefits and harms, values and preferences. Look back on this in 2 years' time when my PhD is done, and you will see more on that. Costs or resources and cost effectiveness. You need to look at acceptability, equity issues, and feasibility. So maybe you do a systematic review, you look at the evidence, and you find, wow, this really is the best solution, but our country can't afford it. So actually, we're not going to recommend it because it's not feasible. Or we don't have the manpower to put it out, whatever. So how recommendations are made with grade is to make a more systematic and transparent assessment. So you have your problem. You have then these different criteria that I was mentioning, benefits and harms, values, balance of effect, so on. You then look at the research evidence. You think of additional considerations, what's relevant for our context. You look at the panel judgments. So you as a NITAG would make a decision, judgment on each domain, and then you would make a decision or a recommendation. As I mentioned, there are these different criteria and there's different evidence that you can use for different options. So it's not only that you would use necessarily a systematic review. So for benefits and harms, you would look at effectiveness studies. So maybe a systematic review and meta-analysis. Maybe for values, you would look at qualitative studies or utility value studies. For resources and cost effectiveness, maybe you'd look at cost effectiveness analyses or other qualitative, other modeling or economic analyses. For equity, acceptability, feasibility, also maybe qualitative, going out and speaking to people, focus groups, so on. Okay, so creating clarity about which judgments are made in relation to what information is also important. So then this is then what it looks like when you're looking at your grade evidence to decision table. You've got your desirable effects, your undesirable effects, how certain you are in the evidence. That's what we were talking about earlier, high, medium, low, very low. What the values are, is there anything important or uncertain about how much people value this outcome? And then the balance of effects. Does the desirable effects outweigh the undesirable effects or vice versa? So those are the health effects. Then there's also contextual factors that you look at in the evidence to decision framework, such as resources, equity, acceptability, feasibility. So what's nice about this ETD, as we call it, is that it forces you to think through all the different options. It's not only about does this work or not, but it's about how good is the evidence and will it work for us and what are the things we need to take into account in our context and our setting. Okay. So when you are making a recommendation then, they come up with these different options. There's a strong recommendation against the option, a conditional recommendation against the option, conditional recommendation for either. So that's where you've got, the evidence doesn't really tell you either way. A conditional recommendation for the option and a strong recommendation for the option. So with this COVID-19 example I gave with the 5 to 11-year-olds, this was actually the decision that our national body came to. They came to a conditional recommendation for the option. And it was basically, they specified that it would be children with immunocompromising conditions. But it's all about consensus decision making. So it's not one person making a decision. Okay, so the strength of a recommendation. A strong recommendation means that you're confident that the desirable effects clearly outweigh the undesirable effects. So you are saying, we are so confident that this is a strong recommendation. This is what we're going to do. We're going to go for it. Conditional means that the group decides that the desirable effects probably outweigh the undesirable effects or are closely balanced, but they're not confident about these trade-offs in all situations, and that implementation, monitoring, and evaluation is needed to address these uncertainties. So another example could be something like a specific vaccine. Perhaps it works better and has better efficacy in like a population like people with HIV that are HIV positive. That maybe would then be a conditional recommendation with a proviso that this is the population that needs to get it. Okay, so in our case, with this Pfizer vaccine, this was our PICO. We said children age 5 to 11. It was trying to decide whether they should be getting the Pfizer COVID vaccine compared to no vaccine, and those were the outcomes that we spoke about earlier. And this is basically what we came to when we were doing the summary of judgments. So this is where you've done your evidence to decision framework and you've made a call, and then it's all summarized in this summary of judgments table so that you can have a look and see, okay, now we're going to make our recommendation. So is it a problem? Is COVID-19 a problem? Yes, that's what the group decided. By the way, if you have any arguments about this, I didn't make these decisions, so you'll have to take it up with the people that did. Then the desirable effects, we said they're small. The undesirable effects, also small. Low certainty of evidence. We have mostly had observational, in fact, we only had observational studies. we said there's probably no important uncertainty or variability about how much people value this. Oops, sorry. And the balance of the effects is that it probably favors the intervention. We don't know about the resources, so it's okay to say you don't know. It's all about transparency. In terms of certainty of the evidence of resources required, we didn't have any included studies. We didn't have included studies for cost effectiveness either for this group. Looking at equity, we said we weren't sure, but acceptability and feasibility would vary. Acceptability was interesting because there weren't really, at the time we did this review, any studies around how acceptable the COVID-19 vaccine would be for parents, for children, but we used data on other vaccines for children to get an idea around what people's ideas are for vaccinating their children. So that was quite an interesting one. So our final recommendation was actually against the intervention. So the wording was the panel suggests not to use it for the overall program for all children. Conditional recommendation, low certainty evidence, but suggests that it can be offered to children considered at high risk of severe illness and death. Also conditional, low certainty of evidence. So in those two statements, you've got a summary of all the different decisions that have been made, and it's transparent. And anyone should be able to go back and have a look at the evidence and see for themselves, do they agree or not, and whether they want to then take it up with the people that made the decision. So just to put this now into the bigger context of the whole evidence ecosystem when it comes to decision making, we've got evidence from primary research. So this is called The Theory of Everything by Holger Schunemann, who is one of the fathers of grade, I guess I would say. So as you can see, you've got a systematic review, but from there you may have it to for background for a HTA process, a guideline, maybe for quality improvement, coverage decisions, maybe for an essential medicines list, maybe for evidence-informed policy making. But they all have these specific criteria that they have in common. And that's kind of the point. We've all got all these different processes have similar criteria in common. Is it a problem? What are the benefits versus the harm? What are the values? What are the costs? How certain are we of the evidence? And then within that, there's different aspects that are going to be more important, right? So for HTA, maybe it's the social, ethical, legal aspects. Maybe for a guideline, it's equity, feasibility, acceptability. For quality improvement, we're looking at measurability and scientific soundness. Coverage decisions, maybe we're looking at policy or legislation. For EML, we're looking at I can't say that word, but pharmacological standards, and also regulatory standards and market availability. Has it been approved in your country? And then for EI, evidence-informed policy making, also equity and feasibility. Then you can get in modeling and conclusions, but the point is they all then feed back into the evidence ecosystem of health decision making. So I guess it's just an idea that using GRADE can help you to see the bigger picture in whichever context you're in. So we actually will have time for questions because I went quite quickly. The take-home messages are that research evidence is central to health and all decision making, which you all know. Experts are actually best placed to inform decisions, but that includes the patients and the public, includes healthcare workers, and includes academics, policymakers, program implementers, public health specialists, and methodologists. But it needs to be a decision that is informed by the evidence, and GRADE then provides a framework for decision making for transparency, specifically with equity in focus. This is a massive, massive topic. It's quite a lot to cram into a short amount of time. So I would encourage you, if you're interested, to come and ask a question now, or come and ask me questions. There's so much reading around it. There's, I don't know how many GRADE papers now, but it's so valuable when it comes to making evidence-informed decisions and being able to back that up, giving your recommendation with a certainty, knowing that you have this behind you to make give people confidence in the process that you're following. Yes, that's it. So, any questions?
Ok.
Please.
Merci beaucoup. C'est bon? Merci beaucoup pour la qualité de votre présentation. J'ai une question sur cet exercice très intéressant. Au fait, la plupart des recommandations, comme ça a été décrit ce matin, sont établies par l'OMS, par SAGE, par des comités d'experts. Est-ce que pour les comités pays, ils sont appelés à refaire l'exercice sur des questions déjà retenues? Au fait, c'est très rare qu'on aille dans une analyse pareille. Merci.
So a really great question, thank you. So we do find that often the country has a question that has already been answered. Excuse me. So you can use existing evidence. You can take a grade recommendation, for example, you can take a grade guideline, and then for your NITAG, you take their evidence, you take the evidence to decision table and you contextualize it for your setting. So you'll say, the evidence probably isn't going to change that much, but what about the contextual setting of our country? And you can bring it in like that, and then you can actually, we call it a development, where you take that guideline and you contextualize it for your own setting. So there's not to repeat what you're doing, otherwise it's a waste of time. No one has time for that. I hope I answered your question. Okay.
Thank you very much for this presentation. It was very, really that it is a great presentation, but it is a little complex. And that's why, if it is possible to share this presentation with us for this evening, to be tomorrow ready to digest it. Thank you very much.
That's a very
please, another question. How the NITAG will be assess the decision? Because in general, the NITAG don't have the possibility to do all this reflection. It means which criteria it has to follow to assess his decision. Please, thank you.
Thank you for your question. I agree. It's taken me a long time to get to a place where I can even talk about all of this. So 1 hour is not going to cut it. So definitely they have the presentation organizers, they can share it. But look, what I would suggest pragmatically is use evidence that has already been created. So go to look for evidence, the WHO, what their recommendations are, and then put it into your evidence to decision framework. So that's this one with the looking at all the different things like benefits and harms. Let me go back, sorry. This one. So this you can find online. It's open access. You have this, you put in the evidence that you have. So it doesn't need to be this long, drawn out process. You put in what you have for your context. It doesn't have to take a long time. If you don't have the answers about equity, then you say you don't have the answers. It's about being transparent, so that when you make a recommendation and your country people come back to you and say, why did you recommend this? You can say, look, this is the process we followed. We used evidence. This is what we considered. This is what we didn't actually have. Did I answer your question? Okay.
Okay.
Any other questions?
Yeah, so we can take 2 more questions and then go for tea break.
Thanks. Great presentation. Just for the question of the colleague from Morocco, I think the NITAG, you are familiar with this table. So it is the one you are using for each year framework, evidence recommendation framework. But the grade is a step higher. So for the recommendation, and I think it's resource consuming. You need human resources. You need also time to do it, and you need money. So if you have no of this or one of these, please, you can use your ETR as you are using it. But I think that in some countries here in the room where they have human resources, financial resources, they can do the ETR, the great. I think South Africa, NITEC is doing great. Yeah, for their recommendation. And also, in my opinion, you need also to have evidence generated in your country. Like big countries like Nigeria, where you have many universities generating evidence, maybe you can try to do great because you have now a very established NITAC. Maybe if you add resources, financial resources, you can do the great method. But it's not for all countries, really.
Yeah. Yeah, and it's not as simple. Thanks for that comment. That's a great comment. It's not simple. I think also just on that point, we really do need research coming out of Africa. Like it's not great to have to always contextualize from the global north. We want to have stuff that's relevant for our people. So that's just an encouragement from my side. That's important. And that's also comes back to the patient and public involvement, you know. If you're asking the people what is important to them, having them on the process from question development makes a big difference, and you're more likely also to get uptake. Yeah. Last question.
Thank you. I prefer to talk in French. OK. So, comme vous l'avez présenté, on a certains critères, ce qui nous rappelle un petit peu les critères pour choisir le test diagnostique ou de dépistage lorsqu'on veut intervenir auprès d'une population. C'est presque les mêmes critères qu'on utilise pour choisir une intervention à introduire. Sauf que pour faire le lien entre ces critères que vous présentez, les 9 critères qui sont divisés en health effects and contextual factors, et le degré de force, strength of recommendation. Are there correlation between the two presentations, the criteria and le niveau de force de recommandation? C'est-à-dire, est-ce que s'il y a à peu près les 9 critères sont remplis, on est dans le strong recommendation. But how to... Is it clear?
I think I understand. You're saying if you have evidence for... It's unfortunately not that simple. It's not just if you've got it, all of them, and it's like a tick box, then it's strong. It's all about how certain you are in the evidence in each criteria, you know? I mean, you could have, for example, really great evidence, all high quality, but like I said earlier, like it's not equitable or it's not feasible or you don't have the resources, then it wouldn't be a strong recommendation. It would probably be maybe a conditional recommendation against. So it's really per question and depending on what your evidence table looks like. But yes, it's also very similar. It's basically the same as the evidence to recommendation. It's just evidence to decision is the language we use in grade for anyone confused. Yeah.
Thank you. Thank you so much, Tasha. I think we will go for tea time now. But before we go for tea time, this is a reminder again for everyone who has a tag that looks like mine, where your name was written using a pen. Koli has asked that within your groups, if you don't have a proper tag, just write your names within the groups and just leave it by her desk when you go get tea. So thank you so much, and we'll be back in 10 minutes for the next session. I'm getting a question here. So if your name is written in pen, even if you have the lineage, but if your name is written in pen, please write your name down and give it to Koli by the door. Looks like you have 20 minutes for tea, not 10. 20 minutes.
Oui, oui. Non, non, on est sur la bonne voie, docteur. On a les éléments pour que nous comprenions votre non, c'est ce qui est en ligne là. On ne pourra pas copier en ligne. Il va le résultat là-bas.
Calvin. Calvin. Je vais partager la photo là. La photo là. C'est terrible. Ouais. C'est pas fait.
Hello? Hello, 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 hello. Can I have your attention, please? Can I have your attention, please? All right. Can I check with you during coffee, tea break, or lunch? How many of you made connection with somebody else outside your home country, outside your NITAG? Just by show of hand. Very few people. So this is not even 20%. So I actually encourage you during tea break, during lunch, interact. This one of the key outcomes from this conference is actually networking and interactions. And that needs to be done because it cannot be done during the sessions because we're busy listening to the speakers. But of course, you know, as each NITAG present about themselves, when you go out, you can reach out to them to find out more about what they are doing during coffee, and more interactions we expect can emanate from there. And these are not interactions, these are interactions that we expect are going to go beyond Cape Town. When you go back to your country, when you go back to your work, you continue interacting with other NITAGs. So that if Nigeria has already made a switch from RTS to R21 malaria vaccine, and Gambia want to do that, you don't have to start from the scratch. You can reach out to Nigeria NITAG and they share their experience. So I think that is a very important component of this training, all of this workshop, to be able to connect with other NITAGs. Okay, so now we're going to come to the last session of today's program, and it's going to be an interactive session. So we're going to have one talk, which is going to be done by Dr. Eves from WAHU, West African Health Organization. And Dr. Eve is going to tell us how WAHU has been working in the region to establish NITAGs, to strengthen NITAGs, and to advance immunization program. He has 20 minutes, and I'm going to time here. Got a timer here, Eves. After Eves' talk, we're not going to take questions for Eves because he will participate in a discussion that is going to be led by CD, NITAG focal point person in Afro, and Wedian, who will be she is the NITAG focal point person in EMRO, right? And that discussion will entail the kind of support that NITAGs get from EMRO and from Afro. And during those discussions, you can also you can ask questions to Eves, or Eve can clarify what he did not manage to get said during the 20 minutes that we've given you. Eves, the floor is yours. Check as I time so that you'll hear a beep. There you go.
Thank you so much, Professor Benjamin. Bonsoir, distingués délégués des pays. Est-ce que nous sommes ensemble? Est-ce que nous sommes ensemble? Magnifique. Je suis Dr. Yves Mogbo. Je travaille à l'Organisation ouest africaine de la santé. Je remercie le professeur Benjamin pour l'occasion
qu'il nous offre, de partager avec vous l'expérience de l'OAS en matière de mise en place et de renforcement des GTCV en Afrique de l'Ouest, dans l'espace CEDEAO. Et je vais faire cette présentation en suivant le plan ci-après, une introduction, le long voyage que nous avons eu à faire pour pouvoir en arriver là où nous sommes dans l'espace, quelques résultats clés, aussi quelques défis et perspectives. Alors, un mot rapide sur mon institution. J'ai oublié de dire que je vais faire ma présentation en français, mais les diapos sont en anglais. Depuis le matin, on entendait anglais, anglais, anglais. Maintenant, on va parler un peu français. Et il y a 6 pays francophones sur les 11 qui sont présents ici. Merci beaucoup. Merci. Alors, l'Organisation ouest-africaine de la santé est l'institution spécialisée en santé pour la communauté économique des États de l'Afrique de l'Ouest. Donc, c'est le bras armé santé pour ECOWAS. Et nous avons été créés en 1987. Comme mission, c'est de contribuer ensemble avec les autres institutions de la communauté économique à la réalisation de l'idéal de la communauté qui est la création de l'Union économique pour l'Afrique de l'Ouest. Et en tant qu'institution spécialisée en santé, nous, spécialement en adressant les défis sanitaires communs à la région de manière collective et de manière stratégique. Et c'est ce que nous essayons de faire. Et nous avons comme vision d'appuyer les pays de la CEDEAO à pouvoir disposer sur le continent des meilleurs indicateurs de santé et de bien-être. Alors, quelques mots rapides sur la CEDEAO. Vous le savez, la communauté économique des États de l'Afrique de l'Ouest a été créée en 1975, 28 mai, et nous allons fêter donc ce mois-ci, si ce n'est pas en cours déjà, 50 ans, demi-siècle d'existence. Et ça, c'est le logo que je porte fièrement ici, que je vous montre. Les 50 ans d'existence de la CEDEAO. Voilà, je vais t'en donner. À la création de la communauté, on était 16 membres avec les amis de la Mauritanie. Mais en 2000, la Mauritanie s'est retirée et on est devenu 15. Mais maintenant, 2024, 3 pays se sont retirés. Vous les connaissez, c'est les pays de l'AES, notamment Burkina Faso, Mali, Niger. Et actuellement, nous sommes 12 États membres avec une population de plus de 360 millions d'habitants, dont 50,2% de femmes. La bonne nouvelle, c'est que tous les pays de l'espace disposent de GTCV, les 12, y compris même les 3 qui se sont retirés. Et ça, c'est un travail colossal de l'Organisation ouest-africaine de la santé, en collaboration avec l'Organisation mondiale de la santé, Bureau régional Afro, pour parvenir à ce résultat. C'est vrai que les GTCV sont à différents niveaux de fonctionnalité. Alors, comment nous sommes parvenus à ce résultat? C'est un long voyage. Tout a commencé en juin 2009, lorsque l'équipe AMP CIVAC, vous voyez, certains d'entre vous reconnaissent Kamel Senoussi. Non? Voilà. Kamel a conduit une équipe de l'AMP CIVAC à l'ouest, à notre siège, à Bobo Dioulasso, pour nous entretenir sur l'initiative CIVAC et la nécessité de créer le GTCV dans les pays de notre espace. Et ensuite, en juillet 2009, toujours, nous avons eu une réunion technique à Abidjan pour discuter profondément sur l'initiative, afin que l'OAS puisse acheter cela pour travailler ensemble avec CIVAC, surtout pour la Suisse de Gambia. Are we together? OK. surtout pour travailler sur la durabilité. Parce qu'ils savent qu'ils sont des projets, ils sont un projet et que d'ici à là, ils vont finir. Quand ils vont finir, quelle est l'institution qui pourra continuer le travail qui a été commencé? Donc, ils ont fait recours à l'OAS et on a commencé cela. Alors, pour pouvoir y parvenir, nous avons conduit en 2010, entre octobre et décembre 2010, une étude de faisabilité. Et l'idée initiale avec laquelle SIVAC était venu, c'était de créer d'office un organe au niveau régional. Puisque nous sommes une institution régionale, ils sont venus dans l'idée qu'on va mettre en place une structure régionale pour travailler directement en qualité de GTCV. Mais quand nous avons consulté les pays, notamment tous les acteurs, aussi bien au niveau régional, il y a notamment l'OMS, l'UNICEF et puis l'UEMOA, qui est aussi dans notre région, et ensuite tous les directeurs du PEV des pays. C'est clairement ressorti qu'il faut d'abord mettre en place au niveau national, et quand on va voir comment ça fonctionne, on peut maintenant penser à mettre en place au niveau régional une structure. Et c'est ce que nous avons fait. Et nous avons restitué les résultats de cette enquête en avril 2011 en invitant tous les directeurs des PEV, des pays concernés, tous les secrétaires généraux, parce que c'est en même temps restitution et plaidoyer pour que les pays puissent acheter l'idée et commencer par mettre en place. Et c'est une date particulière parce que c'est cette date qu'il y a eu l'insurrection contre l'ancien président du Burkina. Ceux qui sont, oui, en avril, 11 avril 2011. Alors, comment est-ce que nous avons procédé? Après cet atelier de sensibilisation, les pays maintenant doivent formuler une lettre de manifestation d'intérêt pour dire oui, l'idée de GTCV, nous comprenons et nous voulons en avoir. Et si nous recevons la lettre de manifestation d'intérêt, une équipe, une mission se rend dans le pays pour voir l'existant. Est-ce que toutes les capacités techniques requises existent dans le pays pour pouvoir mettre en place un GTCV? Est-ce que la volonté, effectivement, y existe? À l'issue de cela, le ministère envoie l'arrêté de création. Et quand l'arrêté de création sort, souvent c'est générique. Maintenant, il faut la note, la décision de nomination des membres. Et là, c'est une autre bataille. L'arrêté peut sortir et la décision va sortir 6 mois, 1 an après. Parce que il y a des considérations politiques qui on va prendre. Est-ce que la personne est... Bon, vous comprenez ce que je dis. Alors, et après la sortie, quand on connaît maintenant les membres qui sont effectivement nommés, on procède maintenant à leur orientation et formation en utilisant les outils mis en place par le projet SIVAC. Et je vais dire que pour pouvoir avoir parfois aussi l'arrêté, il y a un pays ici présent, nous avons mis 10 ans à travailler avec le pays. Elle a levé déjà la main, c'est elle. Sinon, elle sait que j'allais appeler son nom. Nous avons mis 10 ans pour pouvoir parvenir à obtenir du pays que oui, nous voulons GTCV. Parce que le pays confondait à dessein ou bien chose là, GTCV avec CCIA. Et ça là, ça avait beaucoup prévalu en son temps. On dit non, nous avons déjà le CCIA qui est là, pourquoi on va avoir GTCV? Non, c'est bon. Oh, la différence est tellement grande. Après, ils ont compris. Ça continue. Alors, SIVAC a très vite vu qu'ils vont prendre fin et effectivement en 2017, ils ont pris fin. Et depuis lors, c'est l'Ouest qui a pris le relais pour continuer le travail qui a commencé. Et nous avons joué un rôle fondamental en ce sens que annuellement, en moyenne, l'appui qu'on fournissait à chaque GTCV pour son fonctionnement, c'est autour de 36 000 $ par GTCV annuellement. Et là, c'est surtout pour pouvoir renforcer l'équipement du secrétariat, pour organiser ces 3 axes spécialement, le fonctionnement, la production des documents scientifiques et aussi des voyages d'études et d'échanges. Globalement, c'est les 3 volets là qu'on couvre. Et nous avons sorti un article ensemble à l'AMP et l'OAS pour montrer le rôle catalyseur qu'une institution régionale a eu à jouer dans l'extension des GTCV dans l'espace CEDEAO. Si Ben veut, en tout cas l'article est disponible. Quelques résultats clés. Le premier résultat clé, et je crois que mon ami, j'ai oublié un aspect important. Je vais revenir. Je ne vois pas. Bon, ce n'est pas grave. Je dois préciser qu'en 2019, l'OMS nous a rejoints avec beaucoup de force. Et c'est justement, l'OMS a tellement compris, finalement, parce qu'en son temps, on avait même formulé une délégation pour aller à l'OMS IST, à Ouaga, pour convaincre le coordonnateur IST en ce temps, cela existait, de se joindre à nous pour faire le chemin ensemble. Maintenant, c'est seulement en 2019 que l'OMS a compris, ils nous ont rejoints, et tellement ils ont compris qu'ils ont recruté spécialement un staff dédié exclusivement au GTCV. Et je suis fier que c'est mon frère et ami Sidi. En ce moment, quand on faisait les va-et-vient, il était le secrétaire de GTCV Sénégal, qu'on appelle le CCS. C'est bien ça. Hein? CCVS, merci. CCVS. Alors, donc c'est ça en 2019. Donc, quand on parle de GTCV, on laisse toutes ces années, ça me frustre un peu. C'est pour ça que j'insiste là-dessus. Puisque Niche est né en 2021. 2021. C'est important de souligner cela. Alors, quelques acquis, c'est le fait que tous les pays disposent de GTCV actuellement, mais à différents niveaux de maturité. Je dois dire que le premier pays à en disposer dans notre espace, c'était la Côte d'Ivoire en 2010. Et ensuite, le Sénégal et le Bénin ont suivi en 2013. C'est bien ça? Voilà, en 2013. Nous avons continué le chemin, on a poursuivi le plaidoyer et finalement, 2024, Cap-Vert a compris et a accepté. Mais c'est cette année qu'ils ont eu leur arrêté de création. Elle vient de le dire. Cap-Vert et puis Guinée-Bissau. Voilà, sur cette carte, vous voyez que l'ensemble des pays de l'Afrique de l'Ouest disposent de leur GTCV, mais à différents niveaux de fonctionnalité, en prenant en compte les 6 critères de fonctionnalité. Mais nous allons revenir un peu là-dessus vers la fin par rapport à ces critères. Autre réalisation, vous savez tous le rôle crucial que les GTCV ont joué, notamment pendant la période de COVID-19, pour pouvoir fournir des recommandations aux pays, guider les autorités, apprendre à introduire. Alors, un GTCV comme celui du Burkina Faso, dans la seule année de 2021, a eu à émettre plus de 6 recommandations. Et les GTCV jouent un rôle primordial en matière de recommandations pour l'introduction de nouveaux vaccins ou de vaccins sous-utilisés. Et dans un pays comme le Bénin, le GTCV est même allé juste à voir quelles sont les causes de faible couverture vaccinale. Je crois qu'ils ont restitué cela. En 2019, Sidi, j'avais organisé un genre d'atelier comme ça d'échange entre les pays, les GTCV qui existaient. Et en ce moment, on a eu la présence d'esprit d'inviter même les pays qui hésitaient, qui n'avaient pas de GTCV pour venir assister, pour apprendre et voir. Et là, nous avons vraiment compris que c'était une bonne chose et qu'on était sur la bonne voie. Alors, le GTCV aussi, vous le savez tous, fournit aussi des recommandations par rapport aux soumissions à Gavi pour les pays qui sont Gavi, qui reçoivent du financement de Gavi. Quels sont les défis que nous avons? Il me semble que j'ai encore 7 minutes. Les défis, c'est d'abord ressources humaines limitées à notre propre niveau, au niveau de l'OAS. Si je dis ce que je couvre ici, vous allez dire si c'est une seule personne, si c'est vrai. Je suis en charge à l'Ouest de la santé de la mère, du nouveau-né, de l'enfant, de l'adolescent, du jeune et de la personne âgée. Et je dois faire face à ça seul. Et en même temps, dans GTCV, dans Santé Enfant, c'est l'AIA GTCV. Donc, pour moi, c'est juste une ligne d'activité. Et nous avons 2 autres personnes, ou bien 3, pour essayer de m'appuyer dans ça, mais de manière partielle. Et même moi-même qui suis dédié à cela, c'est encore partiel. C'est encore partiel. Et parmi les 3 ou 4 membres, il y a le professeur Sombier et le professeur Benjamin a omis de citer l'OAS parmi les membres du Managing Board. Or, le professeur Sombier est celui-là qui a été désigné pour représenter l'OAS au sein de ce board. J'insiste sur ces choses parce que c'est important. Alors, j'ai comme autre défi, c'est la disponibilité non seulement de ressources humaines au niveau de l'OAS, mais aussi au niveau des pays pour avoir les différentes spécialités requises, soit pour mettre en place, soit pour renouveler. Parce que pour renouveler, il faut avoir les spécialités avant de renouveler. Et aussi un autre défi que nous avons déjà souligné ici, c'est la disponibilité de données locales. Et là, nous saluons la création de niches ici qui aide beaucoup en cela. Et Niche est en train de faire un travail formidable. Il faut continuer ce travail. Un bas à professeur Benjamin et son équipe, s'il vous plaît. Merci beaucoup. Merci. Alors, un grand défi, sinon les 2 derniers défis que je vais souligner, c'est la nécessité d'avoir un secrétariat solide, vraiment solide, parce que c'est vraiment la colonne vertébrale de GTCV. Et je voudrais ici que nous réfléchissions quel est le modèle. Dans beaucoup de pays comme UK, le secrétariat est hébergé par une institution de recherche. Ou bien en Allemagne, c'est une institution de recherche qui joue carrément le rôle de secrétariat. Bon, ce n'est pas encore le cas chez nous. Dans notre espace, les GTCV qui marchent correctement, on essaie de recruter quelqu'un pour venir renforcer le PEV qui est déjà surchargé. Et c'était le cas au niveau du Sénégal, et c'est le cas, et là c'est à travers l'OMS, et c'est aussi le cas au niveau du Togo, à travers l'OAS. On a recruté quelqu'un spécialement pour mettre à disposition, appuyer les travaux de recherche d'évidence, de formulation, tout ce qu'il faut pour maintenant présenter en plénière aux membres de droit pour pouvoir décider. Alors, une autre grande préoccupation qui revient, c'est le financement durable des GTCV. Tout le monde a souligné cela ici. Quel est le mécanisme le meilleur pour pouvoir assurer un financement durable du fonctionnement des GTCV? Jusque-là, nous l'avons fait, l'OAS, et on n'a jamais manqué. Actuellement, j'ai encore assez de fonds pour les GTCV sur la ligne de 2025. J'ai même écrit à tous les directeurs de PEV, ils sont ici, pour leur annoncer cela. Mais pour le moment, j'attends toujours leurs requêtes. Parce que l'OAS n'a plus que sur base de requêtes. Si un pays ne demande pas, un pays membre, si un pays ne demande pas, on ne peut pas aller faire un appui. Alors, quelle est la manière la plus durable de le faire? Je crois que ça fait plus de 10 ans qu'on dit à la fenêtre renforcement des systèmes de santé au niveau de l'appui Gavi dans les pays, pour les pays éligibles à Gavi. Au moins, si les directeurs du PEV mettent dans leur budget annuel, ça pourra bien passer, ils pourront continuer à fonctionner. Parce qu'à partir de cette année, mes patrons ont décidé que ça suffit de donner fonctionnement au GTCV qu'on a créé depuis 10 ans. Ils sont maintenant un peu adultes, il faut qu'ils se prennent un peu en charge. Donc, les choses n'ont pas fonctionné. Voilà. C'est surtout pour les échanges d'expériences, les formations, on peut continuer, surtout pour les nouveaux membres qui sont admis dans les GTCV. Alors, j'ai commencé déjà par les perspectives, c'est de mettre le focus sur le renforcement des capacités, mettre ensemble les GTCV pour travailler au réseautage, les échanges d'expériences et continuer les formations, surtout pour les nouveaux GTCV. Et nous, l'un des rôles que nous avons comme institution régionale, c'est le plaidoyer auprès des politiques au niveau des pays pour le financement endogène de la santé, y compris de la vaccination. Dans ce rôle, nous allons continuer naturellement. Et pour nous, c'est ici, c'est bon que nous puissions trouver le consensus sur comment renforcer le secrétariat de manière solide et comment trouver le mécanisme approprié pour le financement correct des GTCV. Voilà, je suis au terme de ma présentation. Et puis, un dernier point sur lequel j'aimerais qu'on réfléchisse. La réflexion a commencé, mais je pense que ça doit se poursuivre. Les 6 indicateurs que nous avons pour apprécier le fonctionnement des GTCV maintenant, c'est bon, mais so what? On a fait réunion, on a fait ce, et après, il faut aller plus pour trouver des indicateurs de résultats. Je vous remercie pour votre aimable attention. J'ai fait économie d'1 minute, bien de 2 minutes. Ben.
If you did very well, thank you so much for keeping time. And please stay here. I'm going to invite Wedian and Siri. I know in the program we've put it as separate, but I think it's just good we make it interactive. And also you from Wahoo as a key partner who has been involved in setting up NITAG, strengthening them. Let's talk about the support that is available for NITAGs in Africa. And we're looking at it from AFRO, from EMRO, and also from Wahoo. And also I know there are other partners that are involved in supporting NITAG. So please feel free to join in the discussion. And maybe I'm just going to give each of you the mic. In here. The first, I think we're going to start with, let's start with Afro. Okay. CD is saying ladies first.
Yeah, ladies first.
Let's vote. Who wants CD to start?
Nobody.
Nobody. So Wedian, just tell us a little bit about EMRO, how many countries, and also tell us more about the kind of support that NITAGs can access from EMRO.
Yep. Thank you. I know this is the very last session, so thanks for still being here. So for those of you who don't know, thank you. Wedian is my name. I've only been at EMRO for about 1.5 years, and some of you may know Dr. Gerald Tuma, who's really spearheaded a lot of the NITAG work. So we have 22 countries in the EMRO region, amongst them about 7 from the African continent. So 22 countries, all but 2 within the GNN, and all of those in the African region, part of the GNN. So that's very briefly. Some of the support, I might just do 1 or 2 for now, and then because it's could take up a bit too much time, and then pass on to the next question. So we do various kinds of support. Over the last few years, many of the countries have obviously undertaken the evidence to recommendation training that we've done, and in partnership with a lot of the partners you see today. We do a number of webinars on various aspects of NITAGs, from conflict of interest, the SOPs. Specifically this year, a couple of things we're focusing on. You've heard a lot, some people have mentioned twinning. So we will be undertaking twinning initiatives within EMRO, and this is the first time for us. We also recently have this year as well a health economist join the team. And she's providing direct support to countries with regards to their health economy questions, any gaps, and how we can support that. So they're just a few things, and then I'll stop there. And if you'd like me to continue, I can after.
Can I clarify something from you, Wedian? In terms of the support you give to NITAGs, is it something that NITAGs request from you and then you provide the support based on the requests, or it's an existing package of support that is available for whoever needs it?
Yeah, so that's a good question. It's a mix of both. So, for example, if we have a training coming up or a webinar, then that would go to all the NITAGs. But then we have support that happens because it's been requested to us. For example, I know not a country in Africa, but recently we were joining the Lebanon NITAG in their meetings to provide support with their evidence to recommendation process. We only a few weeks ago, a lot of the single country training happens when countries contact us requesting support, also with their evidence to recommendation. So it goes both ways. So direct support to all, or very specific when the countries reach out to us.
Thank you so much, Wendy. And we're going to have time for NITAGs to react to this support available so that you can tell us what kind of support you've accessed and also what kind of support you may have wanted, but you did not get it, so that collectively we can think of ways of putting together resources and manpower to make that kind of support available. Then I will move on to Siri. Over to you, Siri.
Thanks, Ben. I think it's one WHO, so it's complementary. Just WHO support to NITAG starts really at Afro when CIVAC, IMP CIVAC initiative stopped in 2017. It's when the WHO stepped in to support the remaining countries to have NITAGs. At this moment, we had like 28 countries with NITAG, but the functionality was really suboptimal. Have like 20 NITAG, which was were functioning. So we had to do advocacy to countries to complete the NITAG establishment. So right now we have now 44 countries with NITAG, established NITAG. We are, so 3 remaining countries, Guinea Equatorial, Gabon, and Central African Republic, without established NITAG. Now we have like 38 of these NITAG fully functioning. And this was possible by advocacy to countries towards supporting bodies like Gavi to fund NITAGs, but also supporting training. Training on operation, how the NITAG is supposed to function, what are the roles within the NITAG members, so core members, secretariat, and how they need to use the evidence ETR training. So the ETR training is basically a 5 days training where we saw the NITAG, so we saw them the operations, from the PICO question to the recommendation. So the way to do that, and we usually group the countries, but we can have also requests from one country. So that are the ad hoc requests. Now in our table we have a request from one country here. So Eve is here. he will be giving the money, and Nish will be giving the technical support as well, WHO. So globally, that is the support, and effectively we collaborate with University of Cape Town to establish this NITAC support hub. And just to say that this is the one in the world, NITAC support hub. It is one, and it is in Africa. Thank you again, Benjamin, and your team for that.
Thanks, Siri. So if I may request you and Yves to comment on, because you've talked about functionality, Yves too. But we know there is that functionality of the old system of 6 criteria, and now there is a functionality of sort of maturity. Do you want to explain to us the difference? And when you say, for example, 38 countries mature, are you referring more to the maturity, or is the functionality of the old system? Okay.
Okay. In the first stage of the NITACs, so the assessment was based specifically on the 6 basic criteria: the NITAC establishment, the secretariat, is the NITAC is meeting at least one time a year, the conflict of interest management within the NITAC, etc. And CVAC and IMP, they were using also an external assessment tool, so developed by CVAC. And since 2021, there is a new tool called NITAC Maturity Assessment Tool, which was developed by CDC Atlanta within a working group, Gavi Task Force for Global Health, and also WHO. So we worked in this working group to develop this tool. So in the African region, we implemented this tool in 30 countries. And I can say that globally, the functionality is over the 50%. So just to talk about the tool, it has 7 indicators. The first indicator assess the NITAC on establishment and the composition. The second indicator is about independency of the NITAC and how the conflict of interest are managed within the NITAC. The third is about the secretariat support and the resources that are given to the NITAC to make recommendation, to make work daily work of the NITAC. And the fourth one is about operations. When the NITAC receive a question, so how they work to make the recommendation. The fifth is the process in making recommendation, the ETR process. And the sixth is about how the NITAC is integrated in the health immunization policy decision making. And the seventh indicator is about how the NITAC is recognized by the other stakeholders in the country, like the academics, like the health scientific societies, etc. So we have about, I think, 38 sub-indicators. The overall score is 80. So the NITAC is scored on 80, a base of 80. So globally, I can say the 30 NITAC we assessed, most of them, they are above 50% of the overall score. But there is three main bottleneck. The first one is the resources. The resources given to the NITAC to function, especially the secretariat support. And the second is about how the NITAC follow up its recommendation. In many countries, when the NITAC receive question from the Minister of Health, they do their job and after submit the recommendation to the Minister of Health, but the follow-up is not done. And lastly is the recognition, the recognition by the other stakeholders. So there is no visibility at the country level. There is no visibility on the great work, the big work, very huge work done by the NITAC towards the health societies and the academics. And just to highlight that after each assessment, we develop an improvement plan with the country, with the NITAC, and after they can follow up this improvement plan. I think we did assessment in some countries here, Cameroon, Senegal, they did self-assessment, Guinea self-assessment, and yeah, that's all. Thanks.
Thank you so much, Sidi. That's very, very informative. So I'm going to ask Yves the last question, and then I'm going to open it up to you so that you can give your insight, ask questions, make comments. Yves, one of the challenges that Sidi has flagged is resources. And it looks like you have an envelope where you go giving each night like 36,000 US dollars. Are you going to give that $36,000 to all the countries, or you just stick to 12 in our region?
Okay, thank you. Merci beaucoup, Ben. Je crois que parmi les 11 pays qui sont présents ici, j'ai dénombré 5 qui sont de notre espace, l'espace CEDEAO, notamment Cap-Vert, Gambie, Guinée, Sénégal et le grand frère Nigeria. Nous avons l'habitude d'appeler Nigeria grand frère, Big Brother, parce que 51% de la population de la CEDEAO, c'est le Nigeria. Si on prend 2 Ouest africains, forcément un sera du Nigeria. Alors, ces 5 pays que j'ai cités savent très bien comment est-ce qu'on procède pour accéder aux fonds disponibles au niveau de l'OAS. Et ces fonds, je dois dire, c'est des fonds des pays, des communautés. Donc, c'est votre argent. Si vous ne demandez pas, vous n'utilisez pas, bon, c'est bon, ça va rester là. Et il y a quand même assez d'argent. Les 36 000 US dollars que j'ai dit, c'est ce que nous avons eu à injecter pour le fonctionnement des GTCV chaque année, au moins par GTCV. Et une année, 3 GTCV, 2 GTCV peuvent demander. Non, ce n'est pas pour l'ensemble. Mais maintenant, nous sommes en train de faire machine arrière pour dire qu'on ne va plus financer le fonctionnement quotidien des GTCV, mais pour des grandes réunions comme ça, pour le réseautage, le jumelage peut-être, et aussi pour la formation. C'est sur ces aspects que nous pensons désormais mettre l'accent dans en tout cas dans notre appui au GTCV de notre région. Donc, je ne vais pas dire le montant, mais je crois que j'ai envoyé un message à tous les directeurs de PEV pour dire qu'il y a des ressources disponibles au niveau de l'OAS. C'est l'argent des pays. Et puis, ils sont informés. Je crois que c'est Albert qui est ici. Kiné, vous avez reçu le mail? Oui. Voilà. Voilà. Donc, et tous sont reçus. Mais nous sommes là pour continuer à renforcer notre collaboration avec des institutions comme Niche, mais nous n'allons pas donner de l'argent. Nous ne sommes pas des bailleurs de fonds. C'est l'argent de la communauté. Merci beaucoup.
Thank you so much, Yves. I think the, the, the ability to get the government fund NITAGs is very special, and those lessons learned in terms of how to engage with the government to continue recognizing and giving resources to NITAGs, it's very useful, and I think if it can be shared across, we would hope in future all African governments commit resources to support the work of NITAGs. Now I'm going to open it up to NITAGs. Please let us know the kind of support you've accessed from WHO, from WAHU. Tell us what has worked. Tell us what other support you might need, and we can put our heads together and see what we can do as partners to continue supporting your work. Yes, when I say as partners, I mean Niche and WHO, and we've got Gavi here, we've got Linksbridge. Maybe actually I can ask Linksbridge and Choices to briefly mention some of the support you've been giving to NITAG, especially in Africa. Just first brief introduction and then some of the support you've given.
Thank you. My name is Nasser Mohammed. I'm working with JSI. I'm a director for the project called Choices, which aims at providing support to countries to strengthen capacity of NITAGs, specifically on new vaccine introduction prioritization and vaccine program optimization. The project started at the end of last year, so it's a new project. We have just started the actual implementation a few months ago, and it's funded by Gates Foundation. We are working with our core partners, including the Task Force for Global Health. Also, we are working with George Mason University and Development Catalysts led by Kamel, who was mentioned here as the founder of NITAG. So we are working with him as well. So the aim is, as I said, to strengthen the capacity, but specifically on new vaccine introduction, prioritization, and optimization. And we are mainly focusing on Gavi-supported countries. So we have tried to identify some of the countries who are yet to do the prioritization of new vaccines and mainly focusing on those countries. But that is not it. If there is any country that they feel they need support in terms of new vaccine introduction and optimization of the vaccine program, we can still figure out how to support that. But as I said, we are mainly focusing on Gavi supported countries, and we are working very closely with WHO, UNICEF, and Gavi as well. Thanks.
Thank you. Linksbridge?
Thanks, Ben, and it's such a pleasure to be here learning with you all. My name is Maggie. I work with a consultancy firm called Linksbridge. We focus on data analytics and vaccine research. We have a range of projects, but in terms of how we engage with NITAGs, my own work has been with the MCV 10 to 5 dose switch, given webinars and supported NITAGs at various conferences, or, interacted with NITAGs, I can't say supported, learned from NITAGs at various conferences. And that's for MCV, but we have a range of vaccines as well.
Thank you so much. All right. Over to you, NITAGs. Now tell us about the support that you've received. Tell us what you feel could be done more. And we're here to listen. Who wants to start? All right, Guinea.
Ok, merci. Moi, c'est Kamara Albert, PF Guinée, et en même temps, je fais partie des membres du GTCV. Au fait, c'est bien vrai qu'on a été sollicité à plusieurs reprises par l'OAS pour soumettre, disons, des requêtes en fonction des besoins identifiés en termes de formation. Mais j'avoue que le pays n'a pas pu honorer au fait, ses engagements vis-à-vis de l'OAS, mais les besoins sont énormes en termes, disons, de fonctionnalité des membres du GTCV. Je pense qu'il y a, lors de la présentation de quelques GTCV, au fait, ces besoins et défis ont été énumérés, mais nous spécialement, c'est aujourd'hui comment fluidifier que les membres du GTCV puissent, disons, parce que nous, on est en retard par rapport à tout ce qui est introduction des vaccins. Et là, dans la stratégie nationale de vaccination, il y a un chronogramme qui a été élaboré par rapport à ces introductions. Et donc, on a besoin vraiment que le GTCV fonctionne presque à 100% pour arriver à, disons, nous assurer que nous puissions tenir au fait ce chronogramme, disons, d'introduction des vaccins. Mais au-delà, vous comprendrez que les membres du GTCV, on est cinq qui sont là et les autres 5 ou 6 qui sont présents ici. Les autres membres, on a besoin énormément de renforcement de capacité, disons, de ces autres membres. Comme vous le savez, c'est des professeurs, des cliniciens, et ainsi de suite. Pour réunir tout le monde, c'est difficile. Mais il faut avoir le même niveau d'information pour que quand tel est absent, que l'autre puisse jouer le rôle convenablement et tout ce qui s'ensuit. Et également, je le disais au vice-président du GTCV, on a besoin, disons, de ce partage d'expérience des autres pays où ça fonctionne à merveille, qu'on puisse apprendre d'eux pour pouvoir fonctionner normalement au niveau du pays, quoi. Donc, voilà ce que j'avais ajouté par rapport à la question que vous avez posée. Merci.
Merci, Robert. Je pense que ça, c'est... Ouais, c'est Albert. Robert, c'est le vice-président. Effectivement. C'est tous des camarades. Ce sont mes oncles, en fait. Je pense que la première des choses pour un ITAC, c'est d'avoir un plan d'action annuel. Ça, c'est fondamental. Il faut avoir un plan d'action. Même si vous pouvez avoir un plan pour 2 ans, 3 ans, c'est bon. Et je pense pour la Guinée, comme vous l'avez dit, le NITAC doit être à 100%. Et actuellement, il y a un exercice qu'on a démarré à l'OMS et dont Nassour parlait un peu. Et je pense que le niche va apporter aussi son soutien parce qu'il y a juste une formation après celle-là sur la priorisation. Donc l'exercice de priorisation pour des pays comme la Guinée, c'est fondamental. Comme vous prévoyez d'introduire plusieurs vaccins, il faut que le GTCV puisse aider le programme à prioriser. Je ne sais pas si le mot existe en français. Et ensuite, c'était après l'exercice de priorisation, maintenant, vous pouvez faire des recommandations individuelles pour chaque vaccin. Et là, les partenaires sont là pour appuyer. Je pense que c'est une occasion d'introduire cette requête demandée par l'OAS pour pouvoir mener à bout cet exercice parce que c'est un exercice long qui va vous prendre minimum 2 mois avec des ateliers. Et voilà, c'est l'occasion de pouvoir faire ça. Voilà. Oh, bon. Allez.
OK. Au fait, c'est pas juste vous couper la parole. Il y a 10 jours, on avait une mission de haut niveau de Gavi, du Fonds mondial et de la Banque mondiale au niveau du pays. Et la mission a rencontré les membres du GTCV. L'objectif, c'était de prendre la stratégie nationale de vaccination avec le programme défini par le pays pour les introductions. Et à partir de là, le GTCV procède à la priorisation en fonction, disons, des revues, des documents, tout ce qu'il y a autour, disons, de ces introductions-là, pour pouvoir proposer ça au pays. Et en fonction de cela, je pense que on pense quand même d'ici 2 mois, ce travail-là va être fait, fini, et puis procéder, disons, à l'élaboration de tout ce qui est requête pour les introductions, pour la soumission à Gavi. Merci.
Thank you so much. And just to mention that the way we structure the training, we do understand it's not possible to bring all NITAG's members from each country. So the thinking is that those of you who are here, you'll carry with you the knowledge back to your country and rub it off to the colleagues that are not there. Because we also know that NITAG's membership sometimes keep on changing. Otherwise, if we rely entirely on the partners to do the training, and also we don't allow you to go and do the training, it's just going to be an endless cycle of you train, NITAG's membership change, another training. So please, as part of your operations, also find a mechanism through which those who are experienced, who have trained, how can you train new members? And that also lifts the workload for CD and others. And also online training is there. So we're going to have a model in the future of different ways of training NITAGs, a combination of in-person, a combination of online, and in-country support, sometime bilateral. So let's not just take training as 5-day in-person training. Let's be flexible because the vaccinology field is evolving and we also need to evolve with it. Okay. All right. Any other NITAG that want to comment? Nigeria, go for it.
Thank you very much. Dr. Dorothy Esangwedu from Nigeria. I will just approach this aspect of funding from a different perspective. When we talk about funding, we tend to talk about the cash being given. But we also need to know that there are hidden charges, there are hidden fees. For instance, governments that create enabling environment for you to function, give you hall to hold meetings and things like that. That's funding. That's giving some participation, which you may not be converting to cash, but it is money. And also, you must realize that most of members of NITAGs, they're not paid. We're not paid workers. And why do I bring this up? During COVID, for instance, some of us were working late into the night online. We were sleeping like 2 a.m., 3 a.m., trying to stay ahead of what is going on so that we can keep our governments up to date on the information that is coming out. We weren't paid. Let me put that in a better perspective for you. In Africa, for instance, you know most of us have problem with energy. And so some of us in our individual homes are providing our own providing electricity, power to run, and we run it for hours just for NITAG. We're not paid for it. Now, I'm sorry, I'm just trying to let you see the bigger perspective because I think most of the time, I'm mostly in the private sector, so don't mind me trying to let you see the bigger picture of cost. And so I need to let you know that individuals actually put money into this that you may not be seeing. I put that in more details for you. When you send transport to people, some people live very far away in another city and come into another city. And even within the city, for instance, some people are taking a long distance from their home to get to the airport. And in a city like Lagos that is jam-packed, it can take you hours. You're the one paying all that bill to get. And with the cost of fuel now, that is money. So I'm just trying to tell you those nitty-gritty that we don't talk about, which also goes into those who deliver vaccines in the community. They're giving pittance. A mom who puts a baby on her back and work long hours to drop oral polio in her, whatever you give her cannot pay for what she gets. So, and some of us, we supervise, we fall into gutters and, and hurt ourselves. You don't pay the bills. I'm sorry, I'm just trying to do something a little different so that you can see the bigger picture. Because usually organizations go and they give funds for something, but they're only funding an aspect that you see, that you write, and you don't see there's more cost that you don't see. So I just want to let you know what the little people do to the funding. Now to Nigeria, who has been funding us? Sorry about that. I was just trying to be funny. You know, the Nigeria we've been funded initially by CIVAC, who came for training. So we had our training, and I suppose since WAHO was sponsoring CIVAC, so you were also sponsoring Nigeria indirectly. And then the WHO has been a primary funder of NITAG in Nigeria, along with UNICEF. And now I'll talk about support. Then a whole lot of other support organizations that help us to get data and all that. Those are funding, even though it's in cash. So I'm just trying to say the total cost of what you actually do is usually not put together well enough so that we tick it off as this was given by whoever. Thank you. Over.
No, excellent, and I fully agree. I think most of the work that is done before even we come to this training is not visible. There is a lot, and I like the messaging for this year's immunization week, which is it's humanly possible, because that is only possible through the sacrifice that we all have to do. So I think we do all understand the meaning of what we do, and satisfaction to what we do is not in terms of money that we get, all in terms of the training we attend. It's the impact we have on the ground. So fully agree, but in terms of being able to quantify this funding, I think for us as NITAGs is important, because when you can measure something, you can be able to identify what are the areas that need strengthening, because then you can be able to have very targeted sort of support in those areas where they are lacking. But I do agree, comprehensive funding is not something that is coming from one funder or one entity. It is a collective of different sources of support and funding. We've got Morocco and Morocco and Senegal, and then we just gonna end because I see we've got 2 minutes left. Morocco, let's go, and then Senegal.
Merci beaucoup. Alors, si vous permettez, je vais rester dans le vif du sujet concernant la relation entre régions et comité national technique de vaccination. Quoique, après-demain, on aura le temps, lors de la présentation du NITAC de notre pays, je vais détailler encore plus. Mais ce qui est important à dire, c'est qu'il y a un appui très important de la région. D'ailleurs, suite à cet appui, nous avons pu avoir cette formation déjà sur l'outil ETR. Nous avons réalisé l'évaluation selon l'outil NMAT, et aussi nous avons bénéficié de plusieurs formations. Quoique la dernière activité qui concerne le jumelage, nous avons raté cet événement de création, ce point de jumelage entre comités techniques de pays au niveau de la région. Je remercie pleinement Gérald Soum, mais aussi Widiane pour le travail accompli au niveau de la région. Sans oublier que nous avons déjà bénéficié d'un appui. Nous étions membres de la CIVAC, par la suite du GNN, avec l'appui de Madame Luis, ENAF. Donc, on a pu assister à plusieurs réunions, soit en ligne, soit en présentiel. Ça nous a permis d'améliorer nos compétences en termes de gestion, quoique il reste encore des champs sur lesquels on a encore à travailler, notamment la mise en place de SOPs clairs sur le bon fonctionnement et les étapes de prise de décision. Il y a encore un travail à faire dans ce sens, et bien sûr nous sollicitons, nous demandons l'appui de tous les intervenants pour nous appuyer pour la mise en place d'un modèle spécifique, bien sûr selon les règles de l'OMS établies par l'OMS pour la mise en place de ces SOPs. Voilà, donc on est toujours à l'écoute de le travail continu de la région. D'ailleurs, il y a eu récemment une programmation d'un congrès de GNN au Maroc, mais malheureusement, ça a été reporté. Je pense que ça sera repositionné dans le prochain mois. Et ça sera une occasion pour former le maximum du membre du comité national et pour qu'il y ait cette mise à niveau de connaissances. Parce que même si on se trouve avec un petit nombre qui est formé et d'autres qui n'est pas formé, donc on trouve des difficultés à amener tout le monde à réfléchir, à faire établir les recommandations selon une ligne directrice commune. Je vous remercie. Sans oublier cette belle opportunité d'être ici présent et de profiter de cette belle assistance et surtout un encadrement riche et diversifié. Merci.
About the
Yeah, sure. I'll just I guess I'll comment briefly, very briefly on that. So I'm really glad you brought up twinning because that is a discussion I plan to have. I've started having with Tunisia and will make my way over as well. But we definitely providing support with SOPs is something we do regularly. At the moment, we're just finalizing SOPs with Somalia, for example, and we've done it with other countries. So all these suggestions are really great, and thanks for sharing. And we'll definitely talk more about them. Thanks.
Thanks, Wadian. Senegal, and then we close the session. Thanks.
Merci beaucoup. Je me présente, c'est Dr Abdoulaye Mangane. Je suis au niveau donc du PEV du Sénégal. Je voudrais juste revenir sur, en tout cas, ce que Dr Yves a dit par rapport donc à la requête qui est possible qu'on peut adresser à l'OAS. Je sais que, en tout cas, une évaluation a été faite par rapport au NITAC du Sénégal pour sa maturité et il est ressorti beaucoup de recommandations. Et ces recommandations, je pense, peuvent être déclinées donc dans un plan d'action. Juste savoir par rapport donc au financement de ce plan d'action, quelles sont les procédures qui existent? Est-ce qu'il y a un manuel pour permettre en tout cas au pays de pouvoir adresser une requête en bonne uniforme? Si ça existe, merci de partager cela.
Ok, merci beaucoup au Sénégal. Je savais que j'allais demander la parole quand même pour préciser avant de partir. D'abord, l'OAS est financé sur prélèvement communautaire à hauteur de 70%, 60 à 70%. C'est-à-dire que c'est les cotisations des pays qui financent l'OAS à hauteur de 60 à 70%. Et le reste, 30-40%, c'est les partenaires qui nous accompagnent. Alors, dans chaque pays, l'OAS dispose d'un point focal logé au niveau du cabinet du ministre. Bon, le Sénégal vient juste de changer, mais c'est le conseil technique numéro 1 du ministère de la Santé. Et je crois que pour la Guinée, c'est le conseil technique principal. Voilà. Donc, c'est à travers ces points focaux OAS que la requête est formulée, adressée au directeur général de l'OAS, pas à Dr Mungbo. Moi, je suis un ouvrier qualifié. Adressé au directeur général de l'OAS avec une lettre de couverture signée par le ministre. Et tout ça est remis au point focal qui achemine cela au secrétariat exécutif du DG de l'OAS. Et quand ça va venir, certainement cela me sera affecté pour demander mon avis. Mais comme entre-temps, on a eu à échanger, et j'espère que quand je vais rentrer, mon bureau, ma table sera inondée de requêtes. Pour pouvoir essayer d'utiliser l'argent que vous avez mis à notre disposition. Est-ce que c'est clair, docteur?
Je pense que le cheminement est très clair, hein, on a bien compris.
Non, le format, vous développez les thèmes de référence, les objectifs et puis les résultats attendus. Et puis c'est tout ça là qui va être analysé pour voir la pertinence. Et maintenant, si c'est pour le rapportage, s'il y a un canevas ou un manuel, bon, le rapportage, c'est vous suivez quand même le format de la requête pour faire le rapport, plus maintenant un rapport financier. Voilà. C'est bon? Oui.
Secrétariat, il y a un modèle de plan d'action qu'on faisait et qu'on adressait à l'OAS. Donc, vous pouvez fouiller ou demander au directeur du PEV. Je pense qu'il doit avoir ça.
All right, thank you so much. Let's give a round of applause to Wedian, Yves, and Siri. Thank you so much. Right, now we're going to hand over to Salim. We've come to the end of the day. You've survived day one. Well done. I can see you all still looking very energetic, which is great. So I'm going to hand over to Salim. Remember, in the morning when I started, I said feedback is so important. We definitely need it because next year we're gonna want to improve on what we are doing today, right? So kindly give feedback to us. Salim, are you Salim? Birthday girl is Salim. Over to you.
Hmm?
The usual scan.
Hi, hello again, everyone. I hope we've had a great day. So everyone needs to use their phone to scan anyway, wherever is closer to you, so we can do the daily evaluations for the day. Thank you so much for your comments, discussions, and to all the speakers that we're presenting today. Yeah, please just scan the code. And if you're having any problems, the real Salim is right there to assist. Just raise your hand. Okay. We have about 38 people logged in now. So it says no vote. No, we haven't started yet. Yeah. So just make sure you are onto the platform.
Happy birthday to you. Happy birthday to you. Happy birthday to you.
Thank you. I'll have this later. Okay, just another minute for everyone to log on. We have about 56 people on now. Okay, so we'll start, but if you haven't logged in, just continue trying. Oh, so which country are you from? And then there is a French version there and Portuguese version that I won't even try. Maybe let me try the French because I did a beginner French lesson. De quel pas venez-vous? Did I get it right? Hmm? So you just write the wait, Salim? It's not showing. Salim, it's not showing. Where's Salim? They're saying they can't see the question. Oh, it says, see, it says locked out. Would that be why? Okay, can you try again? It's okay? Okay, okay. So please just write the, yeah, there we go. Tunisia, Mauritius. Yeah? Okay. Yeah, that's.
You're good? Oh, the code?
The code again. Okay, just take over. You'll take over.
Yeah, sorry. Are we good? Can we move on? Next question? Next question? Which of these would be the hardest to live without? Choose. Can you go without chocolate, music, your favorite drink, whatever that may be, your phone, or TV? You can choose one. What is the hardest to live without? Yes. What can you not live without? You want all the time. Good. Okay, I'm gonna move on. Just to keep time. Okay, so now first question. How useful was the information presented in this session? This session being Introduction to Niche and its core services. Think back to the morning. And then your options is mostly what I learned is important to me and I'll apply it. Some of it is useful to my work and some not. And what I learned is interesting, but I don't think I'll apply much of it. Keep in mind what we're asking you about is niche and its core services, what we provide, and everything like that. If you think back to the presentation. Most people answered? We can go ahead? Cool. Okay, next question. How useful was the information presented in this session? And this was the South African NITAG, their presentation. Did you find what they presented useful? Are you going to apply it? Okay, I'm going to move on. I'm going to move on to the next question. How useful was the information presented in the session development and uses of the niche library guides? Okay, I'm going to move on to the next question. Now think back to the session, global, regional, and national sources of evidence relevant to NITAG's work. Do you remember that session? How did you find it? Okay, I'm going to go on to the next question. This now is asking about the session WHO Afro-regional immunization policies. How did we find that session? Okay, we're going to move on now to the next question. How useful was the information presented in this session? This is Cameroon and Cabo Verde, the NITAG presentations that they gave us, presenting on their work. Okay, I'm going to move on to the next question. It's just interest of time. The Gambia NITAG presentation, how useful did we find that? Okay, next question. Now the session on using grade for NITAG decision making. Okay, moving on to the next question now. So the experience from WAHO, establishing and strengthening NITAGs, how was this? There's not that many left, guys, okay? Just bear with me. Few more minutes. Next one, the session NITAG support in Afro, the facilitated discussion. So this is the last few ones. That was kind of mixed. Okay, I'm going to move on to the next one. This is now the facilitated discussion in EMRO. It was again mixed and whatnot, so it's fine. Okay, I'm going to move on to the next question. We just have two more. So list anything new that is applicable from these sessions. So out of all the sessions today that we learned and everything, what stuck with you the most and that you'll apply going forward? Okay, grades quite. Are people copying each other or is that actual thing? Grade is quite important, yeah. Okay, a lot of people are liking grade and the lib guides. HPV. Okay, everyone at least put one thing down. Let's go to the next question. And enter a word or phrase to describe how you feel about the training so far. How are you feeling? Excited? Ooh, okay. Okay. How are you feeling about the training so far? Are we excited? Are we interested? Are we enthusiastic? Oh, someone said that. Okay, everyone. You can continue putting in things there. There's just some announcements to make. The first one is anyone who came and parked at the hotel, you do have to get your tickets validated unless you want to pay money. So Fernando is just outside in the lobby area. Just give him your ticket. He'll validate it for you. You'll be good. The second thing in terms of housekeeping is how do I put this? Timeliness. So timeliness, right? The first day, it's fine. We're still teasing out the problems and everything. You're allowed to be a little late here and there. Tomorrow, we're going to fresh start, nice and early. Sorry. Okay, nice and early, on time. So remember, registration begins at 7:15. Come sign your name, make sure everything is good and whatnot. We're going to start promptly on time, 8:15. And this is information that you don't want to be missing. We want to all learn and everything. So the first night tag here, Ben, did you explain the scores and everything? They know how it works? Yes, being on time is 5 marks. So the first night tag, your whole group needs to be here on time. You can earn 5 points to the first one. However, the one who's lost with all their night tag members here lose 5 points. That's it. We good? Okay. Hey, it's only the first and the last one. That's it. Okay. Other than that, everyone, thank you. Enjoy.
Yeah. Yeah. Yeah, but there was bias. There was still bias. Exactly. No. Just be fair. Point at people that they raise their hands. Just be fair. Not to give us points, but also give us a chance to say something. Don't say we're not here. Let us see, coach. Open the mic and speak.